Trustee, Mr. M.G. Gopinath, who has stood with us in all tough times and has been the most instrumental person in developing this hospital with the state-of-art technology that we have today. Welcome you, sir. And Group Captain KVM Asraf, our General Manager, whom we look upon for all our day-to-day problems, who has sorted out all our problems and ensures a smooth sailing of our hospital. Welcome you, sir, for this inaugural function. And Professor Ramachandra Bhatt, former Professor of Ophthalmology at Medical College Hospital, Calicut, has been associated with us for a long time and he has been mentoring almost all our PGs. Welcome you, sir, for this function. Dr. Laila Mohan, Director, Comtrust Academy of Research and Senior Pediatric Ophthalmology Consultant at our hospital, who has been the main backbone of our hospital for a long time, and she has molded most of our consultants as well as PGs in their career. Welcome you, madam, to bless this occasion. Dr. Anju Chandran, the Orbit and Oculoplasty consultant, who is the main brain behind this CME. Welcome you, Anju, for this conference. And we have a large array of speakers who are the specialists in their own fields to enlighten all the delegates in Orbit and Oculoplasty topics. Most of the speakers will be introduced in detail in their respective sessions. I welcome you all to this conference. And last not the least, all the delegates who have come to attend this conference on a Sunday. Welcome you all for this conference, and I wish this conference all the best. Thank you.
Thank you, sir. For the presidential address, I invite Dr. Arup Chakrabarti, President of KSOS.
Good morning, friends. I am Arup Chakrabarti, President of KSOS, representing Kerala Society of Ophthalmic Surgeons in this program organized by Comtrust Eye Hospital. I would like to thank the organizers for having a tie-up with KSOS for this academic event and asking me to inaugurate this CME program, this webinar, in the format of a webinar. As we all know, Comtrust Hospital has been at the forefront of eye care. It has been an iconic institute in South India, doing great work for last so many decades. And it also plays a very important role in the dissemination of knowledge among its peers. And I think this is the 24th meeting that I'm inaugurating as a president, KSOS involvement, and third meeting for Comtrust Eye Hospital. This particular meeting, I think, is basically on oculoplasty. And when I saw the program, the topics were really wonderful, very useful topics. And what really caught my eye was the faculty list. There are faculties from all parts of the country, virtual who's who in the field of oculoplasty. So I'm sure this is going to be a grand program. And thank you, Dr. Anju, for coordinating with me. And Dr. Anju has taken a lot of effort in making sure that the program goes on in time. The brochures have come out well in time, well in advance, and we have tried to disseminate the information with the help of KSOS for quite a couple of days, before the program started. So I think we are on the right track. Before I conclude, I would also like to inform you that the KSOS has been going full throttle in all its wings. Dr. Gopal has been conducting the PG classroom program every Wednesday evening in a very meticulous manner. Dr. Srini has already, as you know, this particular meeting is under the scientific committee CME module. He has already collected, I think, more than 56 instruction courses for the upcoming Drishti, and I encourage all of you to submit papers, videos, and posters, and the website is open right now. And last but not the least, that on-demand portal is active. I encourage you to visit KSOS website, go to the on-demand, where you find that all the scientific contents or presentations made in 2021 conference so beautifully prepared by Dr. Rajiv Sukumaran, the past chairman scientific committee. Everything is available on the website. In fact, the scientific committee CME modules, the PG classroom, these are also incorporated in the same website. So it is basically going to be very, very useful to all of you. There will be a formal inauguration in a couple of hours' time for the on-demand portal of the KSA website. With these words, I wish this CME, this webinar, all the best, and I'm sure all of us are going to learn and benefit immensely from this webinar. Thank you very much.
Thank you, sir. For lighting the lamp, I invite all the dignitaries on the dais.
Vakratunda Mahakaya Suryakoti Samaprabha Nirvignam Kuru Me Deva Sarvakaryeshu Sarvada Vakratunda Mahakaya Suryakoti Samaprabha Nirvignam Kuru Me Deva Sarvakaryeshu Sarvada.
For the inaugural speech, I warmly welcome Dr. K. Karthikeya Verma, Chairman of Comtrust Eye Hospital.
The Chairman of Comtrust Hospital, Dr. K.K. Verma, is not available here today to address you personally. However, he sends an inspiring message to be read out to you. I shall read it out presently. Dear friends, I consider it an exceptional honor to address you at the inauguration of the annual CME of Comtrust Hospital. First of all, here at Comtrust Hospital, we are thrilled to be able to host such a prestigious event. We are looking forward to a great avalanche of knowledge from great stalwarts in the subject. Secondly, giving an opportunity to showcase the strengths and opportunities available in our state in the field of oculoplasty is in itself a welcome goal. Finally, I do hope that such an exposition will stimulate all to sharpen their skills and execute work which ultimately will reflect honor upon ourselves. At this juncture, although such an exhortation is unnecessary, I would strongly recommend futuristic research in this field. We have more than enough talent in our midst that we should be pathfinders rather than followers. As some of you probably know, I have more than a mere platonic relationship with ophthalmology, and I have always cherished my attachment with the subject and ophthalmologists. Therefore, it gives me immense pleasure to declare the CME open, and I hope the knowledge shared will go a long way to remove darkness and cobwebs in our understanding of the subject, as well as give a big boost to the practice of the specialty. I greet you well, Dr. K.K. Verma.
Thank you, sir. Next, we will have the Fellowship Completion Certificate distribution. I warmly welcome Dr. K.R. Bhatt, Senior Faculty at Comtrust Eye Hospital. I also invite Dr. Prakash V.S., Chief of Vitreoretinal Services at Comtrust, to distribute the certificates. First, I welcome Dr. Radish Raj, who has completed long-term fellowship in vitreoretinal surgery and has joined as a consultant in the vitreoretinal department. Next, I invite Dr. Prayagi, who has completed long-term fellowship in vitreoretinal surgery. Next, I invite Dr. Shariga, who has completed short-term fellowship in medical retina. Now I invite Dr. Bindu S. Ajit, Chief of Glaucoma Services at Comtrust, to grant the certificate to Dr. Arino John, who has completed long-term fellowship in glaucoma. To felicitate the ceremony, I invite Dr. Padmaja Krishnan, President of KOS.
Good morning, everybody. It's always a pleasure to come back to Comtrust. And as Prakash said, Comtrust has always been in the forefront of academics. It started with their CMEs even before the DNB course started. And now it's so heartening to see fellowships in the various subspecialties being conducted by Comtrust. There was a time when our aim was actually to make people see. Today, we want them not only see, but we want us who see them to make them look better. So oculoplastics, quite apart from treating disease, also helps. The face is ultimately the most important, the most attractive part of a person, and what gives beauty to the face are the eyes. So oculoplasty aims to beautify these, to bring the eyes back to looking like they are, for other people to see them as well as to take care of the diseases that the person might have. I'm very pleased to see the array of speakers, all eminent in their own field, and I look forward to hearing from them and their pearls of wisdom for all of us. I felicitate this occasion, and I'm sure that this CME will be a grand success like all the ones that have gone before it. Thank you.
Thank you, Madam. Next, to felicitate, I invite Mr. M.G. Gobinathan, Managing Trustee of Comtrust Eye Hospital.
And members of the fraternity, I am really happy to be participating in this opening ceremony of our Comtrust CME. I wish the CME all the very best on behalf of the charitable trust and myself. I remember when I joined as a trustee way back in 2005, there were hardly any other players in the field other than Calicut Medical College and Comtrust in the field of ophthalmology. Now, we have dime a dozen clinics and hospitals. Calicut has become a hub of ophthalmic treatment area. As it's always a merit to be plenty that will definitely increase the quality of the treatment to be imparted to the patients. I wish this CME all the very best, and thank you very much.
Thank you, sir. Next, to felicitate, I invite Group Captain KVM Ashraf, General Manager of Administration of Comtrust.
Good morning, ladies and gentlemen. First of all, I congratulate our academic team for arranging an array of stalwarts for the CME. I am sure each and everyone will go back with a lot of provocated thoughts. What we are doing, what we can do, and what will be the future of these specialities in ophthalmology. I wish everybody a great participation, and Comtrust for the future CMEs. We have been conducting CMEs every year, and I'm very proud to say that it is one of the best feather in our cap. I'm sure this Dr. Prakashan team will continue with this zeal and effort in future. Thank you. Jai Hind.
Thank you, sir. Next, I invite Dr. Leila Mohan, Academy Director and Chief of Pediatric Ophthalmology and Strabismus, to felicitate the ceremony.
Respected President Dr. Arup Chakrabarti, other dignitaries on the dais, and my dear friends, I'm so happy to see that as we near the silver jubilee of our hospital, we have specialized into, we have all the subspecialties. The last golden feather added is Oculoplasty, and we all know that in Malabar we didn't have a proper customized prosthetic department and ocularist. We have a regular ocularist coming to our Oculoplasty department, and I'm so happy that it is working in full-fledged. The Oculoplasty department has taken up so well during this very short time, and I congratulate Dr. Anju for that. And I also congratulate and thank the administration and trustees for lending all support for our academic activities and progress in the field of ophthalmology. And I wish this CME all success. Thank you.
Thank you, Madam. For the vote of thanks, I welcome the Organizing Secretary, Dr. Anju Chandran, Consultant Oculoplastic Surgeon at Comtrust Eye Hospital.
Honorable guests who have gathered here and those who have joined us virtually, and dear delegates, good morning to all of you. On behalf of Comtrust Eye Hospital, I would first and foremost like to thank all the distinguished speakers who have made this academic feast possible. I have been left disarmed with the grace and spontaneity with which they have accepted my humble invitation. Being stalwarts in their respective fields, they have put up with my constant pestering with much graciousness. Thank you to them. A special thanks to our chairman, Dr. Karthikeyan Verma sir, for his warm wishes. I express my deep gratitude to Dr. Arup Chakrabarti, President of KSOS, for taking out time from his busy schedule and joining us today. I deeply acknowledge Dr. Padmaja Madam, who is representing Kozhikode Ophthalmic Society, and by joining us here to adding to the sheen of the program. My special thanks to our Managing Trustee, Mr. M.G. Gopinathan sir, and our GM, Group Captain, KVM Ashraf sir, for their great support. Special thanks to Dr. Bhatt sir for his constant pearls of wisdom. I cannot express my gratitude enough to Dr. Laila Madam and Prakash sir for entrusting me with this responsibility of being an organizing secretary, and thank you for your constant guidance and encouragement. A special thank you to all my dear colleagues and residents for your relentless support. A special mention to Dr. Devaki and her heavenly voice. Thank you, Dr. Bindu Madam, for showering her blessings on the graduating fellows. There are a lot of people who have been working in the background who are ensuring the seamless execution of the program today. Our IT team, our audiovisual team, our supporting ground staff. Thank you to one and all of you. On a personal note, I had no clue on what lay in store for me when I took this upon, and along the way I have learned to collaborate, cooperate and delegate. I thank each and every one of you for that. You have given us a precious Sunday morning, and I hope we deliver the best. Thank you.
Thank you, Madam.
Yeah, good morning, Akshay. Hi.
Good morning. Hi.
Good morning, everyone. So we have arranged 5 sessions today, covering a variety of topics and with the best faculty lined up. During the session, each talk will be for around 10 minutes, followed by a question and answer session. Questions can be put up in the chat box. We'll begin with the first session, blepharon. I invite the discussant, Dr. Laila Mohan, Chief of Pediatric Ophthalmology and Director of Academy at Comtrust. I also invite Dr. Priya Simon, Consultant Ophthalmologist at Comtrust. Over to you, Madam.
Thank you, Dr. Nafia. Can you hear me? Yes. So, I feel very happy to kick off this exciting CME on a very important topic with eminent faculty from all over India. And to start off, we have the first session with our very familiar eminent faculty, and on a very important topic, the lid, which, as Padmaja Madam has already pointed out, the eyes, of course, gives the beautifying organ of the body, and so lid, of course, comes first. And so we have this first session with blepharon, and the first speaker is Dr. Akshay Gopinathan Nair. He did his residency from Shankar Nethralaya, Chennai, and underwent fellowship training program in oculoplastic surgery Ocular Oncology and Aesthetics at LV Prasad Eye Institute, Hyderabad, and New York Eye and Ear Infirmary of Mount Sinai, USA. And currently, he is the consultant of ophthalmic and plastic surgery, consultant in ophthalmic plastic surgery and ocular oncology at Advanced Eye Hospital and Institute at Mumbai and Aditya Jyoti Eye Hospital, Mumbai. Academically, he serves as a reviewer for over 30 index journals with over 120 plus peer-reviewed publications. He has received achievement awards from American Academy and Asia Pacific Academy of Ophthalmology. His special focus in training residents, especially skill development for writing papers and critiquing scientific literature and assessing medical evidence, all of which are aimed at inculcating the practice of evidence-based medicine. So I invite Dr. Akshay G. Nair to talk on the spectrum of ptosis surgery, a video-based presentation. Over to Dr. Akshay.
Thank you, ma'am. I hope I'm audible.
Yes.
Yeah. Thank you, Dr. Anju, and to Comtrust Hospital for this invitation. It's always good to speak at a Kerala CME, although virtually this time. So I'll be talking on ptosis and the spectrum of surgical options that we have for the treatment of ptosis. Before we get into the surgical management, it's extremely important for us to evaluate a patient of ptosis comprehensively, because it's the evaluation that is going to tell us what is the ideal surgical correction for a particular patient with ptosis. The history, of course, is the most important thing. The onset of history, or the onset of ptosis, in terms of whether it is congenital or whether it is acquired, is important to differentiate. Another crucial factor that we need to pick up on is the progression and if there is any variation. Diurnal variation especially is a red flag for myasthenia gravis, which not always is treated surgically, but is rather treated medically. Trauma is another thing that we need to find out, and we should not jump the gun and immediately operate patients with traumatic ptosis. This is a 25-year-old girl who had a history of blunt trauma with a stick that her child, which she was playing with, hit her over the eyelid. In February, she had a near total ptosis, which improved by April, and by June, she had near normal palpebral fissure height. So traumatic ptosis, the rule is to always wait for 6 months by the calendar. Always in a patient of ptosis, we should not overlook the basics. Assess the visual acuity, the best corrected visual acuity with cycloplegic refraction in children. Always ensure that you've checked the pressures and the fundus before diving into the measurements. Visual acuity is extremely important because children with congenital ptosis are extremely prone to developing amblyopia as a result of the ptosis, especially in severe ptosis, if it is obscuring the visual axis. The measurements that we look for are the palpebral fissure height, the MRD1 and MRD2. In certain examinations in your vivas, an examiner may ask about MRD3, but clinically that has very little significance. Another thing that you should also look for now when we talk about palpebral fissure height is a clinical clue that can help you figure out whether it is congenital ptosis or acquired ptosis. Now look at the picture of the gentleman on the left. There is an obvious left eye ptosis with frontalis overaction. Now look at the palpebral fissure height when the patient looks down. The palpebral fissure height increases compared to the normal eye in down gaze. Compare that to the lady on the right. The palpebral fissure height decreases compared to the normal eye in down gaze. This clearly indicates that the patient on the left, the gentleman, has congenital ptosis, which means a tight, fibrotic, fat infiltrated ptosis, which levator, which does not go down as compared to a loose dehisced aponeurotic levator, which is going down further than normal on the right side. Marcus gun jaw winking phenomenon is another thing that we need to assess. Ask the patient or the child to open their mouth and not just open up and down, but also to move the eye jaw sideways. Sideways movement, especially the medial and the lateral pterygoid muscles, can also have a synkinetic connection with the eyelid. In your examinations, it may be asked what are the grades of Marcus-Gunn jaw winking phenomenon. A mild Marcus-Gunn phenomenon is when the eyelid or the ptotic eyelid gets lifted but is not corrected to the size of the contralateral normal eyelid. In a moderate degree, the Marcus-Gunn jaw winking phenomenon, the eyelid goes up to the top of the limbus, which means it gets corrected to match the contralateral normal eyelid. And in severe Marcus-Gunn jaw winking phenomenon, it goes beyond the limbus, which means the eyelid goes higher than the normal contralateral eyelid. Marcus-Gunn jaw winking is extremely important because in patients with ptosis with Marcus-Gunn, you need to be very clear what is it that you want to treat, whether it is the ptosis or the Marcus-Gunn, or if the patient desires that both be abolished or both be treated, then we have to customize the treatment accordingly. Bell's phenomenon is another thing that needs to be assessed. Bell's phenomenon is the upward and outward movement of the eyeball on forced eyelid closure. You need to make sure that Bell's phenomenon is good, or else you also need to counsel the patients for exposure keratopathy, and especially in cases of lag of thalamus, which may occur after ptosis correction in congenital ptosis patients. Absolutely the single most important measurement which practically decides every future surgery in ptosis is your levator action. How do you do that? It's extremely important that you ask the patient to look down, gently place a finger on the eyebrow. You do not want to apply too much pressure that it causes pain. Gently block the frontalis. When the patient is looking down, you align your ruler to mark your zero at the level of the eyelid, and then ask the patient to look upwards. The maximum excursion of the eyelid will give you the measurement of the levator in millimeters, levator action in millimeters, which of course is then graded as mild, moderate, severe, as poor, fair, good, or normal. And finally, eyes test and fatigability. These are absolutely important. I'll quickly run a video to demonstrate how an eyes test needs to be done. So the most important thing before starting an eyes test is to document the ptosis that the patient has here. You can clearly see the right eye has moderate ptosis, the left eye has severe ptosis. The next step is to place ice packs on both eyes, even if you're assessing one eye. And you must keep this ice pack for a minimum or maximum of 2 minutes, no longer than 2 minutes. You may even take off the ice packs for a few seconds to give the patient a respite and then place them back. The most ideal technique to assess the ice test is to put ice cubes in a latex or a rubber glove and then place it on the eyelids. And at 2 minutes when you take it off, also it's important to know that if you want checking ice test for ocular motility, you may keep it for up to 5 minutes. But once you take off the ice packs, again, photograph or document, and then you can clearly compare the right eye, which was moderate ptosis, now has improved completely. So has the left eye, which had severe ptosis. So 3 millimeter palpebral fissure height in the left eye has now improved to 8 millimeters. So this is a positive eyes test. When do you call it a positive eyes test? When you have at least 2 millimeters of correction after 2 minutes of placing the ice pack. Once you've documented this, this has an extremely high sensitivity for myasthenia gravis. The other test that we need to do is the fatigability test. Now, in the fatigability test, you ask the patient to look upwards and continue a sustained up gaze for at least 30 seconds. Over time, in front of you, you would see that the eyelid is unable to maintain a sustained up gaze and it starts drooping down. This is because of the fatigue that sets in as a result of the lack of acetylcholine to act on the neuromuscular junction end plates. And as a result, the eyelid completely shuts down with the patient unable to maintain this. This is a clear positive sign or a fatigability test. Again, an extremely high sensitivity for myasthenia. So now that we've gone through your examination and understood levator, what levator action is when we come to decide what sort of surgery is needed. So the amount of ptosis and the levator action are the two parameters that are needed to figure out what needs to be done. So if there's mild ptosis, my go-to surgery is usually a muellerectomy or a conjunctival Mueller's muscle resection, or a levator resection, for which I prefer an anterior approach for levator resection. Levator resection can also be done in mild, moderate, or severe ptosis. So we'll first come to a conjunctival muellerectomy. For this, a patient needs to have a positive phenylephrine test. So the ideal patient would be one who has mild ptosis with a good levator action and a positive phenylephrine test. In this case, we can plan for a conjunctival Mueller's muscle resection. So the first thing that we do is give a frontal nerve block. This is a sensory block for the upper eyelid. And then we take traction sutures to stretch the eyelid out. Then the next step is to place a Demar retractor to flip or evert the eyelid. Now, once you've done this, the next step is to mark the lower edge of the tarsus. Now, this will be your marking point to measure where the traction sutures would be placed. Now, in this case, there was mild ptosis or 2 millimeters of ptosis. So the amount of conjunctival to be resected, or the Mueller's to be resected, is 8 millimeters. 1 millimeter of ptosis needs to be corrected with 4 millimeters of conjunctival Mueller's muscle resection. So at 4 millimeters, we've marked this point. Why 4? Because this mark point serves as the midpoint for the amount of conjunctival Mueller's to be resected. Thereby, now pulling it up, you have 4 millimeters on either side. You can either use a Putterman's clamp or a ptosis clamp, or if that is not available, 2 curved artery forceps can work very well in clamping the tissue that needs to be excised. Once this is done, you pass a Prolene suture, which is first a knot is taken exteriorly, and then the suture is internalized through the skin coming out of the conjunctiva, and in a crisscross fashion, the suture is passed just underneath the clamp or the forceps in a serpentine fashion, front to back and back in the front again. Once you've reached the entire length of the clamp, the suture is then again exteriorized through the skin outside. Now here we are passing the last loop, and then the suture would then be taken through the conjunctiva and then back out through the skin. Once it comes out through the skin, the next step is excision of the clamped tissue. For this, you take 11 number or a 15 number blade and hugging the metal such that your blade is constantly in contact with the metal. You excise that amount of tissue that is within the clamp. The suture that you've taken and exteriorized in this is then simply tied. This opposes the cut conjunctival ends on the inner surface of the eyelid. This suture is taken off at 1 week and is an extremely simple and a predictable surgery that gives you good results. It has a short learning curve, and then here the traction sutures are taken off. A BCL can be placed because the sutures may rub against the cornea, which again is taken off at 1 week. Now, if you see the patient at 1 month after surgery, you can see that the ptosis has corrected well without a scar and maintaining a good lid crease. The next surgery that I'll talk about is a levator resection or a levator reattachment surgery. In a resection surgery, especially for congenital ptosis, you cut and reattach. In a reattachment surgery for aponeurotic dehisced levator muscles, you reattach it to the tarsus. In congenital ptosis, the 2 normograms that are used are the Beard and the Burke's rule. They depend on the amount of levator to be resected or the ideal position to leave the eyelid at the end of surgery. In most cases, we prefer to have an intraoperative assessment which decides how much of the levator needs to be resected and where do we reattach the levator. Again, I'll quickly run through with a surgical video. This is a patient with right-sided mild ptosis, left-sided mild to moderate ptosis. The most important step is to mark a lid crease, and then I like to mark the mid-pupillary point, which serves as a good guideline for passing your cardinal suture. The next step is to infiltrate the upper eyelid, which gives you good local anesthesia. The skin lid crease incision is made with a radiofrequency monopolar handpiece or with a blade. Gentle dissection is done through the orbicularis to expose the tarsus. You can also use a Westcott scissor to gently dissect the orbicularis, the pretarsal orbicularis, off of the tarsus. So now you're able to visualize the white tough structure, which is the tarsus of the upper eyelid. So that's the skin, that's the pretarsal orbicularis here, and that is the tarsal plate, the anterior surface of the tarsus. And the upper edge of the wound, of course, has the orbicularis and the skin. Now here you'd ask an assistant to hold the lower edge of the upper wound and now open up the orbital septum. These small septae-like structures is what is the orbital septum. And as you open up the orbital septum, you will see fat bulging out. This is a good sign because anatomically it tells you that you are above the levator, because the name for this fat pad is itself the pre-aponeurotic fat pad. So here you can see the fat bulging out, and that white structure that is seen below is the levator aponeurosis. So you can confirm by identifying the levator aponeurosis. Conversely, now you can ask the patient to look up while holding the aponeurosis and feel the tug, or you can stretch it out and ask the patient to look up and see the muscle as it physically moves up when the patient tries to open the eye. So now that you've identified the levator, in this case, it's a reattachment. So you pass a cardinal suture, which in this case is 6-O-proline, then take a partial thickness bite through the tarsus. Always check that you've not gone full thickness, and then pass it back up again through the levator muscle. Now, once you've done this, you try to place a slip knot, which is a temporary knot, which can be immediately undone if required. So once you place a slip knot, you get an approximate idea of the correction of the eyelid. And then you ask the patient to completely open the eye. While doing so, I like to turn off the overhead lights, because once you turn off the lights, the patient no longer has photophobia and can freely open their eye. Now you can see that this is slightly above the limbus. This is where I like to leave it, because remember, we've anesthetized the orbicularis. The orbicularis is a protractor or a muscle that closes the eyelid. So the eyelid height will come down. Once the middle suture is taken, the lateral and the medial sutures are taken. Remember here, the needle passes slightly obliquely through the tarsus. It's the central suture that gives the height correction. The medial and the lateral sutures only give or help in modifying the contour of the eyelid. Remember to take a medial bite, because in many cases you may have a medial droop if it is left uncorrected. Again, partial thickness to the tarsus, and then you come back in and pass it through the levator edge. Now, once all these three sutures are taken, you can again do slip knots, correct based on the assessment on table, or if you're confident enough, you can go ahead and fasten these sutures as we are seeing here now. Once these three sutures are fastened, your eyelid height is corrected along with a good contour. And the next step is to trim the levator that is redundant. This is the third proline suture being passed. You need to be careful that you don't hitch the lacrimal gland while passing the lateral suture. Once this is done, the next step is to trim off any redundant levator that may be present. Again, check the intraoperative height correction. You can see that as the surgery has progressed, the eyelid height has already corrected itself. This is 1 millimeter under the limbus, exactly where we would want the eyelid to be. So this is trimming off the redundant levator muscle. And now we take lid crease deepening sutures with an absorbable suture, which in this case is 6-O vicryl, pass it through the stump of the levator and then through the pretarsal orbicularis. By tightening it, you would see that the edge of the wound rolls inwards, essentially deepening the lid crease. Once this is done, the skin is then sutured with a non-absorbable material like 6-O-proline in a continuous manner. Here you can see that the wound has been closed. Apply a dollop of ointment. I don't patch mitosis patients. At 1 month, you can see that the eyelid height has been corrected with symmetrical height and contour. Levator resection is an extremely predictable surgery and can give good gratifying results in acquired as well as congenital ptosis, as you can see here. And finally, the last surgery that I'm going to talk about and show is a tarsofrontalis sling. In this case, you can see severe ptosis in this lady, but she's got severe Marcus gun phenomenon as well. So in this case, the options that we have for severe ptosis with poor levator function is a right levator resection. But in this case, you would still have the persistent jaw winking. A right tarsofrontalis sling would correct the ptosis, but not the jaw winking. A bilateral levator excision with tarsofrontalis sling would mean that we would end up operating on the normal eyelid, of course, but the patient was not amenable to this. So our surgery of choice was to excise the levator and put a sling in the ptotic eyelid. The cons of the surgery are that there is lid's asymmetry in down gaze, but it corrects the ptosis as well as abolishes the Marcus gun. So in this case, what we're doing is a Fox pentagon, where a silicone sling is passed from the forehead, engaging the frontalis muscle, anchored onto the tarsus, and the frontalis muscle then lifts the eyelid. And that's why it's called a tarsofrontalis sling. The first step is infiltration of the areas where we would be making the incision. A frontal block is also given, and the lid crease area is infiltrated with local anesthetic. A lid crease incision is made. This is different from a closed ptosis or a closed sling surgery. This is what is called an open sky sling surgery. A lid crease incision is made and some amount of skin is also excised, like a mini blepharoplasty. Once this is done, we are doing it because we can identify the levator and excise it. As we saw in the previous surgery, identifying the tarsal plate is important. And once the tarsal plate is identified, we go upward and identify the levator muscle, dissect it out completely, and then it has to be excised. A lot of authors and surgeons insist that the entire levator has to be excised right up to and even beyond the Whitnall's ligament. It depends on surgeon to surgeon. I usually don't go that high up, and about 2 centimeters are enough. The stab incisions for the frontalis sling are made here. This is 2 centimeters above the mid-pupillary line and just above the brow line on the medial and the lateral side. An 18-gauge needle with a pre-swaged silicone rod is taken. This is commercially available, passed from the forehead site into the lateral wound, and then through the fat pad and the septum, outside through the wound, externalized. A small loop is placed outside, and then it is passed back up through the medial forehead wound, and then again with anchoring of the frontalis muscle, passed back up through the central wound. Now the loop of silicone that is left outside needs to be anchored to the tarsal plate. Now here it is being done with a non-absorbable suture like 6-0 Vicryl, such that it anchors it there, and as it dissolves, it causes scarring and fibrosis, which further helps to hold the sling down in place. You can also use a non-absorbable material like Proline. 2 such anchoring points are sufficient to lift the eyelid. I'm running a little late, short on time, so I'll skip through. Once this is done, you adjust and tighten the sling based on where you want to leave the lid. The next thing is lid crease deepening sutures, which is taken through the septum and then passed through the pretarsal orbicularis. And finally, the wounds are closed on the forehead, and the lid crease is also then closed with 6-0 Proline in a continuous fashion. Now you can see that in down gaze, there is lag of thalamus. Patient is able to close the eye, but more importantly, the ptosis in primary position is corrected, and also the Marcus gun jaw winking is abolished. In special scenarios like CPEO, you can perform a sling surgery, but you may want to undercorrect a little because the Bell's phenomenon is very poor for these patients. So to summarize, assessment is crucial because assessment of ptosis is going to lead you to the ideal surgical plan for every patient. Counseling preoperative is important because patients need to know about postoperative lag of thalamus and also the possibility of resurgery. Your levator function remains the most crucial measurement that tells you what surgery needs to be done. At the end of the day, one size doesn't fit all, and you have to offer customized surgical solutions to your patients for ptosis. Thank you for your attention, and I'll be happy to take any questions if there are. Ma'am, I can't hear you. I think you're on mute.
Okay. Thank you so much, Dr. Akshay, for those wonderful videos with very explanatory notes, very useful information. And I have a few questions. Is it okay if you can sit through the first session and take up the questions at the end, Dr. Akshay?
Ma'am, I actually am leaving in a bit. I have a flight. Okay. That is why I'll be, if there are any questions, I'll be happy to answer them now.
Okay, thank you. I'll get it. So one of the questions is how would you address the lag of ophthalmos, or does it need to be followed up, or?
Yeah, so especially in severe ptosis, when we correct it either with a supramaximal levator resection or a tarsofrontalis sling, in the early days after surgery, there is going to be severe exposure keratopathy because the eyelid is still not able to close completely. There'll be severe lag of ophthalmos, and also because the bells may not always be good. So one thing that can be done is to place a bandage contact lens for the first 1 week. But in all sling cases, we prefer to do what is called a frost suture, where a 4O silk or a 6O vicryl is passed through the lower lid orbicularis, and then the suture is taped to the forehead, pulling the lower lid up. This for 1 week is the kind of hand holding that is needed, especially in cases with severe lag of ophthalmos. But over time, the eyelid usually the Bell's phenomenon is good enough that the lag of ophthalmos persists only in sleep time, and about 2 millimeters of lag of ophthalmos with good Bell's phenomenon is not something we really need to bother. But patient counseling is important because sometimes patients are surprised that their relatives tell them that their eyes are open when they're asleep. So I think it's important to let them know before surgery that they're going to have post-op lag of ophthalmos. Very rarely do we have lag of ophthalmos that is persistent long enough to cause exposure keratopathy. But if that is the case, we have had a couple of cases where I have gone in and reversed the sling because you rather preserve the eye and the surface at the end of the day.
Thank you. Another question is, when there is a Marcus jaw winking in a child, when would you prefer to interfere? Because not for amblyopia, because eye is exposed otherwise. So when would you take up this child for surgery?
Right. So actually, that's a very good question. But the problem is that this is a very controversial topic also. For me, the single most important thing that decides the timing of surgery is the severity of ptosis. If it's a child who has got moderate or severe ptosis, it doesn't matter that they have Marcus gun or not. They need to be operated early to prevent meridianal amblyopia. But if it is a mild ptosis, or in a lot of patients, they don't even have any discernible ptosis, maybe 1 millimeter or so, but it's the Marcus gun jaw winking that is more significant for the parents. In those cases, they can be operated at any time. But again, it's important to counsel and know from the parents what is it that we want to treat. Is it the ptosis that's a problem or the Marcus gun? Because if it's ptosis that's an issue, a simple levator resection may bring the eyelid to a normal height and primary gaze. But if it's the Marcus gun, then as the video where we show, we have to disinsert and excise the levator and then correct it with a sling. So I think it's important to know what we treat before deciding, before going in for surgery.
Okay. Thank you, Dr. Akshay. I would like to know, if there is no Marcus, would you expose the tarsus and levator as you did for the Marcus gun ptosis now you have been showing, or you would just put a sling without?
Yeah, in those cases, I would do a closed sling. I would not do an open sky sling unless I have to excise the levator.
Okay. So in those cases, there is no need for anchoring, is it?
In those cases, there is no need for anchoring because the orbicularis itself is you haven't cut through the surgical planes, and you don't need to anchor. A lot of surgeons, even for a simple sling, do open it up because that gives the advantage of a well-formed lid crease, and also you are assured that your tarsus, the sling is anchored to the tarsus, and you will not have epitarsal migration later on.
Thank you so much. It has been wonderful. It has been a wonderful talk, Dr. Annie.
Thank you so much, ma'am.
Thank you. Shall we move on to the next talk? Dr. Annie, do you want to ask something?
My experiences, I have for last few years, I have never put a frost suture. I think it's not necessary. You can just put ointments, thick ointments, and ask the patient to put them even from the first day onwards every 2 hours, and also at night. I've never put a frost suture. It's not necessary because I found that under the pad, when you put a frost suture, you pad it, and under the pad, the frost suture is rubbing on the cornea sometimes. So I never pad and I never put a frost suture. I don't know the experiences of other panelists.
Thank you. Thank you. It has been a wonderful session. Thank you, Dr. Akshay.
Thank you, ma'am.
Okay. Shall we move on to, I invite Dr. Priya to introduce. There is a small change in the order of topics. Dr. Shruti Tara will be talking on the next topic. Over to Dr. Priya.
Our next topic is management of ectropion and lagophthalmos. Our speaker is Dr. Shruti Tara. Dr. Shruti is consultant in Department of Orbit and Oculoplasty Services at Shankara Eye Hospital, Coimbatore. She's done her oculoplasty training in Singapore National Eye Center. I welcome Dr. Shruti Tara. Over to you, madam, for the session.
Am I seen? Am I heard?
Yes.
Thank you, Dr. Anju and Team Comtrust for having me here. It's a privilege to be a part of this this meet, and Kerala is always very welcoming, and I thank you for that. So the next couple of minutes, let's just go through the ectropion and the lagophthalmos management. As we all know that lagophthalmos is, ectropion is the outturning of the eyelid margin, and I don't really need to go into the details of the theory. And obviously it presents with tearing, congestion, thickening of the lid margin, conjunctival keratinization, corneal epithelial breakdown, and sometimes keratitis as well. So the management basically is divided into medical and surgical management. Medically, we use a lot of lubricants, and surgical is something that I will just go through in a few slides from now on. So this is for a very mild ectropion, usually the medial one, where there is a small diamond-shaped conjunctiva is excised and the retractor is reinserted. I'm sorry, I don't have the video for this one alone. Excuse me for that. So now what we, basically we all know that it is the ligamentous sling at the canthal angles that is abnormal. So we have to refrain from excessive excision of the healthy tarsal plate. But having said that, we should not undercorrect it as well. So this is a small video on lateral tarsal strip. That is the gold standard for tightening any of these lid laxity. So this patient is not with ectropion, but this is just to show steps. Lateral canthotomy and cantholysis is done. And the lid is freed from its attachment. So you see the lid becomes lax like that, and it is split at the gray line so that your anterior lamella and the posterior lamella is separated, and you get a strip of the tarsus that way. Okay. So once the strip is made, the epithelium is debrided on either side, and adequate amount of tarsus is excised. It's good to measure twice and cut once. The epithelium is debrided so that we don't want the epithelial cells to get into the orbit and form an implantation dermoid later on. The so formed strip is anchored to the periosteum at the level of the lateral tubercle. So basically you should go into the orbit 2 millimeters from the rim. So that is how you get that opposition to the globe. So I use a double arm. One is the free end of a free needle, which is threaded onto the other end of the vicryl stitch and anchored to the periosteum. So both the ends are anchored, and you can see that the lid hugs the globe. So once that is done, it is very important to form the lateral canthus. After we excise the excess tag of skin which is there, so that excess skin where you have separated the media from the posterior and anterior lamella is excised. So that is a little bit of the lash bearing area. And then the lateral canthus is formed by approximating the gray line to gray line. So that gives a sharp edge to the canthus. So that is very important because later on we don't want rounding of the canthus, and that can cause tearing. And the skin is closed. So tarsal ectropion is something where the entire tarsus is rolled out. And after a lot of surgical minimal experiences that I have had, somehow I'm not too good in doing it from the conjunctival aspect till I found out this technique by Dr. Sampath Raghavan. This is called the Leicester sutures technique, where the suture is from the skin. You come on 2 millimeters below the lash line, and you come into the tarsus, and you reverse the needle and come out from the fornix to the skin, and thereby you're anchoring the retractors also. So you can see the lid actually turning in. Three such sutures are taken along the entire length of the lid. Somehow this seems to work well in my hands. I'm sure the experts a lot of them are doing it from the conjunctival side. Somehow the results were not too good, or my surgical technique was not right. So this seems to be working well in my hands, and I have been doing this, and I couple this with the lateral tarsal strip. It is consistent, and it is it's easy to learn. So three or four such sutures are placed, and then, as I said, I couple it with the lateral tarsal strip. So this is the pre and the post-operative appearance of one such patient, and I don't take off the stitches. We just leave it and it falls off because we're using vicryl. And this is another small technique which I picked it up from Dr. Ganga, where when the lid is not very lax, and you can get away without doing a lateral tarsal strip, you don't actually cut the lateral canthus, thereby you're not hampering its sharpness. 4/0 vicryl is taken, and a knot is placed to prevent slippage. A small stab incision is made at the lateral edge of the tarsus, and the needle, double arm needle, it's a double arm needle, so you enter from the stab incision to the wound that you have. I have made a lid crease incision here, a small lid crease incision. You come out of that, and then you hitch it to the periosteum, again into the orbit. And the second edge of the needle is also passed to the same stab incision, a little away from the first one as you exit, so that you include more tissue in between the two sutures. Here again, the angulation will be up. The traction is above. and it is tied. So this works well with mild lid laxity. So what about when there is a lot of medial canthal tendon laxity? We can do a attachment of the medial canthus to the periosteum. So I prefer the open technique because I know where exactly I am anchoring. There are some people who are doing it in closed as well, but this works better with me. The medial end of the tarsus is exposed. A small pocket is created and you exit through the incision that you have made here medially. And for this, I prefer a P2 needle or a half circle needle, because that gives you a deeper anchorage. That is what you want here, because we don't want the medial canthal standoff. So the P2 needle is then anchored at the level of the posterior lacrimal crest. Again, here the traction is above. So once that is done, I exteriorize it to the skin and tie it up. So this is the kind of the laxity which is reduced on pulling. So medial canthal tendon plication again is there in all the textbooks. I'm not too fond of it. It doesn't give you the adequate tightness when required. Mechanical ectropion like this in this patient with the nevus and yet another patient of the similar kind, a simple shave excision works well. And evening of the margin is very important here. And so that gives you a simple surgical excision. So cicatricial ectropion again depends on the kind of ectropion, the severity of the ectropion which is there. Simple ones can be dealt with Z-plasty like in this patient. Or if there is a scar which is horizontal along the lid margin, you can take a flap from the upper eyelid and anchor and hitch to the lower eyelid and thereby correcting the ectropion. I prefer this to the free grafts. Or simple, sometimes ectropion like that, when you want to prepare for the surgery, you can also soften the scar by giving 5-fluorouracil, about 0.5 to 0.2 ml of 5-fluorouracil is injected into the scar tissue. Sometimes you get a severe cicatricial ectropion of this kind where the patient had to undergo a series of surgical procedures, grafts, Z-plasties to give a reasonable correction of this kind. And this is yet another patient which is there in the list, but I really have no clue what to do in this kid. I'm waiting for expert opinions on this, and people can really guide me as to what to do in this. Sometimes a poorly sutured wound can cause ectropion, and here there was the patient had canalicular injury as well. If not anchored in its place, can cause ectropion later on. So if you see a badly sutured wound like that, feel free to remove it and resuture it. And sometimes case like this, wherein this was operated elsewhere for neurofibromatosis and the patient had ectropion, I went in from the posterior aspect and excised conjunctiva and molars to give a correction of this. Now, lag of thalamus, various causes from the facial nerve to cicatricial to iatrogenic, proptosis, uriblepharon, thyroid eye disease are all the causes. Bell's palsy, where we treat them with drops and ointment initially, but I prefer now to, especially if there is exposure keratopathy, I prefer to do a chemical tarsorrhaphy by injecting botulinum toxin to the levator and to create a ptosis of this kind. So medial and lateral canthoplasty, wherein the medial canthoplasty where you hitch the orbicularis of the lower eyelid to the orbicularis of the upper eyelid, works in some cases like this, but in some patients, just a single procedure alone may not be sufficient, and we may have to couple them with a retraction repair, and also sometimes spacers need to be used. And this is the retraction repair that I prefer doing. I prefer the conjunctival approach. This is the Patterman's technique, where the conjunctiva is undermined and it is reflected to the fornix, and just the conjunctiva alone is reflected, so that the Muller's muscle is still attached to the levator posteriorly, and the Muller's is then incised in its entire length and reflected towards the fornix again and excised. So you can see the levator posteriorly, and the entire length of the Muller's is excised, and the conjunctiva is glued in place. So this is the post-operative appearance of this gentleman, where I did the Mullerectomy. I did a lateral tarsal strip and also a medial canthal suspension. So, and sometimes you get patients like this with facial palsy and brow ptosis. So marking is again, I've done a direct brow lift here. Lift up to the place that where you want the lid to be, I mean the brow to be, and then drop the brow down. So medially, I don't prefer a spindle. I prefer to take a V incision there, because it gives a more medial lift. And it is excised. It looks a little gory, yes, but the thing with this is, you have to anchor it to the periosteum in patients with facial palsy. This is pre and this is the post. Again, I have done a lateral tarsal strip and a Mullerectomy in this patient. So lid weights are used. I'm again not a great fan of lid weights. And this was at another patient who had a subtle mild lag of thalamus, and he wanted correction. So I did a Mullerectomy and a very, very limited lateral tarsorrhaphy. And he was not happy with that. He wanted that little bit of the lid to be lifted up. And so I gave fillers and this area so that it stretches the anterior lamella and pushes the lid up. So again, thyroid eye disease can cause a lag of thalamus, obviously, and this was pre three-wall decompression, and this is post three-wall decompression. So basically, it is no single procedure actually helps. You might have to club them all to give a better result, and combine them all and tailor-made to every patient. Thank you.
Thank you, madam, for the excellent talk and excellent videos. It was really informative.
Thank you, ma'am.
So there are a few questions. Shall we take them now? While doing surgery for medial canthal tendon laxity, what precautions would you take to prevent injury to lacrimal drainage system?
Ma'am, basically, when you are taking the medial part of the tarsal plate, you don't really go higher up towards the canaliculus is one. And that is why I prefer doing the open technique, wherein I reflect the lacrimal sac so that I don't injure the lacrimal sac. And then actually it is not very, the bone is quite friable. It's quite thin there. So when you're anchoring, sometimes you can actually puncture the bone there. So I see it and then I take a bite so that, I don't pass through the lacrimal sac. So I don't prefer the closed technique here. That's the reason. And using a P2 needle is very important, because that needle has got that contour, that contour is a half circle. So when you take a bite, the next bite is where you want to exit. It just automatically comes up.
So is there a chance for kinking of the canaliculi?
Yes, it can kink.
You said, Sudhitara, you said posterior lacrimal crest. Posterior lacrimal crest, did you mean
You don't
anterior?
have to go so far down, ma'am. Yeah, you don't
Okay,
really need to
posterior
go
is
so far
posterior
down.
to the.
Yes, you don't have to go so far. What I meant is in that angle you have to go. You don't have to go because if you are very anterior, there is a medial canthal standoff, and then it defeats the whole purpose. It doesn't really follow the contour of the globe.
You
So
can, if you go from behind the original attachment of the medial pupillary ligament, then you will be in the correct thing, no?
Yeah, that's why some people prefer doing it transcaruncular. They go transcaruncular and then they come out. That is another way of doing it.
So another question in the chat box is, how do you manage cicatricial ectropin in ichthyosis?
Yeah, ichthyosis. There are a lot of papers on that where they take the mother's skin and do that. But then actually there is this acetron. I think it is, I forget the name. This is one of that, Dr. Santosh usually uses that thing. I forget the name of the tablet. And that actually helps. You have to give it in concurrence with the pediatrician and the dermatologist, and that actually helps in reducing the cicatricial ectropion in these patients. But the downside to that is, again, in males, you'll have to give it for a long time, and that can affect the the reproductive system and things like that. So there is a little controversy on that. I forget the name of the tablet. I think I should give it to me at the end of the session. I will tell you.
Dr. Fairuz, do you want to add something? That was a very excellent talk, especially the medial ectropion, which is quite often difficult to tackle. Very nice videos, Dr. Shruti. Long time I have not seen you.
Yes.
Yeah. So shall we go to the next session? If there are, if you can sit through the full session, we can take up any more questions which are coming.
Yes, definitely.
Yeah. So now we go to the next session, which is none other than our dynamic Dr. Fairuz, who has done her residency from Mysore Medical College and Research Institute. She then underwent fellowship program in ophthalmic plastic surgery, orbit ocular oncology in LV Prasad, and did fellowship in ocular oncology at Wills Eye Hospital, Philadelphia. And currently she is the director of Horus Specialty Eye Care, Bangalore. She is the vice president of Asia Pacific Ocular Oncology, Pathology, and scientific committee member of AIOS, section editor of IJO, as we all know, alumni of Asia Pacific Association of Ophthalmology Leadership Development Program, and has received the achievement awards from American Academy, Asia Pacific Academy, and she has been one among the top 100 women ophthalmologists worldwide, included in the Power List 2021. So, and lot more to say about her. Over to Dr. Fairuz for that talk on lid.
Thank you, ma'am. Thank you so much.
Yes,
for
eyelid lesions and their management, a very important topic. Lid lesions are very common. Okay, thank you, Dr. Fairuz. Please take over.
Thank you very much, ma'am, for the kind introduction. And thanks to Anju and you and Comtrust for having me here. It's a pleasure and a privilege. I'm going to share my slides. Just a second. I hope it's visible and I'm audible enough.
Yes, yes.
All right, yeah. So yes, this is definitely a very interesting topic. We come across various eyelid lesions, be it a specialist, be it a general ophthalmologist, be it a postgraduate student, when, there are certain situations where you are in a dilemma as far as diagnosis is concerned, as well as the management is concerned. So I have kept few case scenarios, and it's really sad that we're all online. It would have been much better to be in person and interact a lot, so that the discussion and learning is much better. Anyways, so these are my affiliations, and I have no financial disclosures or interest. Well, so the first eyelid lesion. Well, where is the eyelid lesion? Did I put a wrong picture? Well, I think it's a wrong picture. My slides are changed. Well, let me just see. Go through it again. Well, no eyelid lesion. Ma'am, you think it's a wrong slide? 1 second. There you go. All right, so a little bit of drama there. Well, these lesions can present like this. This patient complained of swelling in the eyelid. A recent patient that I saw in December, she complained that she had a swelling of the eyelid. And then she also says that swelling subsided on itself. There was a resolution, a swelling came in. And she was seen by an ophthalmologist, a specialist, and she was treated as a case of chalazion, all right, as an MGD. But, this doesn't really look like a chalazion, and you exactly doesn't see anything. There is no lumpiness, there is no bumpiness over the eyelid. It's so flat, as you saw in the previous picture. But lid eversion is so very important, and detailed evaluation of the lesion is so very important. We all know that chalazion appears as a yellowish granuloma in the tarsus. There could be a burst chalazion. It could just appear as a swelling with an intact tarsus on the surface. But this is something really different. In fact, the patient was under treatment for chalazion, and since it was not resolving, this patient was referred to me for a query whether we should do an incision and drainage in this chalazion. But this looks slightly different, right? Yeah, as you can see here, it's very flat. It's kind of a plaquic lesion over here. But there are certain abnormalities that you can see on the surface is the intrinsic vessels. Although there is no large feeder vessels, but there are abnormal vessels on the surface. And what is most striking, this is actually a very flat surface over here that you see. Most striking is that there is some amount of fleshiness and a nodularity in the inferomedial margin of this lesion. And there is absolutely no lash loss, all right? It's just the lesion is just growing towards the lash, and it is still not caused any lash loss, which is very classic and characteristic of a sebaceous gland carcinoma. Well, there is rounding of the posterior lid margin. And this is what it looks like. Well, I didn't have a second thought about it. I didn't go for an incision and curettage in this case. Well, the plan was eyelid excision with a wide margin, frozen section, and reconstruction. The story doesn't end here. It's a nice story. It's a very good story here. All right. This is what the clinical picture was. Now, I went ahead taking, a wide margin. So clinically, how do we take a wide margin in sebaceous gland carcinoma or any eyelid malignancy is that the clinically visible margin is initially marked. So this is basically the clinically visible margin with the lesion. And then you take 4 millimeters on either side. You take medial, lateral, inferior. And this is the posterior lamella of the eyelid. We also do the same in the anterior lamella. And this is how you cut it. All right. Yeah. So, I thought I would get some amount of lateral lid margin for reconstruction. And this was exactly 4 millimeters. But unfortunately, there are certain situations where very rarely I get frozen section margin positive, despite a 4 millimeter margin. And this patient came as a frozen section margin positive. What does that mean? This is a very flat lesion. This is kind of a very flat, morphic kind of a sebaceous gland carcinoma, not the classical nodular one. It doesn't have a pegytoid extension. The tarsus looks absolutely white in color, no congestion. But there is some amount of extension and advancement and infiltration of the margin. In fact, the patient went ahead getting again another 2 millimeter margin in this case, and that's when we reconstructed her. So this is post-op 10 days and this is post-op 6 weeks. I mean, I just operated her in March. Her PET scan was done and that was within normal limits. So this is how basically we manage sebaceous gland carcinoma. So yet another case. This again is another case, very subtle. The patient says there is some amount of thickness that I feel, some nodularity in the lower lid margin. But when you see exteriorly, there is nothing there. It's totally silent. So on lid eversion, again, there is this yellowish whitish lesion over there. Well, it could be an epidermal cyst also in this particular case, but epidermal cyst is very, very limited. But you can see there is kind of infiltration which is happening towards the posterior lid margin. And this also, in fact, came as sebaceous gland carcinoma, although it is a very tiny nodule sitting in the inner part. So lid eversion is so very important, and detailed evaluation, the vascularity gives the clue. We always think about lash loss, but that happens when the tumor really grows into the posterior lid margin and the lash gets affected and then it falls off. But there can be the initial presentation where the lashes can be intact as well. And this nodularity over here, which is extending, is also a clue that this is kind of a risky lesion. This was also a sebaceous gland carcinoma. Now, this was, we all know that sebaceous gland carcinoma is a masquerader. And this is a case report that I had presented and published during my fellowship, and a very, very rare case of a sebaceous gland carcinoma, which actually presented as a cyst. You can see that bluish, cystic appearance in this lesion. In fact, the operating surgeon initially thought it is a cyst. So that was a cyst excision which was done. And as a surprise, it was a sebaceous gland carcinoma, and a further excision was carried out. Now, this patient was again treated as chalazion, but she had multiple recurrence, all right? Multiple recurrence, incision and curettage done twice elsewhere. Well, although it is quite inflammatory, it is kind of hyperemia over the skin is there, you avert it, you can see it's more of a transparent cystic thing. But seeing the other case during my training, this was also kind of suspicious because it's a masquerader, right? Although I was not too convinced about the sebaceous gland carcinoma, and in situation where you're really not convinced, and then it's like 50-50 chalazion and sebaceous gland carcinoma, do an incision and curettage, and always send the specimen for histopathology. So this same thing I did an incision and curettage for that, and histopathology came as chalazion. All right, so yet another case. Well, her history is very rapid. She said that within 2-3 weeks, there is this swelling which appeared in her upper eyelid. In fact, sebaceous gland carcinoma is not something which appears in 3 weeks, although there is a rapid progression of growth, but it will be the patient usually comes with a history of 6 months, 4 months. This is just like an acute onset where you're thinking of an inflammation or an infection. But this is a cystic lesion. So, well, we went ahead doing an excision biopsy, but this came as an epidermoid cyst of the eyelid. Although, as you see here, the tarsus is absolutely fine. It is more sitting on the epitarsal area. So this again was a patient who was treated as a case of blepharitis, unilateral blepharitis. We all know meibomian gland disease is a common clinical scenario, but then unilateral blepharitis is again a red flag. All right, so she has this kind of a very ulcerated eyelid lesion in the lateral canthus, and the suspicion was a pegytoid spread of a sebaceous gland carcinoma. So any blepharitis which is asymmetric, unilateral with ulceration, always think of a pegytoid spread of sebaceous gland carcinoma, and this was a sebaceous gland carcinoma with a pegytoid spread. And she has been having, she's still under treatment, she has been having multiple recurrences despite excision several times, but well, doing well so far without any systemic issue. So just a little bit on the map biopsy. In such situation where you have pegytoid spread, although it's very evident in the lateral canthus, you may have pegyatoid spread in different parts of the bulbar conjunctiva, the tarsal conjunctiva, and the fornix. So this is the rule that we follow as far as map biopsy is concerned, whenever a pegyatoid spread is suspected. So in fact, we take 17 specimens. I mean, the caruncle is not included here. The caruncle is also taken, including the bulbar conjunctiva, the fornicial conjunctiva, upper and lower, and the tarsal conjunctiva, and everything is kept. It's like a 2 into 2 millimeter specimen, a square specimen that we take, pinch it out, keep it on a filter paper, number all the specimens, and this goes to the pathologist, which is numbered. And also in your documentation, you should be having the numbers. So once the report comes, you exactly know where the mapping is and which are the areas which is positive or negative. Well, similar situation, basal cell carcinoma, again, it's a very infiltrative disease. It can be superficial, it can be nodular. There is a morphiform here also, infiltrative ones. So this was also yet another case where I actually had to go 2 times margin clearance for complete, margin negativity. And this can also be associated with systemic syndromes like Gollen-Gott syndrome, basic syndrome, and commonly xeroderma pigmentosum. So sometimes you land up with very extensive reconstructions in situations where there is an infiltrative pattern of whatever the carcinoma is. Yet another case of basal cell carcinoma where, the entire lower lid and even including the anterior orbit has to be excised and reconstructed with larger flaps. So why is this so very important, and why am I highlighting this here? This lady was seen by me with a recurrence of a basal cell carcinoma where a simple eyelid excision was done with 2 millimeter margin by from somewhere, and frozen section was not done. Margins were not proven negative, and she came back with a recurrence in 4 months. So I just want to really emphasize the need for this. Eyelid melanoma is yet another lethal eyelid malignancy. In fact, in eyelid melanoma, I go much more wider, around 5 millimeters to 7 millimeters of wide margin, because this is much more lethal than sebaceous gland carcinoma, and we don't want any recurrence in these lesions. So you might land up losing a lot of tissue, but well, as oculoplastic surgeons, you have various ways to reconstruct this. This was a large inferior tensile flaps, not even too complicated flap, which was taken in there. And this is how she looks after 2 years of reconstruction. So I'm just going to quickly take you through the measure, not the entire surgical procedure. Probably we don't have time in this. So what do I mean by margin clearance on a surgical table is, we use a caliper, we exactly measure 4 millimeters, we use a marker from the clinically evident margin anteriorly, including the anterior lamella. Also avert the eyelid and take care of the posterior lamella also. And this is even for the postgraduate students, in a busy government medical college, you might be the one who might be operating on these cases, and you have to be very, very cautious and diligent in this. So we take traction on the other side of the margin, which has been marked for the incision, and once the traction on the other side of the tumor, and then so this is how we excise the margins, making sure that the entire lesion is taken off, and it's kept on a filter paper. So there are situations where we also take an extra margin for the frozen section, if at all there is a little bit of more congestion in the conjunctiva. And well, I'm not going into the reconstruction over here. So this is what I mean by it. So, well, there are rarer tumors also, and this was a patient who was actually referred for a eyelid cyst, but it doesn't look like a simple eyelid cyst, right? There is a lot of vascularity, there is a lot of redness. So certain things that you have to keep in mind is adenocarcinoma is something that you have to keep. It could be primary, it could be a metastatic adenocarcinoma of the eyelid. And surprisingly, this was my first case of syringoadenocarcinoma, and well, this came out to be a tumor, but not just a simple cyst. So this is how he looks like after complete excision with margin clearance. Now, well, we do come across a lot of cysts in our clinic, and it's very important to really look into it and not miss it and consider it as a simple cyst. You have to, again, kind of evaluate in detail. So doing So a torchlight, you can see how transparent it is, whether there is any solid part in the lesion. You can actually detect a feeder vessel. Well, there is a vessel over here, but it's not a very, very classical feeder vessel. So with transilluminancy in a cystic lesion, you can actually get to know a lot of features of the lesion. This came out to be a syringoadenoma, and very, very rarely, as you saw in the previous case, it can have a malignant variant syringoadenocarcinoma. Yet another cystic lesion in the eyelid. So she gives a history. 1 year back, there was a cyst. She was seen by an ophthalmologist. A needle was pricked and the cyst was, taken out. Just with a needle prick, the fluid was taken out. Well, after 1 year, she says, like immediately after 4 months, it's again started regrowing. And this is the growth in 1 year. It is a cystic lesion, purely a cystic lesion, you see it here. But well, the feeder vessels, the color, the redness, I was not comfortable about it. She just came for a simple excision with me, but I was not comfortable. And I did go for a margin clearance in this lesion. And this came out to be an endocrine mucin producing carcinoma of the eyelid. And this does have an association with CA breast. So in her, a thorough systemic evaluation was done, including mammography and chest CT. Everything came out to be normal. So there are cystic lesions which can also present as a benign, simulating a benign lesion in a malignant variant. So just summarizing the malignant eyelid tumors: basal cell, squamous cell, sweat gland carcinoma, keratoacanthoma. Keratoacanthoma is a low-grade malignancy. Now, the lethal eyelid tumors, this is how actually I classify my tumors to get the seriousness out of it: Merkel cell carcinoma, malignant melanoma, and sebaceous gland carcinoma. And this is in the chronological order of severity. Merkel cell carcinoma is the most dangerous, most lethal, then is malignant melanoma, and then comes sebaceous gland carcinoma. This was a patient who presented with this nodular lesion in the upper eyelid. Well, there is ulceration, referred as a case of query basal cell carcinoma. Yes, it does have those, central ulceration, a crater is there. So another differential diagnosis that I kept in mind was keratoacanthoma. I really thought this could be a malignancy and, well, prepared for frozen section, margin clearance, but this came out to be a nodular hydroadenoma, which is benign. So there is a lot of simulation here and there. It's always good to take care in these lesions. Yeah. So a similar lesion over here, which is in the periocular area over the brow. Well, when this patient presented, I did have keratoacanthoma again in mind because of this crater which is there, and you can see the heaped up skin all around, which is very, very classical of keratoacanthoma. And since I saw a nodular hydroadenoma earlier, well, that was the second differential diagnosis, but this came out to be a keratoacanthoma. And keratoacanthoma, again, is now classified under a low-grade malignancy of a low-grade squamous cell carcinoma. So it's very, very safe to get a margin clearance. In fact, I took a 3 millimeter margin clearance in this, and the patient is doing fine. So this patient, I'm sorry, I gave away the diagnosis over here. She was again, frantically referred by an ophthalmologist, thinking that, and this is a very rapid growth of a lesion within 2 months, where, probably suspecting a malignant lesion in the eyelid. Well, there is absolutely no vascularity, which is seen, it's like a very, probably some amount of keratin. And this was arising actually from the conjunctiva, the lower tarsal conjunctiva. And it came out to be a pyogenic granuloma. As you can see here, there is frons. I also thought of an inverted papilloma or a keratoacanthoma arising from the conjunctiva. I did go for a 2 millimeter margin, but this came out to be a pyogenic granuloma, which was the first differential diagnosis anyways, because there was no signs of malignancy in this. And she came really panicky because someone told her that it could be a cancer, but this is how she went back. This Aji was very, very cute. She was so happy after the diagnosis. Going on to a few of the benign eyelid tumors, which can, lesions which can be tumors or inflammation. And these are the common ones that we see in our clinical practice. It could be nevus, differences, papilloma, neurofibroma, vascular tumors, and Bell-Chalazion is very, very common. Eyelid nevus, the way I manage, it is a benign lesion. It's mostly cosmetic when we want to take it off, but there can be some amount of hair follicles which is sitting on the tumor. Some patients comes with irritation, which is touching over the cornea if it's in the central portion of the eyelid. This is a kissing nevus. Well, cosmetically, it is not looking good. So it's a very simple procedure. Even in eyelid nevus, simple eyelid nevus, what I do is like a very simple shave eyelid excision biopsy. There is absolutely no sutures, no cautery, and it's left for secondary healing. And that's exactly what I did here. It's it's excision by stripping and shave. And this is something that I learned from my mentor in LV Prasad. All pigmented lesions are not nevus. All pigmented lesions are not melanoma. This is again another common skin lesion which is seen in the eyelid, ocular and periocular area. As you can see, this stuck-on appearance, and which is very, very classical of seborrheic keratosis. But certain large lesions might require extensive surgical reconstruction. So she needed a skin graft. Being an older lady, I just did a blepharoplasty on the other eyelid where she looks more rejuvenated and more beautiful, and the same skin was put over here for reconstruction, and well, this is how she looks after this extensive excision. Cyst, yes, they can be smaller cysts, they can be bigger cysts, which is arise from the eyelid, sebaceous cyst, epidermoid cyst, and this was a large cyst, and we all know that it's very, very straightforward case of a benign cyst. It was excised, and well, this is 1 week after suture removal of this surgery. Now, going on to vascular lesions, yes, there has been a lot of discussion regarding capillary hemangioma and its treatment, and there has been a paradigm shift after the introduction of propranolol, oral propranolol. And this was a child who initially presented immediately after birth, within 1 month of birth, and with a capillary hemangioma. So the rule is, if it's not obstructing the pupillary axis, we can even wait, because there is a natural self-resolution for capillary hemangioma. But of course, parents are hyper about it, and they even are concerned, even as a newborn baby, about the cosmetic appearance. So what I did was went ahead with timolol, topical eye drops over there. Timolol, the gauze was soaked in timolol. The timolol gel is not available recently, which was put over the lesion, and also 2.5 milligram of propranolol was given in this child, and this is how you can see the lesion has resolved. So this is pre-treatment, and within 4 months, the entire lesion went away. Now, this is a 24-year-old lady with a lower eyelid swelling. You can see a bluish swelling over here. Anything which is bluish in color, reddish in color, we all know that it's vascular. In fact, she had a vascular lesion, and it was a varix of the eyelid. So the only thing that I did was to inject bleomycin. So bleomycin is a very well-known drug for veno-lymphatic malformation, what we call as lymphangioma, especially in macrocystic lesions. But the application in my practice, I have slightly extended to other vascular lesion also. So in this varix, which is very difficult surgically to excise, it really, really works. I have used it in even orbit varix. So the injection bleomycin was given. Just with 1 session, the entire lesion melted away. Now, this patient again was referred with a fullness in the lower lid. Well, when you see this case like this, you can even think of an eyelid bag where, you're attempted to do a lower lid blepharoplasty. But well, this was something more. It was not soft. It was more firmer. And as you can see here, there is nodularity over here. It's not an age-related lower lid bag, more to do with it. We did an MRI, and as you can see here, there is lesion which is sitting over here. Well, I did go ahead with an incision biopsy from the fornix, and this came out to be a small lymphocytic lymphoma, chronic lymphoid lymphoma in this case. So very rare lesions, which is even systemically involved, can also metastasize and present as an eyelid lesion. So these things have to be kept in mind. Now, a few newer advances as far as eyelid lesions are concerned, especially the eyelid malignancy. The sentinel lymph node biopsy, yes, yes, it does have indication. Yes, we do it. So the technique is basically you inject technetium 99 into the conjunctiva over here. You just inject it under topical eye drops, and then the patient goes, my head and neck onco team does it for me. They go for a lymphoscintigraphy. The only thing I do is to inject the drug. A lymphoscintigraphy is done with a handheld gamma probe, and if there is some uptake which is detected, then the skin is marked, excised, and then the lymph node is taken out. So what are the indications? There still exists some amount of controversy where people kind of shy away from doing it. I'm basically very cautious with my patients. I definitely do PET scan for all these patients, but well, when there is a requirement, well, we do this sentinel lymph node biopsy as well. So the indication is any cutaneous eyelid melanomas of more than 1 millimeters in size and more than 1 mitotic counts in high power field, and of course if there is ulceration. Sebaceous gland carcinoma of more than 10 millimeters and Merkel cell carcinoma of any size. As I told you, it's the most lethal one. And this I learned from this particular publication by Beta Smiley of MD Anderson, who is a great ocular oncologist. Now, the other newer advancements, this is basically for the postgraduate students who are sitting here. You might get an answer regarding this. I mean, a question for your exam regarding this. This is the hedgehog inhibitor, the Vismo-Degib. Eriveg is the product commercially available, and it is FDA approved use for basal cell carcinoma. And well, this is how the publication shows the effect. I have not personally used it so far. The other thing is epidermal growth factor receptor targeted therapy, mainly in squamous cell carcinoma, erlotinib. It is available in cancer centers, but it's usually used as a secondary mode of treatment. I have a couple of patients who had, a recurrence in the orbit of squamous cell carcinoma, where you really young patients who really, you don't want to go for an exentration. So the secondary line of management adopted was an epidermal growth factor receptor along with the radiotherapy. Well, this is a publication where they have seen a significant, promising outcome with the epidermal growth factor receptor. The checkpoint inhibitors, immune checkpoint inhibitors, again, is very much in use in the United States of America as in trial and also in certain oncology centers. I don't have personal experience with it. This is very, very expensive and it's very difficult to procure in India. So we have the PD-1 inhibitors, the PD-L1 inhibitors, and the CTLA-4 inhibitors. So, well, I just took you through in this limited time, a brief overview of the eyelid lesions. And first things first, I wanted to highlight the malignant ones so that we never go wrong. Well, we are not perfect, I know, even in my practice, there can be misdiagnosis, but as far as possible, if you do a very meticulous evaluation with patience and passion, I think most of us can get it right. And thank you very much. So always please follow oncological principles. We are all oculoplastic surgeons. I know we all want patients to look beautiful and good, but then never compromise on the oncological principles. You can really well reconstruct large excisions. Thank you so much.
Thank you so much for those variety and wonderful videos and all the lesion. I know there are still more, but very large variety. Thank you. It was a wonderful talk. Shall we keep the questions for the end of the session and go on to the next?
Definitely. Please, ma'am, go ahead. I'm here. I'm sitting here.
Thank you.
Yeah.
So, Dr. Priya.
Our next topic is lash disorders, my approach. Our speaker is Dr. Marian Pauly. Dr. Marian Pauly did 2-year clinical fellowship program in orbit, oculoplasty, trauma, and reconstructive aesthetic surgery from Shankar Nethralaya, Chennai. She underwent ICO short-term fellowship in ocular oncology from Wills Eye Institute, USA. She's recipient of gold medal for best outgoing subspecialty fellow from Shankar Nethralaya. She has participated and presented papers in state and national level conferences and won many awards. I welcome Dr. Marian Pauly. Over to you, madam.
Yeah, hi, good morning to all of you. At the outset, let me thank the Comtrust team, Dr. Anju, Laila madam, for giving me this opportunity. Let me share my screen. Hope the slides are visible. Okay. Yeah. So I'm going to deal with a very common thing which we come across in our OPD, lash disorders. So first before I start to the topic proper, what's the role of eyelashes? It actually protects the eye. And second, the lash follicles, the length is like 2 mm in the upper lid and 1.75 mm in the lower lid. The main two common things which we come across are, one is trichiasis and the other one is dystrichiasis. So what is trichiasis? It is misdirection of eyelashes towards the globe. What is dystrichiasis? So in this picture you can see one or more extra row of lashes, extra row of cilia within the tarsus behind the normal row of lashes. Trichiasis can be either primary or secondary. In primary trichiasis, the follicle is distorted and the lid margin will be normal. Whereas in secondary, follicles are normally aligned and the lid margin is rotated inwards, what we are seeing in this. Dystrichiasis can be congenital or acquired. It can be isolated or syndromic. Syndromic means it can be associated with ptosis, strabismus, or any other systemic conditions. Here the pathology is the epithelial germ cells, failure of epithelial germ cells to differentiate completely into meibomian glands. Instead, they become pilosebaceous units. Before I move to the management, it is very, very important to understand the anatomy of the lid margin. So we know there is conjunctiva, mucocutaneous junction, meibomian gland orifices, gray line, and anterior lash line. When you deal with a patient presenting with, usually they present with irritation, watering, photophobia, that's the most common complaints. So when the patient enters your OPD, just see. First, rule out epiblepharon. So what is epiblepharon? Here, there is an extra row of skin over the lashes causing pseudo-entropion kind of picture. Then ask for any infections, especially trachoma, herpes zoster. These are the two things which we come across in our clinical practice. Then look for any autoimmune disorders. Most of the time, patients, when they come to you, they won't say that, no, they will just present with irritation, watering, photophobia. And ocular cicatricial pemphigoid is really a missed condition. So always ask for any skin diseases which they might have taken it is very light. And when you see a patient, always ask for this OCP. Then Stevens-Johnson syndrome, chemical burns, obviously most of the patients will have clinical findings, other clinical findings in the ocular surface. Then ask for any trauma or any surgery. Surgery, like for example, previous lid tear repair or any surgery near the periocular region. So coming to the examination per se, first examine the lid margin. Is it in the normal position or is there any rounding of posterior lid margin or any anterior migration of mucocutaneous tension? Sometimes the lid margin is not at all well defined. So some inflammatory process is going on. So now when you see a trichiasis, see whether it is focal or diffuse. Focal means confined to a small quadrant. Diffuse means it is involving the entire length of the eyelid margin. Now look for posterior lamellar scarring. Then look for symblepharon. So finally, look for any involutional changes, because involutional entropion also most of the time it is missed when the patient presents with irritation, watering, and when you look at the slit lamp, lids may be normal position. What we can do is ask the patient to have a forced lid closure like this. So if the lid goes inward, that means the patient is getting occasional involutional entropion, creating the troubles. Then look for dystrichiasis and epiblepharon. This is pertaining only to the trichiasis and dystrichiasis part, but you have to rule out the causes for watering, irritation, other reasons also. So now, once we have decided, like we have differentiated dystrichiasis, trichiasis, what are the goals of our treatment? So one, make a continuous row of lashes, if possible. Reposition of the misdirected lashes. Then eliminate the lash that cannot be reposited. Like some of the lashes, even if you do, it can come back, or the lid itself is in a different position, so that eliminating the lash itself might not correct the problem. So finally, reconstruct the lid margin if needed. So this is broadly classified into one is lash or follicle destruction surgeries, other one is reposition surgeries, and finally combined procedures. So come to the destruction surgeries. So one is simple epilation. So this is a temporary procedure as we know. It is very simple and fast, and it is done under slit lamp. Here the main thing we should remember is when you hold the lash, hold at the near the root, that is near the lid margin. Don't pull from the tip because it can cause partial epilation, and partially epilated lash will give more trouble than the normal lash. So hold the lash at the, if possible, near the root, that is near the lid margin. Now coming to the radio ablation of lashes. This is done using radio frequency cautery, done under local infiltration. Fine needle is used. I will show a small video. So the radio frequency tip is inserted into near the lash follicle, almost 2 millimeter into the lash root. Then the radio frequency pulse is applied for the 5 to 10 seconds. So you can see some white bubbles at the margin, and the lash bulb will be attached to the cilium. So this is, you can see this lash root and with the lash. So this is an ideal way of doing radio ablation of lashes. Here success rate is around 70%. And if you want to increase the efficacy of this, you can inject mitomycin C 0.02%, 0.1 ml near the lash follicle site, which gives more good result. This is very useful in patients with Stevens-Johnson syndrome or ocular cicatricial pemphigoid, where only few focal trichiasis is present, or focal trichiasis or dystrichiasis is present, without any associated other problems. Coming to the electroepilation, current is applied for 1 to 2 seconds. It's a low power AC. Heat will destroy the follicle. Here the recurrence rate is more, that is more than radio frequency ablation, around 50 to 70%. Laser epilation, I personally don't have any personal experience. Argon laser and diode laser has been used. So now come to the cryotherapy. Cryo destroys the follicles by freezing. This is useful when there is a broad area of the misdirected lashes. This is commonly used in dystrichiasis. This is done using nitrous oxide and double freeze thaw at -20°C for 20 to 30 seconds, thawing for 1 to 2 minutes. Can be done either through skin or through conjunctiva. And after 5 to 7 days, usually the cilia will fall by itself, or you can epilate the cilia. The success rate is around 70 to 80%. So in dystrichiasis, what we do is we separate the lid into two lamella, anterior lamella and posterior lamella, along the gray line, and cryo is applied to the posterior lamella so that it destroys the lash roots. And in most of the time, it gives you a very good result, that is around 80%. So now come to the second procedure, that is pentagonal wedge resection. So what is the role of wedge in management of trichiasis? This is done only in segmental trichiasis. See, for example, a litter has been done, and a one of 3-4 lashes with a small shallow notch. So what the advantage is, when you do a pentagonal wedge, you can correct the notch as well as you can remove the trichiatic lashes also. So this was a case of trauma with a small wedge and localized trichiasis underwent wedge resection. Coming to eyelash refination. This is a new procedure which I'm using in very localized trichiasis. So we are doing trefination with Sisler's ophthalmic microtrefine. This is the instrument, and this can be inserted to the lash follicle and you can extirpate the lash root. It has already been published in OPRS journal. It has got a success rate of around 60%. So far we are seeing all those procedures with around 80% or 70% success rate. So now the next procedure is surgical excision of lash bearing follicles. So this procedure, if it is done correctly, it gives around 100% good result, like 100% success rate. So this is a 70-year-old lady presented with trichiasis more than 20 years. She had undergone multiple procedures, multiple radio ablations and multiple manual ablations in the past. So she came for a permanent procedure and she was not really bothered about the cosmetic aspect. So in this case, you can see her lashes are very fine, normal lashes only, but fine, but they're causing trichiasis. So I have done, what I have done is the 2 millimeter anterior lamella, that is the lash bearing area, is excised. So with radio frequency cautery, the incision is made, basically splitting the lid. It's only 2 millimeter depth. Anteriorly, skin is also incised. And now you excise the strip of anterior lamella. And finally, it looks like this, and it will granulate by itself. So this is her post-op picture at 2 weeks, and she is still under follow-up. She is doing fine. The only problem, it has got a cosmetic blemish because the lashes will not grow back. It is a permanent destruction. Now coming to lash repositioning procedures. So lash repositioning procedures primarily involves correction of entropion. So first is cicatricial entropion. So when there is a mild cicatrization, we can do a posterior lamellar tarsal rotation. So in cicatrization, we know pathology mostly lies in the posterior lamella, conjunctiva and tarsus. So in this case, we are rotating only the posterior lamella. The tarsus is incised around 3 millimeter from the lid margin. Marking is made. You can use either blade or you can use a radio frequency cautery. The tarsus is fully cut. And now sutures are taken from the tarsus, distal tarsus, sorry, from the proximal tarsus to the lid margin. The suture should come out through the lid margin. You can use 50 vital, basically absorbable sutures. So in this case, you can get almost 180-degree rotation of the tarsus. So this is done in mild cicatrization, which is not really progressive, especially old trachomas primarily. And sutures are tightened and the tarsus is rotated. In first case, we have rotated only the posterior lamella. Similarly, you can rotate both the lamella like this, both anterior and posterior lamella. So now come to little more severe entropion. So this is basically, we are advancing the tarsus. So in this, done in severe cicatricial entropion with shortening of the posterior lamella. Rotation is done when there is no shortening. If there is shortening of tarsus, you have to augment the posterior lamella with either mucosa or donor sclera or hard palate. My preference is mucosa, oral mucosa. So what we are doing, so in this case, you can see the tarsus is normally it should be around 10 millimeters and 8 to 10 millimeters. So here you can see hardly 2 or 3 millimeter tarsus. So what I have done is posterior lamella is advanced and tarsus is rotated, and I have put a mucous membrane graft also. So this is tarsus is cut, posterior lamella advanced, tarsus rotated, and this bare area is covered with mucous membrane graft. So this is his post-operative picture. So now come to the anterior lamellar repositioning. So anterior lamellar repositioning is done again in mild entropion with it can be combined with mucosal graft if there is a keratinization present, usually done in Stevens-Johnson syndrome. So what we have done is anterior lamella is mildly repositioned and keratinized lid margin is excised and covered with mucous membrane graft. This is the post-operative picture. So this is another patient, again keratinization replaced with mucous membrane graft, and this is the anterior lamellar repositioning sutures with Y0, Y3. I'm just skipping this. This is a short video where mucous membrane graft is done for the lid margin keratinization. A strip of keratinized lid margin is excised with. I use blade in this because already there is a cicatrization, so partly will cause more cicatrization. So I'm using the entry blade. And this is covered with mucous membrane graft. You can use glue or switches. So finally, we come to the senile entropion. There are various procedures to correct senile entropion. We know the pathology is lid laxity, both vertical laxity and horizontal laxity. We have to correct both to get a good and a persistent result. There are many surgeries done in entropion. Most of the time we combine most of this 1 or 2 procedures together. The most commonly done procedure is lateral tarsal strip, which Dr. Shruti Tara has already shown. So I'm just skipping the video of lateral tarsal strip. So the main thing is in entropion, when you correct the lid margin, like when you form the lateral canthus, you should be very careful. It always follow the anatomical principles. Otherwise, if 1 millimeter is going wrong, either way, you can cause recurrence of entropion also. So what I do is, in my practice, I combine lateral tarsal strip with everting sutures. So everting sutures primarily addresses the retractors and orbicularis overriding. So this is a short video. This alone can be done, especially in very old patients. The sutures are taken from the fornix and should come out through the lid margin. I'm using a 50 vicryl. Ideally, you have to use a double arm suture. Here I'm using a cutting needle. So the suture has come out the lid margin. 3 such sutures are taken corresponding to the medial limbus, pupillary plane, and lateral limbus. The sutures are tightened, which gives a good result. This alone also can be used, especially in very sick patients or bedridden patients, which is done just an OPD procedure. This is a case of entropion corrected with lateral tarsal strip and everting sutures. Second procedure is reinsertion of retractors. That also gives you very good result and proper position of the lashes. Sometimes entropion can recur due to persistent laxity. It has to be tackled if it recurs. Little bit overcorrection is accepted because we know lid laxity is an ongoing pathology. So now coming to the other causes of lash disorders, epiblipperon, which I have already discussed. So here what we are doing, we are excising horse procedure, that is excising skin orbicularis. Very minimal excision is needed, and that too if the patient is very symptomatic, most commonly seen in children, and some of those thyroid patients also you can get epiblipperon, that is acquired epiblipperon. a very minimal skin muscle excision, that is skin orbicularis excision is done, which gives you a very good result. Then coming to the lash ptosis. Lash ptosis is associated with floppy eyelid syndrome, especially in older age group and even in youngsters, which is very common nowadays due to obesity as an association of obstructive sleep apnea. So here the problem is lashes will droop and will obstruct the visual axis. It can occur an isolated thing also, as a lash ptosis can be an isolated thing, especially in patients with chronic allergy, with chronic rubbing leading to lash ptosis. Then along with the true eyelid ptosis, you can have lash ptosis. So that is very, very important to in the preoperative evaluation of ptosis, whether we should tackle lash ptosis or not. After ptosis correction also, you can get when there is an overhanging lid fold causing exerting pressure over the lashes causing lash ptosis. So it can be corrected with supratarsal fixation of orbicularis. It gives you very good results also. So to conclude, lash disorders is a spectrum of disorders, can be congenital, acquired, syndromic also. So the pattern and the cause of eyelash abnormality we should assess, and patient and surgeon comfort also should decide the treatment decisions. It is actually really challenging, even though, I mean, one lash can create lots of troubles in a patient's life. So it is very challenging. Most of the time we combine different methods. That only will give you 100% or almost 90% result. And patient education regarding the recurrence is very, very important in selected cases. And this will give you a very gratifying results. Thank you.
Thank you, madam, for the excellent talk and excellent videos. As we are behind scheduled time, we'll move to the next session. Thank you.
Thank you.
Thank you, everyone. Thanks.
Thank you.
Leela ma'am. Yeah, nice to see
It was
everyone.
a wonderful session. Very important too.
Yeah, lots of learning. Yes. Hi, Marian.
Thank you.
Thanks, ma'am. Thank you, everybody. Thanks a lot.
Thanks. Annie ma'am, bye.
Yeah,
Dr.
don't
Shruti.
leave. You're leaving now. Okay.
No, not leaving. I'm around.
Actually, a lot more questions are there, but I think there is no
Yeah.
time to discuss. That's why.
How many minutes short? 20 minutes short. My God.
Yeah, we are less waiting.
Yeah.
Okay, thank you.
Thank you, madam. Moving on to the next session, we have the Pandora's box. The discussant for the session will be Dr. Ann J.K., consultant oculoplastic surgeon at Little Flower Angamali Hospital. Dr. Hema V.K., consultant ophthalmologist at Comtrust. Over to them, ma'am.
Welcome, everyone. Our next session is Pandora Box. To discuss the session, I invite Dr. Ann J.K., who is a senior consultant in the Department of Orbit and Oculoplasty, Little Flower Hospital, Angamali, since the past 12 years. Over to you, ma'am.
Thank you, Dr. Hema. After an elaborate session on lids, we are moving to our session, that is Orbit and Pandora's Box. It is my pleasure to introduce our first speaker of the session, Dr. Anish Sridhar. She is the senior consultant in oculoplasty and neuroophthalmology, Little Flower Hospital, Angamali, and she is the unit chief. She did her MBBS from Thrissur Medical College, MS from Calicut Medical College, and she started the full-fledged ocularity clinic in Kerala in 2005, and she was mentored under Dr. Santosh Honavar. And I invite her for her presentation on Orbit, a potpourri of cases. Over to you, Annie ma'am.
Are my slides visible?
Yes, ma'am.
Okay, thank you. So I was wondering about how to arrange these cases, potpourri of cases of the orbit. When I came across an old slide where we had audited our cases, this was in 2014, where we found that inflammatory cases were leading the list with lymphomas and cystic tumors, vascular tumors, lacrimal gland tumors. So I'll go in that order approximately. This was a 26-year-old driver from the Gulf who was visiting Kerala only once in a year. and he came to us with a right proptosis, and he gave a history of nasal block since 10 years, treated under various ENT surgeons. And we found that there was a huge mass in the medial orbit, and CT scan also showed evidence of FES, which was done on both sides. So we debulked the mass, and the biopsy came as a fungal granuloma or aspergillosis. This is usually common. Aspergillus fungus is in where the people work under dusty conditions, and also with maybe with onions also. Onions, that black fungus is aspergillosis. So idiopathic orbital inflammatory disease or orbital cellulitis or pseudotumor, as we previously called it, could be sclerosing or non-sclerosing. So sclerosing disease, patient can present with a hard mass in any part of the orbit with calcification and bone erosion. And you can see the movements here are very well preserved. So it is not infiltrating. And it can occur in very young children also. And the CT scan will give the picture like a lymphoma. But histopathology will show a fibrosis and lymphoplasmacytic infiltration. So you always have to suspect an IgG4 disease, which can occur in any part of the body, like pancreas, salivary gland, thyroids, retroperitoneum. There's retroperitoneal fibrosis in the kidney and the lungs. So the diagnosis of IgG4 related disease is done by an elevated serum IgG4 of more than 135 milligram per deciliter, or a ratio of IgG4 positive to IgG plasma cells in the histopathology more than 40%, or more than 50 IgG4 positive cells per high power field. So the characteristic rapid response to steroids will clinch the diagnosis, and you may have to have a long-term treatment with either steroids or other immunosuppressives like azathioprine or rituximab also. This was a 40-year-old male who came to us with a left proptosis. CT scan picture showed a molding mass around the globe. We thought it was a lymphoma, but histopathology showed emperipolysis or lymphophagocytosis, where there were presence of live lymphocytes within the histiocyte. So the CD68 was positive, as also S100. Diagnosis of Rosai-Dorfman disease was done, and it was published along with RCC Trivandrum. This is a man who came with a prominence of the zygoma and a discharging sinus of the lateral canthus. The CT scan showed extensive destruction of the zygoma, which is soft tissue mass, which in biopsy turned out to be orbital tuberculosis, and it was totally, the bone completely remodeled with treatment. This was again a diagnosis as a lacrimal adenitis. There was a little hard lacrimal gland mass which was palpable, and it was biopsied. There was a palisading pattern of necrosis. The fungus was suspected, but that was negative. PCR was diagnostic of an orbital lacrimal gland tuberculosis. This is again a hard mass in the inferior orbit, which is producing a hypertropia and also a lacrimal nasolacrimal duct obstruction, which when biopsied showed non-necrotizing inflammatory cells with the Langerhans cell, giant cells, and the diagnosis was an orbital sarcoidosis. He was treated on long-term steroids for nearly 1 year, and the mass completely resolved. This man presented with redness and pain in the right eye, and there was a soft, fluctuant, slightly tender mass palpable in the superior medial orbit. And CT scan showed a mass lesion which was producing gross excavation of the inner table of the frontal sinus, and the mass was abutting on the dura, and there was also extension to the ethmoidal sinus, but it was a frontoethmoidal mucocele which was completely curated out. In addition, you have to create an additional opening to the sinuses, otherwise the mucocele can recur. But for that, you may have to acquire the help of an ENT surgeon. Subperiosteal abscess can present as a directional proptosis. Usually it's down and out, because in children, the ethmoidal sinus is usually involved. The chemosis and congestion will be less than in an orbital abscess, and CT scan will show a smooth dome-shaped swelling which is pushing the medial rectus laterally, and this will have to be drained. This patient presented as an abscess, a painful swelling in the upper medial orbit. Somebody had done an IND for him, but it had recurred. So CT scan showed a thick cystic mass with layered contents. So this was a dermoid which has to be completely removed, otherwise it can recur. This was done long back in, I think, 2006. So then I did a lid splitting orbitotomy where the lid is split completely and the mass is approached. But now I would do a upper lid crease incision. This was again a lady who presented with a mass in the temporal area, and she had a slight S-shaped ptosis also. The CT scan showed a cystic mass in the lateral orbit, which was extending through the frontozygomatic suture in the lateral orbit to the temporal area. It's not seen very clearly in that CT. So this is a dumbbell dermoid, which the wall has to be completely removed from the temporal fossa as well as the orbit and also along the suture. So all of us ophthalmologists in Kerala would have experienced recurrent patients who come with recurrent attacks of edema, migrating edema, which will resolve with a residual mass, usually in the anterior orbit, which when you on the table, it will show a cold abscess-like condition where there may be altered pus within the hard mass, and you can see remnants of either live worm or dead or degenerating worm. If the worm has completely degenerated, the diagnosis can be made only with a PCR for dirophilaria. We have more than 50 cases now which are PCR positive for dirophilaria. This was a non-resident Keralite, that was a manual laborer who was from the northeastern states, and he had a boggy mass which is non-tender. There was watering, but syringing was free. And the CT scan showed a bone eroding mass which is extending to the nasolacrimal duct, and the nasal endoscopy showed a reddish mass with yellowish spores on the surface. He gave a history of bathing in ponds. It was a rhinosporidiosis. A mild fullness of the temporal fossa should never be missed. This patient also had a slight hypotropia and on the left side, and CT scan showed a mass which enhanced very well with contrast. It was a bone hemangioma. This was a huge mass in the medial orbit with bone excavation, that is, it was present for more than 1 year, and this mass as well as a small mass in the anterior orbit, anterior to the orbital septum, both of them showed the same histopathology characteristics. They were schwannomas. This was again another huge mass which was encapsulated, but it had been breaking through the capsule and pushing the globe out, and it was a fibrous histiocytoma or a solitary fibrous tumor, which has been increasingly reported from other parts of the body by general surgeons. This lactating female presented with the fullness of both the superior orbits. There was a slight mass lesion felt in the lacrimal gland fossa, which when biopsied showed foam cells with lymphocytic infiltration. There was a two-tone giant cell, which is characteristic of a xanthogranuloma. This was again an ill-defined mass in the superior orbit, which in biopsy turned out to be a syringocystoidenoma. A bone eroding mass in a child always makes us shiver because it could be anything from a leukemia, rhabdomyosarcoma, etc. This was curated out and biopsied. There was eosinophils, plasma cell, giant histiocytes, and it was diagnosed as an eosinophilic granuloma, which is a part of a Langerhans cell histiocytosis. Curating itself is treatment. You can also inject local Vicort or lesional, intralesional steroids are also curative for this lesion. This child gave a history of recent onset of squint and defective elevation, and there was a mass in the superior orbit. We had a multiple differential diagnosis, but it turned out to be a simple hematoma. She did not give any history of any trauma. This child gave a history of trauma. There was a skin abrasion, but they could palpate a solid mass underneath, which when biopsied was CD99 positive, but TDT negative, which ruled out all the other small round cell neoplasms like lymphomas and lymphoblastic leukemias, etc. It was a primary neuroectodermal tumor. This was again a teenage boy who had a hypotropia and a fullness of the temporal fossa. A CT scan showed a huge mass which is extending to the brain and eroding the temporal bone. And this was also CD99 positive but TDT negative. And he developed swellings all over the body. He was treated at Vellore given chemotherapy, etc., but he expired within 1 year. So this child came with unilateral proptosis and a retrobulbar mass. So again, we have to suspect leukemia, etc. His fundus examination was negative. This fundus picture is of another patient. This peripheral smear was negative. So we did a biopsy. It turned out to be leukemic deposits. So if the fundus picture or a smear is positive, we can avoid a biopsy under GA, and we can straight away treat him for leukemia after doing a bone marrow biopsy. But his after the biopsy came, the bone marrow was positive for leukemia. Orbital yolk sac tumor is very rare tumor, and it's a malignant germ cell tumor which occurs usually in the ovary and the testis of infants. This was reported in collusion with Dr. Swati from LVPA. This was a punched out lesion in the temporal pole, and it was producing corneal exposure and a panophthalmitis, and it was a biopsy turned out to be a CD138 positive plasmacytoma, which was a part of a multiple myeloma. This patient too expired after 1 year. This elderly man who had a mass in the inferior orbit, and he gave a history of squamous cell carcinoma of the vocal cords. So we expected a secondaries, but it was a totally unrelated tumor with the basophilic secretory material and perineural invasion. This was an adenoid cystic carcinoma, which is totally unrelated. So the orbit stumps you once in a while, gives you a kick on the head once in a while. So this was a squamous cell carcinoma, which is extending to the orbit. So this has to be accentuated. A molding mass in the superior orbit, which melted on radiation, was a lymphoma. This was a lacrimal gland lymphoma, which had a fish flesh appearance on table. Anyway, I removed the whole tumor, and the patient was then investigated for systemic lymphoma. Bilateral lacrimal gland masses, which when biopsied turned out to be lymphoma. The patient gave a history of systemic lymphoma, which she had hidden from us and also from her husband. So bilateral lacrimal gland masses, you should think of lymphomas, leukemia, sarcoidosis, Sjogren's disease, tuberculosis, vaginas, or more innocuously orbital inflammatory disease as we had seen earlier. This was again a rare case of orbital lacrimal sac lymphomas, but the patient has absconded after the CT. Again, bilateral lacrimal gland masses. This patient really stumped us. You can see the intraoperative appearance of follicular or papillary appearance of the lacrimal gland, and histopathology showed amorphous acellular eosinophilic material which stained with Congo red, but there were lots of lymphocytic infiltration. And I like the slide very much. This is a picture of the amyloidosis, picture of apple green birefringence. The lacrimal gland was positive for CD20 lymphocytes and CD138 plasma cells, and it was diagnosed as a low-grade B-cell lymphoma with extensive amyloid deposition. And the bone marrow biopsy also showed low-grade B-cell lymphoma with plasma cells in the leukemic phase. This was all these investigations were done at Rajagiri Hospital, where Dr. Leda, pathologist, and Dr. Sanju Syriac, the oncologist. So a diagnosis of extranodal margin zone lymphoma was made with atypical lymphocytes in the blood, bone marrow infiltration, and the presence of abdominal lymph nodes also. And all his orbital lesions disappeared. I had removed, debulked most of them, but they disappeared with chemotherapy. So this was a case of lacrimal gland amyloidosis, which in itself is very rare. Only 18 cases were reported till 2014. And but a case was reported in with both amyloidosis and bone developing in an orbital lymphoma. Sarah Copeland in 2016 demonstrated, he reported a case of amyloidosis with lymphoma in the lacrimal gland. And she had said that the pathologist should be aware of this association because bulky amyloid deposits may mask an underlying lymphoid neoplasm. So coming to lacrimal gland tumors, this was a lacrimal patient with hypotropia and axial proptosis. and there was a rounded tumor in the lacrimal gland fossa, which was remaining in the lacrimal gland fossa, and there was bone excavation, and it turned out to be a lacrimal gland pleomorphic adenoma. This was again a mass in the lacrimal gland fossa, which was extending beyond the midline and below the lateral pacral ligament, and there was extensive bone excavation and erosion. This was an adenoid cystic carcinoma. This was again a patient who presented with a mild ptosis and a proptosis, but CT scan showed it was only the tip of the iceberg. There was an extensive tumor with bone destruction extending to the temporal fossa. This was again an adenoid cystic carcinoma, which was biopsied, and then it was treated later by Dr. Santosh, who gave a high dose chemo reduction, and then an en bloc excision and extensive external beam radiotherapy was done for this patient. This was again another tumor which stumped us. Hello, is there any other disturbance? Okay. This was the patient presented with recurrent attacks of pain and redness in the lacrimal gland area. There was a lacrimal fossa mass with cystic, which is a cystic lesion, and there was bone excavation, but there was no bone erosion. The histopathology showed sheets of abundant eosinophilic cytoplasm, and the pathologist did diagnosis of oncocytoma, lacrimal gland oncocytoma. So we sent them to an oncologist for to rule out any systemic lesions. So they found a parathyroid oncocytoma, which was FNAC'd under ultrasound guided biopsy, FNAC, and whole body CT scan showed renal enlargement, and we thought it would be a renal oncocytoma, but it was a renal clear cell carcinoma, totally unrelated. That is where the orbit usually it stumps us. Okay, now coming to vascular tumors. This was a axial proptosis which increased during pregnancy. There was a well-defined homogeneous lesion which was not well enhancing very well with contrast. This was a on excision, it was a cavernous hemangioma. This was again a huge mass which was seen in a non-resident Keralite. I approached it through a lid crease incision, a lid splitting orbitotomy earlier, and it was a vascular lesion with pericytes, which is a hemangiopericytoma. Any recent sudden onset of bleeding or subconjunctival hemorrhage or proptosis, sudden proptosis in a child, you should suspect lymphangioma. The CT scan showed multicystic lesion with fluid levels, and they do quite well with injection bleomycin. 1 or 2 injections may have to be repeated. A lesion with swelling which appears some days after trauma with discharge of pus into the conjunctiva or from the lesion, you should suspect a wooden foreign body, and you should follow the path of the pus because it's seen only as a small air pocket in the CT or in the MRI. Follow the path of the pus, it will lead you to the foreign body. This was a lesion. This girl was treated as a ophthalmos, and you can see the the left side of the face was hypertrophic, and the CT was done, which showed a hypoplasia of the sphenoid vein. Caffeolae spots were seen. This was a neurofibromatosis, and there was a small pulsatile proptosis also. So this patient with a long-standing proptosis and a small convergent squint and hypotropia. So what is the CT finding? This case also stumped us. This was just a posterior staphyloma. Thank you. Thank you to the pathologists and the microbiologists, without whom we would never have come to all these diagnoses.
Thank you, Dr. Annie, Thank you, Annie ma'am, for sharing your experiences. And because of short of time, only one question. I know you have a lot of experiences with parasitic masses. So what is the clinical presentation, and is there any role of medical management in parasitic masses?
We start Bendex or albendazole treatment, and along with steroids. I don't know if steroids alone bring up the resolution of the mass, or is it the patient's immunity which is because even if you don't give anything, sometimes the mass resolves. But anyway, we start albendazole because it doesn't have any side effects. So we start albendazole for 1 month, and as also antibiotics are also set to resolve the lesion, the mass lesion. But after 2 months, anyway, I think the mass resolves by itself, even with or without our help. But if you don't want to give the patient steroids, the patient may develop recurrent attacks of edema, and that can frighten the patient. Either you can remove the lesion by excision biopsy, or you can start him on steroids and low dose steroids and continue for 1 month. The lesion resolves anyway.
Okay, madam. We will move on to the next talk, and if you have any questions, we will ask you later. And I request Dr. Hema to introduce the next speaker.
Next, we have Dr. Kirti Koka, who is a consultant and in charge of fellowship training program at Shankara Nethralaya, Chennai. She has completed her MBBS from Kilpauk Medical College and ophthalmology residency from Stanley Medical College. She completed her long-term fellowship from Shankara Nethralaya, Chennai, and done her observership under Dr. Bhupendra C.K. Patel at Moran Eye Center and Dr. Bida Ismaili at MD Anderson Cancer Center, Houston. Her areas of interest are orbit and adnexal oncology. Over to you, ma'am. Dr. Kirti, ma'am.
Yeah, I've just unmuted. Sorry. Thank you so much for the kind introduction. Thank you, Dr. Anju and the Comtrust team for giving me this opportunity to present. So my topic today is surgical approaches to the orbit. And like we know, the surgical approaches, like anything else, has been evolving with time. From the earlier larger, more visible incisions, we have now moved on to smaller incisions, scarless surgeries, and in the recent times to even image-guided surgery, which helps in better localization of the lesions. Now, in order to have a good surgical approach, we need to have a very good knowledge about the anatomy of the orbital bones, all the structures of the orbit, the contents, and the relationship to each other. Because this is very important to decide what approach we're going to choose. We also need to know about the various surgical spaces. In brief, you know that we have the subperiosteal space, which is a narrow space between the bone and the periorbita. There's a tenon space between the globe and the tenon's capsule. And then you have the extraconal and the intraconal space, which are separated by the extraocular muscles and the intermuscular septum. Most often, the lesions tend to lie in one particular space, but sometimes they can even traverse from one space to the other, requiring larger or more extensive approaches in order to gain better visibility to the space. Before trying to decide the approach, it is very important to do a thorough evaluation of the patient, clinically, imaging, and a proper anesthetic workup before taking up the patient for any surgery. So any surgery, the approach should be such that it gives a very good exposure to the surgical field, but at the same time avoiding damage or any damage to the adjacent vital structures. Though in any kind of tumor, we are not thinking about cosmesis as the end goal, we still need to try and make our incisions such that they are not very visible. So we get not only a good functional outcome, but also a good cosmetic outcome in the end. The choice of your incision is going to depend on where the tumor is located, the size of the lesion, and also very importantly on what your main goal of the particular surgery is. Are you just trying to take a small sample to get a diagnosis like an incision biopsy, or is the entire tumor going to be removed in toto? So the approaches can be divided as those which lie anterior to the equator are generally approached by an anterior orbitotomy. Those posterior to the equator and medial to the nerve can be approached by a medial orbitotomy. Lateral to the optic nerve can be approached by a lateral orbitotomy. Whereas those in very posterior located near the apex generally are very difficult to approach by these by the anterior or the lateral orbitotomy. Then they are approached by the transcranial route. And those which are located medially at the apex can also be approached by transnasal endoscopic approach. So the anterior orbitotomy can again be divided into superior and inferior, which are then further divided into transcutaneous, where we go through the eyelid skin, or the transconjunctival, which is going to do the conjunctiva. The lateral orbitotomy approach is very good for lesions in the supratemporal orbit, especially lacrimal gland tumors, whereas the medial orbitotomy approach is very good for sac tumors and any lesion in the medial extra and intraconal space. We shall now discuss each of these approaches in detail. So the anterior approach most commonly is the lid crease approach, and the other approach is going to be a subbrow approach. Another technique is where an incision is made directly in the brow, but the problem is it leads to localized alopecia and hence is avoided. The subbrow approach is also a very good approach for lesions. However, it can also produce a visible scar if proper closure is not done. The lid crease approach is generally very preferred nowadays. Here is a case you can see of an external angular dermoid. The lesion is very well visible and easily palpated. This can be approached by two ways. One, we could have done the subbrow approach, or one is the direct lid crease approach. We chose the direct lid crease approach, as you can see. Here is a short video. So the skin is incised. After incision of the skin, the orbicularis dissection is then done. You then palpate to find where the mass is. Once the mass is localized, the septum is going to be opened up in that region. Then blunt dissection is done carefully to avoid rupture of the lesion, and the mass is then separated from all the surrounding structures and removed in toto. The incision is then closed by lid sutures. It should be taken to note here that the septum should never be closed, because then it can produce retractions. Okay. Here is another case where you can see there is a subperiosteal hematoma here. So in this patient, you can see we have taken the lid crease approach, and rather than opening the septum, you can dissect upward in the suborbicularis plane. So here we're not going to open the septum, but dissect upward in the suborbicularis plane to reach the orbital rim. From here, you get a direct access to the subperiosteal space, and the hematoma can then be evacuated. Here is another child with a very large superior lesion, which is extending almost up to the apex. Again, here, very good exposure could be obtained by just an upper lid crease incision. The lid crease incision again to the periosteum, and then either you can elevate the entire periosteum to reach the mass, but if the mass is very well palpable, you can open the septum and then dissect and separate the mass from the surrounding structures, and the entire mass can then be removed in toto. Here the mass was not removed toto, but it was removed in piecemeal. Not always do we need to use a lid crease incision. Here is a case of lymphoma, which is one of the most common malignant tumors in adults. Here you have the lymphoma along the superior extraconal space. But in a lymphoma, the main aim is just to get a small sample for biopsy and not to remove the entire lesion. So here, rather than approaching the mass by lid crease approach, very often you also notice that in lymphomas they have a salmon patch where there is extension into the subtenon space. So here the incision can be directly made on the conjunctiva, the superior conjunctiva, and the sample can then be taken for biopsy. Similar approach can also be used by a superior fornicial incision can be done to reach the superior extraconal space and take a sample for biopsy. Now moving on to the inferior approach. So the inferior approach can be either the transcutaneous approach, which is going to be the subciliary, or the lower lid crease approach, or sometimes an approach which is a direct rim incision can also be made. And the other kind, which is generally the one which most commonly we nowadays use over the transcutaneous, is going to be the inferior fornicial approach. So the inferior fornicial approach here, you're going to make an incision in the inferior fornix. This can also be combined with the lateral canthotomy, cantholysis, and also an extension to the transcaruncular area to get wide exposure of the medial, the inferior, and the lateral extraconal space. So thus it helps to remove large lesions located in the inferior orbit. This is called the swinging eyelid approach, and this also plays a very important role for fracture repairs. So this way we can avoid the subciliary approach. So when we are approaching any of the inferior spaces, the subciliary approach Generally, the incision is made 2 millimeters below the lid margin from the ciliary line. Then you reach the suborbicularis plane and do a dissection in the suborbic plane to reach the rim. From here, you can enter the periosteum can be elevated and you can then reach the inferior extracorneal space. The direct rim approach gives direct access to the rim. But the main disadvantage with both these techniques is that it leaves a visible scar and can also produce a cicatricial ectropion. Hence, to avoid this, nowadays most surgeons prefer the transconjunctival approach, which gives very good access to the entire inferior extracorneal space and helps to avoid the complications of ectropion and a visible scar. So the transconjunctival approach also here, the incision is generally made about few millimeters below the tarsus, lower border of the tarsus, and then dissection is done to reach the suborbicularis preseptal plane. So here what happens is when we dissect in the suborbicularis plane, you can avoid the fat coming into your pathway while operating. From here, the periosteum can be elevated and then you can enter the inferior extracorneal space. However, if lesion is lying in the extracorneal fat, a direct fornicial incision can be made to reach the extracorneal compartment. Here is a male patient who has a lesion in the infralateral lesion. It could be easily palpated from the skin side, and you can see on imaging it is a very well-defined lesion located in the anterior orbit. So the main goal of our surgery here is to remove the mass in toto. So for him, we chose an inferior inferior fornicial approach, and the lesion was removed in toto. So here you can see the inferior fornix is incised. The conjunctiva is then opened by blunt dissection. The mass is then localized. Blunt dissection is done all around the mass in every plane in order to separate it from the surrounding structures. Here we use Freer's periosteal elevator to gently separate the tissue from the surrounding structures. Here you can see the lesion is now removed. The conjunctiva can either be closed with sutures, but I generally prefer to not put any sutures in the conjunctiva and just leave it without sutures. Just oppose the edges and it generally heals very well without any kind of symboliferon or any kind of entropion post-procedure. Since this was a very well localized lesion in the anterior orbit, a canthotomy was not made. However, here you see that this is a very large lesion located in the inferior space, intracorneal space. And to this, we approach the lesion with a swinging eyelid incision transformation, which is extending a little bit into the transcaruncular region in order to get very good exposure to remove the lesion in toto. The lateral approach is going to be used for lesions which are large, involving the lacrimal gland region. Here, the stellate right incision was what was used previously. Now we have moved on to the lateral lid crease approach, and also you have the lateral canthotomy incision approach. Okay, so all of this gives very good surgical exposure to the lateral orbit, especially the supratemporal rim, and in fact with dissection you can even get access a little bit to the infratemporal orbit. So the lateral orbitotomy is of two types, one without bone removal and one with bone removal, where a rim of lateral orbital, a small window of the lateral orbital rim is removed, which gives better exposure to the lateral extracorneal space in order to remove large lesions which are located posterior to the equator. So this is a lesion which is involving the lacrimal gland region. Like you can see, it's a very well-defined large lesion extending from the anterior to almost the middle one-third of the orbit. This on imaging was indicative of a pleomorphic adenoma. So here the lateral lid crease, extended lateral lid crease approach was taken, which gave access to the entire lateral extracorneal space. Bone was not removed and the mass could then be removed in toto. However, here when you have a very large lesion like an adenoid cystic carcinoma, where there is going to be capsular breach, there's involvement of the bone, then you do a lateral approach with bone removal to get better exposure and complete removal of the mass. Dr. Honavar usually says avoid the lid crease, but do a direct approach in order to prevent seeding of the lesion in the because here you're going to create a skin muscle flap, and that can lead to seeding of the lesion in the skin later, and patients come with a recurrence much later. So rather do a direct approach like the stellate right incision. This lateral approach is also very good for patients with thyroid orbitotomy, where you need to do a cosmetic decompression, where you're going to do a cosmetic decompression of bone removal as well as fat removal. So the lateral approach gives access all to the supralateral, the lateral and the inferior basin for thinning of the bone. This is a short video of the lateral orbitotomy with bone removal. After skin incision is made, dissection is done. The orbicularis is opened and then the supralateral rim is approached. Once the supralateral rim is approached, the periosteum is then incised 2 millimeters from the rim, and the periosteum is then elevated along the lateral rim as well as the interior orbit. The bone is then sawed and then the bone is removed with a punch. Once the bone is removed, the periorbita can then be incised and the tumor can then be removed easily. The bone can be replaced. It can be replaced in place either with sutures or with glue. The periorbita is then closed and the skin is closed. The skin and orbicularis is then closed. If you want to avoid a lid crease approach, recently the other technique that can be done along with the lateral canthotomy is using a transconjunctival approach even for large lesions involving the lateral orbit. Here a transformational incision is made in the lateral fornix, and this is combined with the lateral canthotomy approach, and this gives very good access to the lateral extracorneal space and the lesion then can be removed. The medial approach is generally preferred for lesions in the medial orbit. It can involve the vertical lid split, the medial lid crease approach, or the modified Lynch incision. The vertical lid split was earlier used, but however nowadays it is not much used because we get very good access with just the lid crease approach or even a transcaruncular approach which is extending into the superior fornix. So if you want to avoid the lid crease, the other approaches which are very well used these days are the transcaruncular and the transconjunctival approach, perilimbal approach. So this is a case of a frontal osteoma. As you can see, this patient presented with a fullness in the medial orbit. So either a subbrow or a modified Lynch incision could be used to remove this lesion. However, we chose a lid crease approach for this patient and we got good exposure and the osteoma was then removed. External angular dermoids are very common in this region, internal angular dermoids, and they can also be approached by a lid crease approach and complete removal of the lesion. And as you can see, post-operatively, the patient is doing well with no visible scar. For lesions involving the lacrimal sac region, you can use the Lynch incision here. The Lynch incision is generally made directly over the lesion. The skin and orbicularis are then opened and blunt dissection is done to remove the mass in toto. The Lynch incision is generally a really good approach to reach even the medial extracorneal space. Post opening of the skin and the orbicularis, the periosteum can directly be incised and the entire periosteum along with the sac can then be elevated to reach the medial extracorneal space. However, the main problem with this incision is that it tends to produce a webbed scar, which is generally cosmetically not acceptable to the patient. In order to avoid this and still remove large lesions in the medial extracorneal or intracorneal space, nowadays the preferred approach by most surgeons is the transcaruncular approach. The transcaruncular approach gives a very good access to any lesion which is located posterior to the posterior lacrimal crust. So once you open up once you do the transcaruncular approach, you can either reach directly to the posterior lacrimal crest region and then enter the medial extracorneal space. But in lesions which are intracorneal, you might need to disinsert the medial rectus muscle in order to get good access to the medial medial intracorneal space. Like as you see, the patient here, she's doing very well post-operatively, post-removal of this large cavernous hemangioma, and there is no visible scar. This is a small video of a medial approach, transcaruncular approach with disinsertion of the medial rectus muscle. Here, after opening the conjunctiva, the tenons is open. Blunt dissection is then done. The medial rectus muscle is then hooked once you enter the medial space. The medial rectus is hooked and then the medial rectus muscle is disinserted. Using malleable retractors and using the hand over hand technique, dissection is then done into the medial space. In case of large tumors, you can also combine it with a lateral canthotomy so that it does not provide any tension on the nerve, and it also gives you a good exposure. Blunt dissection is done and the mass is then removed. You should be careful to look for any vascular pedicle, and that has to be cauterized, otherwise it causes bleeding. The transcarentular approach is then, incision is then closed with vital sutures, and the canthotomy is also closed. The transnasal approach is generally preferred for lesions in the medial subperiosteal space like an abscess, where it can be approached completely by the endoscopic approach, and the abscess can be drained. For lesions in the sac region, the nasolacrimal duct, and lesions in the nasal cavity, the transnasal approach is very good and generally done along with our ENT colleagues. Another place where the transnasal approach can be used is for medial wall fractures. So in medial wall fractures, this can be combined by an external as well as a transnasal approach. This gives good exposure of the posterior part of the fracture, posterior and superior edge of the fracture, and helps in easy placement of the implant. For lesions which are located in the frontoethmoid lesions, such as any foreign bodies or any masses, the endoscopic approach is very useful and helps to remove the lesion completely. The transcranial approach, I'm not going to go into details regarding the transcranial, but it is generally used for lesions which are located in the orbital apex, the superior orbital fissure, the optic canal, or the cavernous sinus region. And this is generally done by our neurosurgical colleagues who approach it by the transcoronal approach to remove the lesion completely. Now the trend has started moving towards image-guided surgeries, where you can use CT-guided, MR-guided, or navigation-guided techniques to help localize lesions, to place implants while doing surgery to get better surgical outcomes. Thus, the take-home message would be, in any surgical approach to the orbit, it is very important to have a good knowledge of your anatomy. There's no particular technique which fits every case, so you have to have a case-based approach. Look at each case properly. An individualistic approach is very important. Make sure that your surgical field dissection is such that you have a good visualization of the entire field so you can remove the mass completely, and gentle handling of tissues is very important to prevent any scarring in the post-operative period. Sometimes for large lesions, a multidisciplinary approach with ENT and neurosurgeons can, at the same time, can help reduce the number of surgical procedures needed for the patient. My acknowledgements. Thank you.
Thank you, Dr. Kirti. That was an elaborate coverage of the topic and nice videos. So for the benefit of the postgraduates, I have a question. Like, when do you consider an incision biopsy? When you will do an incision biopsy, and what are the precautions you have to take before doing an incision biopsy? Because some of the representative samples may not be there in the sample. So what all things you have to look for? I mean, yeah.
So when you have a lesion which is, say, ill-defined, not a very well-defined lesion, or your imaging is very well suggestive of probably a lymphoma, or you have a lesion like Dr. Annie had shown, you have lesions of the lacrimal gland bilateral, you're suspecting inflammatory pathology, but you're not sure, your blood workup does not add up, and you need a small sample, so, or a tuberculous lesion. So these are all cases where you're going to probably plan for an incision biopsy and not an excision biopsy. So incision biopsy, it is again important. So you to study the scans first properly to see how big the lesion is, where it is extending. Dr. Honavar always says, so you know, the superficial part of the lesion generally is going to be fibrosis or it's just inflammatory cells, and the true pathology probably lies within the lesion. So it's always important to take multiple samples. A layered approach is what he says. So you take lesion from the outer part of the lesion, then you take a lesion from the middle part and also the posterior part. So that way you have a representative sample from each area, so you don't miss the diagnosis. This is especially so for inflammatory lesions, tuberculous lesions, where the main necrosis is probably going to be seen in the center and not in the periphery. Yeah, so I think that would be the approach for an incision biopsy. Yeah.
Thank you, Dr. Kirti. And it's time to move on to the next session. Our next speaker is none other than Dr. Santosh Honavar. And he needs no introduction, but it is my duty to introduce him. He's the Director of Department of Ocular Oncology and Oculoplasty at the Center of Sight, Director of Department of National Retinoblastoma Foundation, and the editor of Indian Journal of Ophthalmology. He's the recipient of numerous awards: Pfizer National Award, Colonel Rangachari Gold Medal Award, Best Show Award in American Academy of Ophthalmology, Dr. Shivareddy Award, and prestigious Shanti Swarup Bhatnagar Award by Government of India, to name a few. So he will be speaking on thyroid eye disease current concept. Welcome, sir.
Thank you, Anne. Can I share my screen? Congratulate Comtrust and KSOS for this wonderful initiative and for asking me to speak on thyroid eye disease. Am I audible?
Yes, better.
The thyroid is considered to be a house on fire. There is a lot of inflammation. And there are two things that you look at in a given case of thyroid eye disease. Of course, Rundle's curve is very famous, but generally what you need to look at is activity, which is a measure of inflammation, and severity, which is a measure of functional or cosmetic deficit. Both of these may coexist, may not coexist. So when you look at activity, you have to measure it, because thyroid eye disease is a chronic disease, and only when you measure and document and quantify the findings would you be able to follow up these patients and say that, okay, they are doing well, they're stable, or they're worsening. If you use UGOGO classification, you can score them on 7 points, of which most of these are inflammation. You can see that pain, spontaneous retrobulbar of more than 4 weeks duration, pain on eye movement of more than 4 weeks duration, redness of the eyelid, redness of the conjunctiva more than 1 quadrant, swelling of the eyelid, swelling of the conjunctiva, which is chemosis or caruncular swelling. All these get 1 point each. And over a period of time, can you measure impairment of function, which is worsening of proptosis of more than 2 millimeter over 3 months, worsening of extraocular motility restriction of more than 5 degree over 3 months, and worsening of visual acuity of more than 1 line over 3 months. These are on follow-up. So if you have a patient coming to you for the first time, you can measure them on a score of 7. And if a patient is on follow-up, they're measured on a score of 10, and more than 3 of 7 or more than 4 of 10 is considered signs of activity. Now, severity is further categorized as mild and moderate to severe and vision threatening. Mild lid retraction, mild soft tissue involvement, exophthalmos of less than 3 millimeter, transient or no diplopia, or corneal exposure responsive to lubricants are considered mild. Whereas moderate to severe is, of course, there is no imminent threat to vision, but the patient has exophthalmos of more than 3 millimeter, inconstant or constant diplopia in functional positions of gaze. Whatever is the functional positions of gaze, in the sense that if a patient is a builder or an architect, for example, he might have to gaze up the building, and that is his functional position of gaze. Whereas for somebody who is on a desk job, primary and down gaze would be the functional positions of gaze. Somebody who wants to drive, primary position would be the functional position of gaze. So whatever is the functional position for that particular patient, if the patient has inconstant or constant diplopia, that is considered relevant. Moderate to severe soft tissue involvement and eyelid retraction of more than 2 millimeter. Now, very severe or sight-threatening thyroid eye disease is when there is imminent threat to vision, either because of dysthyroid optic neuropathy or corneal breakdown. Now, when you talk about management, if a patient has mild, moderate, or severe disease, but it is inactive in terms of severity, but it is inactive for more than 6 months, then you can consider surgical intervention if they need it. But conservative management would include symptomatic solutions, lifestyle modification, quitting smoking is very important, achieve a stable euthyroid status. Selenium is controversial. Then you go for sequential surgery if the patient has been inactive for more than 6 months. Timing is the key here. There is no controversy about the management. But the role of primary medical management comes in if a patient has active disease. Even if the patient has mild active disease but with impaired quality of life, you may consider the patient for medical management, definitely for moderate to severe and sight-threatening diseases, which translate to symptomatic exophthalmos disabling diplopia in primary or functional positions of gaze, moderate to severe soft tissue signs, corneal exposure that is not responding to lubricants, compressive optic neuropathy, where also in patients who have imminent prophylaxis as an imminent prophylaxis for radioiodine treatment. If the patient is up for radioiodine treatment as a prophylactic measure, you may start on steroids. Now, this slide shows the immediate relief and rebound with various modes of treatment. If you give oral steroids alone in these patients, 30% of them respond on a constant basis, and 70% of them may have reactivation after you taper off oral steroids. If it is intravenous steroids, intravenous methylprednisolone pulse therapy, then 70% may not rebound and 30% may rebound. Of course, all this depends on their thyroid status, their lifestyle, and also the age of the patient and the gender of the patient to a great extent. If you have the patient on both intravenous steroids and immunomodulators, possibly you get the best remission rate. 80% remain in remission and 20% may still rebound. Of course, use of immunobiologicals, radiation, and intraorbital steroids are all in addition to this. Now, we use what is called a low-dose intravenous methylprednisolone protocol, where the total dose that is given is not more than 4 grams. So initially in the first pulse, which we call the induction pulse, we use 500 milligram for 3 days, that is 1.5 grams. And every 3 weekly, the patient gets 500 milligrams. So totally, the patient receives 4 grams. At pulse 4, we evaluate the patient for residual activity. And if you find that the patient still has significant residual activity, then you would bring in immunomodulators at this stage, not to wait until you have completed the pulse of oral steroids. The reason is because immunomodulators will take time to work. They take 4 to 6 or even more number of days to start working. So unless you have a very smooth handshake between the IV methylprednisolone, which is going to be stopped at pulse 6, and immunomodulation, the patient may have an abrupt rebound because the patient is not on any active forms of therapy if you were to start at the end of IVMP. So generally, we start immunomodulation between pulse 4 and pulse 5. Now, there are, for immunomodulation, there are medications. There are many drugs, but either mycophenolate mofetil or azathioprine are the preferred drugs. Cyclosporine is used by some groups, and also methotrexate is used by some groups, but we prefer mycophenolate mofetil or azathioprine, which have a very good safety profile. These work as steroid sparing agents, and you can continue to give them for 6 months or more. So how do these patients respond? We look at the response in terms of reduction in activity, reduction in extraocular motility restriction, and also exophthalmos. So if you look at exophthalmos, you can see that many of these patients respond very well to intravenous methylprednisolone. This patient, you can see that his exophthalmos has evidently reduced, but not to the extent that we are happy. Of course, the patient may still need surgery, but there is a reduction in exophthalmos. This is a patient pre-treatment and post-treatment with azathioprine as well. You can see reduction in exophthalmos, which is quite significant. This is one more patient where both activity and amount of exophthalmos that he has reduced. You can see post-treatment, that is the appearance, whereas this was the same patient pre-treatment. So how many patients do we find reduction in exophthalmos, and to what extent? I would say about 60% of patients have remission from exophthalmos, and mean improvement in exophthalmos is about 2.7 millimeter. The range is very huge, 1 to 9 millimeter. So about 2/3, you can say, have a reasonable response to reduction in exophthalmos. Now, what happens to ocular motility and diplopia? You can see this patient has restriction in ocular motility. You can see that the left eye is hardly moving up. Following treatment, you can see that the patient has, of course, he has reduction in lid retraction as well, which is again a positive effect, but his ocular motility has improved and he is rid of diplopia. You can see that the left eye is moving up fairly well, and he has no diplopia currently in primary position. This patient has got an excellent response. You can see she had hypertropia initially, and then the eye has settled down now after immunomodulation, and she also has minimal diplopia or no diplopia. This patient also, you can see that there is restriction in ocular motility in upgaze, which has resulting in resolution in diplopia. The reason is very evident. You can see that the inferior rectus muscle, which was so bulky, has come down in size, and her inflammation in the muscle has gone down. This is one more example of a patient where there is minimal movement of the right eye in down gaze, and following immunomodulation, the patient has improved in motility, and he used mycophenolate mofetil along with intravenous methylprednisolone. And even extraocular motility restriction and diplopia improve in about 2/3 of patients. I would say about 60% of patients will have improvement in extraocular motility, which is reasonable. Now, remission in disease activity happens in a majority of patients with immunomodulation. You can see in about 90% of patients, we have remission in disease activity, which is the primary goal of treatment anyway. So your goal of treatment is to make them inactive or less active, but at the same time, you also get benefit in terms of reduction in exophthalmos and also improvement in ocular motility. Clinical activity score drops tremendously. You can see from initial 7.1 mean, we have a drop to 1.2, which is extremely good. So compared to other studies, we find that combining intravenous methylprednisolone low dose, higher dose really don't actually help these patients unless you're dealing with this thyroid optic neuropathy. Combining it with immunomodulators actually gets you much better response and minimal side effects. Now, if a patient has sight-threatening thyroid eye disease with imminent threat to vision, then you go for a high-dose intravenous methylprednisolone. If a patient does not have improvement within 2 weeks, or if a patient is worsening even earlier than 2 weeks, you can go for a transnasal posterior medial decompression for this thyroid optic neuropathy, or for patient who has a corneal breakdown, you can go for 2-wall or 3-wall orbital decompression if that is really required. Patient is not responding to IVMP. This patient responded very well. This is how we presented. And you can see the thickness of extraocular muscle is tremendously increased, and he settled down very, very well with a large amount of reduction in chemosis, and also his exophthalmos has reduced, his activity has come down, all with conservative treatment. He did not need surgery at this point in time. These are the patients who had choroidal folds and has also settled down. What are the newer modalities of management? Newer modalities are mainly using immunobiologicals. We have a spectrum of drugs which target each of the sites that can cause activity. But what is currently used is rituximab in India. What has come new is teprotumumab, which is currently not available in our country, but can be used when it becomes available. So these are the drugs that are recommended. But what is used, what really works fairly well is rituximab, and we use it only in patients who are resistant to standard immunomodulation. This was one such patient who had refractory strabismus following IVMP. Her pressures used to remain high, and azathioprine as well. She settled down with a couple of cycles of rituximab. This was a young individual who had a refractory thyroid eye disease, always inflamed, always painful, and he had refractory diplopia. And following rituximab, he settled down well. The dose of rituximab that we use is 500 milligram, repeated twice over 2 weeks. That is one set, and after that we give a gap of 6 weeks and repeat the same. So we give a set of 4 injections split into 2 with 6 weeks gap. Teprotumumab, as I said, is one drug which can show profound effect on proptosis reduction. So this may eliminate the need for decompression in a finite number of patients. I wouldn't say all of them. So this works very well in thyroid eye disease, causes remission in activity, and also improves ocular motility, and the major reduction is in proptosis or exophthalmos. Now coming to eyelid retraction. In a patient who's inactive, after you've done everything, lid is the last, and finally, if you want to look at what you do for eyelid retraction, if you look at the literature, you get confused because levator recession has been studied so extensively. There are so many publications. When there are so many publications for a very small or minor surgery, you get worried as to why is it happening, because everyone is finding different results and the results are not constant. This patient, I was pretty happy with the results, but the patient was not happy because there is a lid crease abnormality. Lid crease goes higher with levator recession. This patient has a flatter lid and they keep cribbing about it. So what is different that we can do for eyelid retraction is intra-LPS steroid injection, either in active phase where it works very, very well, or in inactive phase where it works moderately well. You can inject transconjunctivally Translone 10 milligram. This patient needed 2 injections. You can see that a lid retraction has settled on. This patient also needed 2 injections over 6 weeks, and he also has reasonable relief from lid retraction. This patient settled down very well. Now we have started using it for even extraocular motility restriction. This patient had a bulky inferior rectus in the left eye and her eye was not moving. After completing her immunomodulation, we injected around the inferior rectus and the medial rectus muscle, and her movement did improve over a period of time. This is the algorithm that we use for thyroid eye disease. If a patient has mild severity, of course, be conservative and then treat only the functional problems or cosmetic problems. If a patient has moderate to severe activity, then we give low dose intravenous methylprednisolone pulse therapy. If a patient has good response, nothing more. If a patient has suboptimal response, then you go for immunomodulation. If a patient has a sight-threatening disease, then you start with high-dose intravenous methylprednisolone. If a patient does not respond and goes on worsening, then you can do an early orbital decompression, ideally transnasal deep medial wall decompression. For maintenance, you use systemic immunosuppressants or immunobiologicals. And then finally, when the patient becomes inactive, you go for sequential surgery. Now, the reason why you do all this is summed up in this slide. If you take out the entire published literature, most of it, and then look at it very critically and put the numbers together, I don't say that this is a very good analysis of data, but I just put the numbers together. This is not a kind of meta-analysis. But when you look at this, if a patient has had primary medical treatment and has been inactive at the time of surgery, that is decompression, etc., then the chance of rebound is 2 to 15%. If the patient has had primary medical treatment and has activity at the time of surgery, but has had primary medical treatment, then the chance of rebound is still low at 8 to 20%. If a patient has inactive disease and has primary surgery, that is fine. Rebound rate is still reasonably low, 4 to 22%. But if a patient has active disease at primary surgery, then you have a huge rebound rate ranging from 24 to 40%. So this you can possibly reduce to a reasonable level by treating the patients medically and then doing orbital decompression. I don't have time to talk about orbital decompression much, but basically our surgery is split into 3 levels. One is decompression, followed by eye muscle surgery, extraocular muscle surgery, and finally lid. Lid is always the last. And when we talk about orbital decompression, we talk about bone removal, orbital decompression, and fat removal, orbital decompression. Just the process of expanding the orbit to create space for the enlarged extraocular muscles and the orbital soft tissue. This was a very nice article for any beginner surgeon to read up how to approach the deep lateral decompression in 3 components. Show you a very brief video clip showing deep lateral orbitotomy. I'll skip the initial part. We tag the lateral rectus and superior rectus muscle and then make a lateral lid crease incision. You don't have to go to the entire extent of the lid with a slight lateral flare. Then the orbicularis is dissected to reach the superior and lateral orbital margins. Then exposure of the periosteum followed by periosteal incision, which extends the entire span of the orbit that you want to decompress. That means lateral 2/3 and the inferior, the lateral 2/3 and the superior. Periosteal dissection. Periosteum in thyroid eye disease is quite adherent to the bone, so you have to be very gentle not to have premature rupture of the periosteum and fat prolapse, etc. Dissection of the periosteum meticulously. So your aim is to expose the entire lateral wall deep enough. Then you can pass tag sutures, forosilk for better exposure. That is the lacrimal keyhole, keyhole through which you see the room, that is lateral orbital wall very clearly. So once you've taken out the overhanging lateral orbital, supralateral orbital margin, you can start burying deep and you preserve the lateral orbital rim and go full thickness below the rim. And as deep as possible, of course, you burr the sphenoid until you're very close to dura, not to expose the dura if possible, and also go on infero-temporally to drill the zygoma. So this is done using a high-speed burr with or without image guidance, if you wish. And you polish out the rim, not to leave it sharp. And finally, make incision in the periorbiter to release the fat that was waiting to come. I would leave a tag of periosteum over the lateral rectus muscle and also be very careful with the lacrimal gland not to injure it. Whatever fat that comes out, you can debulk using lateral orbital margin as the chopping block. Monopolar is safe RF, but you keep looking at the pupil, not to pull on the fat and not to damage any of the extraocular muscles which are already tagged. So be careful with the lacrimal gland and debulk the fat around it. Finally, reposit all the orbital soft tissues and close only, not to close the periorbita, close only the orbicularis and skin. So these patients do fairly well following surgery. These are some of the examples of patients who have undergone deep lateral orbitotomy. It's a fairly cosmetic surgery. There is no evident skin scar because you used a lid crease approach. So in conclusion, I would say that medical management in TED is indicated as primary management in patients who have active disease, patients who have moderate to severe activity, and also those who have threat to vision. We use intravenous methylprednisolone, oral immunomodulation, and rituximab as an escalating protocol, which has reasonable success in control of activity and also exophthalmos and extraocular motility restriction. Biologicals, of course, are knocking at the door and may become the standard of care in the near future. Surgery is performed in an expedited manner for patients who have dysthyroid optic neuropathy that don't respond to medical management. Planned decompression in inactive disease followed by extraocular muscle surgery, and lids are always the last. So the belief in thyroid eye disease is that if you have a house on fire, you douse the fire before you rebuild. So control inflammation before you rebuild the patient's orbit and also rehabilitate the patient cosmetically. Thank you so much.
Thank you, Dr. Santosh. And it was an excellent presentation as usual. And I'm sure that most of the doubts and confusions regarding thyroid eye disease might have been cleared by now. And we have some questions. Dr. Hema?
Yes, sir, we have one question. What's the role of imaging in inactive thyroid eye disease? Do we do imaging?
Yeah, we do imaging as a baseline because patient who is inactive today may become active later. So whenever the patient comes to you for the first time, you always image the patient and document the thickness of the extraocular muscle, the status of the optic nerve, whether it is stretched, because there is something called, I didn't go into the details, but there is something called stretch neuropathy. When the optic nerve becomes stretched because of excessive or bad orbital fat, then the patient can still lose vision without having disc edema, etc. So you look at that and you look at the amount of orbital fat itself and document all these measures for future considerations. And if you're doing orbital decompression anyway, then you would need imaging, definitely.
And in medical management, we have to start immunomodulators as we are coming to the end of IVMP. So what will be the first choice? Which drug you will consider first? And do we need the help of an intern to work up the patient before giving immunomodulators?
If you have the facility of an internist in-house, then that is fine. But if you have to send the patient out just for that, I don't think it's a good idea because it's fairly simple. You have to do a baseline hemoglobin and CBP and liver and renal function test, chest X-ray and ultrasound abdomen, which you would have anyway done for starting IV methylprednisolone. Serum electrolytes are also advised as a baseline. And after that, every 3 weekly, you just repeat HP % and CVP. And at the end of 3 months, you repeat LFT. That is what we do. If a patient has a prior history of tuberculosis, etc., then you have to be very careful. Otherwise, it's a safe drug to start. My primary choice is azathioprine. It is inexpensive and has a very good safety profile. It's been a time-tested drug. It's a choice of drug for me. Mycophenolate mofetil works exactly like azathioprine, slightly different mechanism, as effective, slightly more expensive, and maybe a little more gentler. So if a patient is in the childbearing age group, a male or female, then you would prefer mycophenolate mofetil. That is from the rheumatologists, that's what they believe. And also literature shows that Both the drugs have really no effect on anybody who is in childbearing age group, but mycophenolate is slightly more preferred in patients in that age group. Otherwise, both these drugs work very beautifully.
So for rituximab, we have to wait till we complete the dose of immunomodulators, or we can start before.
It is a stepwise treatment because each step that you climb higher, you have a higher rate of complications. 4-gram IVMP is extremely safe. You generally don't have any issues with 4-gram IVMP. That is your low-dose intravenous methylprednisolone. Beyond that, it's 6 months of azathioprine. Again, that has a good safety profile. So if both these have not worked, then you bring in rituximab. Then the patient will be on double immunomodulation. You can't stop azathioprine and then start rituximab. See, while the patient is on azathioprine, you'll have to still continue azathioprine and start the patient on rituximab. Some of these patients are even on maintenance low-dose steroids as well, oral steroids. So they will be on triple immunomodulation. And COVID times, of course, so you have to be very careful. So rituximab is started at the very end when the patient does not respond to any of the prior 2 measures. And that percentage is very, very low.
There are some patients, there are clinically active but mild disease. So is there any role for oral steroids?
Yes, oral steroids do have a role in patients who have mild activity and have lifestyle issues with that mild activity. So, but then you should realize that oral steroids always, patients who have become inactive on oral steroids tend to have a higher chance of rebounding. So they may need recurrent course of oral steroids, which will have cumulative toxicity and also result in obesity, acne, hirsutism, etc. So if you have to repeat oral steroids, then I would shift to IV methylprednisolone.
Okay. And one more question. In lid retraction, you told it is in the active state, but we see a lot of patients in inactive stage with the lid retraction. So this triamcinolone injection will help in them?
Yes, it helps in about, I would say, about 50 to 60% of patients. We're putting the data together, and initially I started giving it in patients who are on active treatment, IVMP, those patients where it was given after 3rd or 4th pulse, we started giving it. And there we got very good response. But in the patients who have inactive disease, then the response is not so good. In the sense that they will have a relief, say 2 millimeter reduction in lid retraction, which may not be good enough in every patient. So I would say half the patients would respond, and my hard stop is 3 injections. Beyond that, I don't keep injecting. It can have side effects. Some of these patients can have elevated intraocular pressure as well. So the latest is 5-fluorouracil, a guarded low-dose 5-fluorouracil in a fibrotic LPS muscle seems to work, but I'm keeping my fingers crossed. I don't have too many patients on this, so I can't talk about the results yet.
One last question. Can we consider cataract surgery if it is an intumescent hypermature cataract in a clinically active patient? What is your take on that, sir?
Yes, of course, you can do cataract surgery. Clear corneal approach is perfectly all right, but with the proviso that the patient may have a higher, problem, vitreous thrust, so mannitol, giving mannitol, etc., and using a speculum does not put more pressure over the eye. All these measures have to be possibly taken before you do cataract surgery.
Okay. Do we have any questions, Hema?
No, ma'am, we don't have any questions.
Thank you, sir, very much. And we can conclude this session. It was very informative session. I thank all the speakers, and it was very nice to learn from you. And we can conclude this session. Thank you, sir.
Thank you.
Thank you, ma'am. We are moving to the next session.
Next session will be lacrima. I invite the discussants, Dr. Vijayalakshmi, who is the head of refractive surgery and senior phacosurgeon, and Dr. Husna, consultant ophthalmologist, both at Comtrust Eye Hospital. Over to you, madam.
Thank you, Nafia. Am I audible?
Yes.
Yeah. Now we'll move on to the next session, lacrima, all about watering, a topic very much important in our day-to-day practice. Now over to Husna, our consultant of Comtrust Eye Hospital, to introduce the speaker.
Thank you, madam. And welcome everyone to the third session, lacrima. The first talk in this session is on evaluation of epiphora by Dr. Akriti Desai. Dr. Akriti Desai is consultant oculoplastic surgeon at Bombay Municipal Corporation. She completed her MBBS and DNB ophthalmology from Dr. D.Y. Patil Medical College, Mumbai, and fellowship in orbit oculoplasty from Shankar Nethralaya, Chennai. She has worked as consultant at Dr. Agarwal's Eye Hospital, Chennai, and at Ophthalmic Plastic Surgery Services, LV Prasad Eye Institute, Vizag. She has presented in numerous national and international conferences and has many publications in peer-reviewed journals. With this short introduction, I invite Dr. Akriti Desai to deliver her talk.
Thank you so much, Husna. Can I share my screen? Is the screen visible?
Yes, madam.
Sorry. Yeah, so good morning, everyone. I would be talking about epiphora, or in other words, excessive tearing, which is often one of the most common complaints of patients visiting an ophthalmology clinic. The etiology of epiphora presenting to a primary ophthalmologist, though, may be a little different compared to those referred to an oculoplasty clinic. I would like to thank Comtrust and Anju for this meeting dedicated to ophthalmic plastics. The goals of evaluation for epiphora traditionally have been to differentiate between the outflow block or hyperlacrimation. Also includes differentiating anatomical versus functional block, as well as to locate the site of the pathology. So the lacrimal system is divided into a portion of production, distribution, and drainage. So while evaluating watering, we need to look for the ocular surface, the tear film distribution, and the lacrimal drainage. As in any case, you need to take a detailed history, but it becomes more important in the pediatric age group, as you would take the history from the caretaker or the parents. The onset, frequency, and the type of watering should be asked for, whether it is watery, mucoid, mucopurulent, or sometimes even blood-stained. The laterality, any precipitating factors, history of any trauma to the face or nose, previous nasal or lacrimal procedures like a FES or a previous DCR or even a DCT, whether the patient has been on any medications like certain anti-glaucoma medications or anti-neoplastic medication like docetaxel or 5-FU are known to cause punctal stenosis. The frequency and duration of this medication needs also to be noted. Or also if there's any history of obstructive sleep apnea or snoring, which we'll come down to later. There's a Monk scale assessing symptomatically how severe is the epiphora from grade 0 to grade 3. I would just include some common tests for epiphora, although a plethora of tests are available, and it's a very broad topic. So T-BUT is a most common clinical test to assess evaporative dry eye disease, which can lead to reflex hyperlacrimation. It's easy and fast to assess the stability of the tear film. 2% fluorescein in the lower fornix can be instilled. Tear film is examined on the slit lamp with a broad beam cobalt blue filter, and dry spots are noted. The interval between the last blink and the first dry spot is to be noted. T-BUT time of less than 10 seconds is considered as abnormal, and it's indicative of aqueous tear deficiency or meibomian gland disease. I'm pretty sure you all are aware of the ocular surface problems like conjunctivitis, corneal foreign bodies, or even vernal keratoconjunctivitis, or as in the third image, the scleritis, peripheral ulcerative keratitis, epithelial defects. And although not a surface problem, even uveitis patients come to us with complaints of watering. So I will not go into details of this. We also need to look for conjunctivochalasis while examining the anterior segment in a case of watering. Schirmer's test is a common OPD procedure that we perform with a number Fortman-Whatman filter paper. Schirmer's 1 is where it's done without the anesthetic, where the reflex secretion is measured. The filter paper is folded at the tip and inserted in the lower fornix at the junction of lateral 1/3 and medial 2/3. This is assessed after 2 minutes to know how much is the wetting of the paper. Less than 5 millimeter is seen in severe dry eye, 5 to 10 in moderate dry eye disease. Now, an under-recognized cause, I would say, of watering is the tear distribution system. Proper tear film circulation across the ocular surface requires a normal eyelid movement as well, which acts as a windshield wiper moving down from the upper lid to touch the lower lid, facilitating vertical distribution of the tear meniscus. The contraction of the pretarsal and preseptal orbicularis replenishes the dryness of the surface, adds lipids and glycoproteins to the aqueous composition, and also removes debris. In the eyelid examination, we assess the eyelid margin for any pathology of the eyelid margin or Meibomian gland disease. The position of the lower eyelid, like you can see, there's an entropion in the left upper image. The orbicularis tone and how good is the blink. The left lower image is a distraction test, wherein you see how far you can pull the lower eyelid. More than 6 millimeter is distraction test positive. Snapback is where you pinch the lid and pull it back, release it, and see how much time it takes to go back. So these are all tests that we do for entropion or ectropion and to know the laxity of the lower eyelid. Canthal tendon laxity is you pull the medial and the lateral canthal tendon separately. So medial canthal tendon more than 2 millimeters is mild laxity, crossing the limbus is moderate, and up to the pupil or beyond the pupil is severe laxity of the MCT. Likewise, lateral canthal tendon laxity is also noted. One of the signs without palpating is the rounding of the lateral canthal tendon. Ectropion is in this patient leading to keratinization of the ocular surface, which additionally contributes to watering. Likewise, even cicatricial disease like ichthyosis can cause ectropion, everting the eyelid, and poor drainage of the tears. Okay, sorry. The next we come to is punctal evaluation. Punctal stenosis is seen in the right lower image. Beyond that, what you see is punctal canaliculitis in the left lower image, wherein the patient has a pouting punctum with discharge at the punctal area. Other conditions are punctal eversion, wherein there is just medial ectropion, or even centurion syndrome. Centurion syndrome is seen in due to the anterior attachment of the medial canthal tendon, wherein the puncta does not lie in the lacrimal lake. On the right upper image is supernumerary punctum, wherein there are two puncta, although often asymptomatic, and this is a rare condition. It has been reported to present with epiphora as well. Now, coming to facial palsy, it has a multifactorial cause of watering. One is the blink dynamics due to the impaired orbicularis tone. There could be lower eyelid paralytic ectropion as well. Lacrimal pump failure due to poor innervation of the deep head of preseptal orbicularis. Corneal surface exposure keratopathy leading to reflex watering in addition to paralytic ectropion and pump failure. And in the recovery phase, crocodile tears due to aberrant regeneration of the facial nerve. Here we can see the fluorescent dye disappearance test being done, wherein on the left side, it is the dye has been cleared completely, while on the right, it hasn't. So what is FDDT, or fluorescent dye disappearance test as is known as? It's non-invasive, it's quick and inexpensive and convenient. Installation of 2% of fluorescent dye in the conjunctival cul-de-sac. It can be evaluated at 2 minutes, 5 minutes, or 10 minutes. 5 minutes is a better balance between sensitivity and specificity of the test. Longer the time, it becomes more specific but less sensitive. McEwen and Young modification of FDDT grading is grade 0, wherein there is no dye in the conjunctival cul-de-sac. Grade 1, a thin fluorescent marginal strip is seen. Grade 2 is somewhere between grade 1 and grade 3, while grade 3, a wide and bright fluorescent strip is seen in the conjunctival pulvis. Similarly, even thyroid eye disease, a patient presenting with watering, the etiology is multifactorial. It could be the retracted lower eyelid, abnormal gradient for tear migration to puncta, incomplete blink due to widened palpebral fissure, nocturnal lag of ophthalmos, fibrotic inferior rectus can lead to a reduced Bell's phenomena and then further exposure, or conjunctival chemosis, and sometimes when it's very severe, even ulceration and of the corneal surface. So these could be multiple causes of watering in thyroid eye disease patients. Another common entity that is missed is a patient looking like this, which apparently looks normal, but is often overweight, has history of sleeping with face down, history of snoring. Such patients, we can pull up the upper eyelid in the superotemporal direction, and you can see it, the upper eyelid easily everts. They can also have spontaneous eyelid eversion. These patients should be referred to sleep clinics to rule out obstructive sleep apnea condition. So tearing in them is a combination of reflex hypersecretion because of the papillary reaction and exposure of the conjunctiva, poor distribution due to lax eyelid, and stasis due to inactive lacrimal pump as well. They also has lash ptosis, as Dr. Marian already mentioned. So coming down to what we more commonly deal with is the lacrimal drainage. Most common test that is performed for lacrimal drainage in our OPDs is the regurgitation on pressing the lacrimal sac. So this is not always properly done. So where would you press the lacrimal sac? Is in the lacrimal sac fossa. Sometimes it's done more medially over the nasal bone or inferiorly, which will not help us interpret it correctly. And the pressure should be backwards, medially, and upwards to have a correct manner of doing the test. So we assess if the discharge is clear, mucoid, or mucopurulent. Then these three, it's suggestive of NLD obstruction. If there is no regurgitation while pressing on the distended sac and the sac remains distended post-test, it is suggestive of an encysted mucocele. If there is no regurgitation but the sac empties into the nose, then it's likely to be an atonic sac. Sometimes other diverticula also can present similarly, but more commonly it is suggestive of an atonic sac. But if there is blood, tinged fluid, it indicates towards a lacrimal sac tumor or a dacryolet. Coming to the technique of syringing, we know we need a light source in the form of a torch attached to a chair. Otherwise, you would need a light source held by an assistant. Local anesthetic drop, normal saline. We prefer a 1 cc syringe, but 2 cc can also be used. Nettleship punctal dilator and 27 gauge cannula. A straight one is preferred over a curved one, so that you can stretch the lid laterally and direct it 2 millimeters straight and then in the horizontal direction. Cotton tissue swabs for wiping and gloves. So how to interpret syringing test? If it is patent, the saline does not regurgitate on slow injection. It's important to not inject very forcefully because although it might come through the throat, it might also regurgitate. So slow injection is necessary. And in addition to what you see, the patient says that they felt the fluid in the nose or the throat. This is indicative of anatomical patency. If complaints of watering still, in spite of syringing being patent, it's more likely to be due to a functional block. If there's regurgitation from opposite punctum, there is you can use the same cannula to go ahead and see if there's a hard stop or a soft stop. Hard stop is indicative of nasolacrimal duct obstruction. In cases where Oplas is negative and you get a hard stop and regurgitation, the sac is likely to be contracted and hence it's not taking up the fluid, but at the same time, fluid is not going down the NLD. If there's a soft stop, it suggests a common canalicular blockage. If there's regurgitation through the same punctum with a soft stop, either through the upper or the lower punctum, it indicates an upper or lower canalicular blockage. Jones dye test is something that is not commonly done, but is often written in all our textbooks in post-graduation that we come across. So that's why I put in this. Jones dye 1 test is used to determine the presence or absence of functional obstruction of nasolacrimal outflow system. So after instilling the fluorescein and anesthetizing the nasal cavity, you can put a bud in the inferior meatus. There is no dye, so it's either functional or anatomical block. Jones 2 test is after injecting and at the inferior meatus, you can ask the patient to bend forward by 45 degrees so that sometimes it goes directly in the throat. So in that, in the second stage, like Jones dye 2, after syringing, we found that the dye was in the inferior meatus and it suggests absence of anatomical obstruction. Preoperative as well, nasal endoscopic evaluation is very valuable for like BCR surgeries whenever you're planning in cases of primary nasolacrimal duct obstructions. How does it help? Because often we see that BCRs are being done without a nasal examination. It suggests what all you can make out is nasal septal deviation, whether there's a paradoxical middle turbinate, whether there's a concha bullosa or bulla ethmoidalis, is the sac positioned properly? Are there any associated nasal pathologies which can be treated simultaneously like polyps? Sometimes even post DCR, when there is a failure of the surgery, we need to do nasal endoscopic examination to look for any intranasal adhesions, whether there is cicatricial closure, any septal deviations, concha bullosa or granuloma. So endoscopic evaluation forms a part of a evaluation of tearing patient. Coming to last, but which has a limited role, is that lacrimal imaging, that is dacrocystography. So conventional dacrocystography involved installation of a radioiodine dye and the X-rays taken after injection of the dye, either through the cannula. But now we've moved to CT-DCT is what is the preferred modality because it gives you better understanding of 3D anatomy. Bony structure around the lacrimal system. MR DCT again has limited role. I'll just come to it. So digital subtraction DCT can only help you probably in image control during balloon dilatation of NLD if you can take X-rays during while the procedure is going on. But three-dimensional imaging of bony structures can help better surgical planning. So CT-DCT is what we prefer. The role is very limited to complex orbitofacial trauma, lacrimal sac tumors, or certain congenital craniofacial anomalies. It can be done in suspected cases of diverticula or functional epiphora or partial NLD, but the upper three are the ones, they are definite indications wherein a CT-DCT would help. For example, here is a case with the right eye Oplas positive. And on CT-DCT, it is seen that the right lacrimal sac there is no dye in the nasolacrimal canal. So the blockage is at the level of the, between the sac and the NLD. Likewise, there is an interesting case wherein a patient had history years ago, trauma, there's no scar around it. There's just one forehead scar. And on CT-DCT, there is superior migration of the lacrimal sac. Other cases of secondary acquired nasolacrimal duct obstruction could be lacrimal mass, as can be seen here in the, which is involved, the lacrimal sac mass is involving the NLD on this side, whereas on the opposite side, the NLD is not, is good. Likewise, even in the coronal cuts, you can make out a mass in the lacrimal sac region. MRDCT has very limited role, just that there's no radiation exposure, and it can assess functional as well as anatomical lacrimal drainage system. Another important aspect is pediatric tearing. It is could be due to congenital nasolacrimal duct obstruction, punctal atresia or stenosis, conjunctivitis, foreign body or abrasion, or even congenital glaucoma, in which cases corneal diameter and IOP needs to be measured. The features of CNLDO are watering shortly after birth, usually after 2 to 3 weeks. Eyes are white invariably, cornea is clear, there's matting of lashes, and Roplast test is positive. There may or may not be swelling in the lacrimal sac region. In acute dacryocystitis or lacrimal sac abscess, Roplast test should not be done. Likewise, syringing also should not be done because it can be more traumatic. Another case of pediatric epiphora, bluish mass is seen in the lacrimal sac region below the medial canthal tendon on the left side. It has been present since birth. So differential diagnosis of this was probably encaphalocele, wherein there is pulsatile swelling above the MCT. But this case was, because it's below the MCT, it was a case of dacryocele. So ophthalmic evaluation involves, can be done with or without EUA depending on the age of the child. FDDT with Roplast, punctal evaluation, eyelid, conjunctiva, cornea, corneal diameter, IOP, and syringing. To conclude, I would like to mention that to avoid trauma to the punctum or false passage, always tip your punctal dilator with an ointment. While inserting the dilator, it is wiser to twirl it as it is being inserted. Insert it only during the in the vertical section. Even while probing the probe, it's better to lubricate the probe with an ointment. Do not apply force as it's likely to create a false passage and further the scarring. Always ensure that a hard stop in pediatric probing is felt before turning the probe downwards and backwards and laterally in the nasolacrimal duct. And for serial dilatation, increase the probe thickness sequentially. Thank you very much.
Thank you, Dr. Akriti, for that excellent presentation on very systematic evaluation of a case of epiphora. We have a question. In a case of patient posted for cataract surgery, if we get a clear fluid regurgitation on syringing, how to proceed? Can we proceed with cataract surgery, or
if there is clear fluid regurgitation on syringing, and then if there's a hard stop, then it's wiser not to proceed with cataract surgery. If there is regurgitation from the same punctum, from the upper as well as lower, if there's punctal or canalicular obstruction, then you can proceed with cataract surgery is what I would do.
Okay, madam.
But there could be a contracted sac, and so even with regurgitation, I would still probably advise a DCR definitely before going ahead with cataract surgery.
Okay, madam. What if we get a partial block? Sometimes we get partial block, no? Part free block.
Yeah, the opinions about partial blocks do differ. So I would do a nasal endoscopic examination, but currently, even in partial block cases, now they even say how much partial, like sometimes how much % of the fluid is coming down. It's very difficult to assess that. But I would still do a DCR unless the patient tells me frankly that I see that significant amount of fluid has gone into the NLD and the patient sees the water is coming the throat. Without that, I would still advise a DCR surgery. I think it's something for cataract surgeons to decide.
Okay, madam. Thank you. Thank you, madam. Okay, now we will move on to our second talk by Dr. Milind Naik on external DCR. I invite Dr. Vijayalakshmi to introduce Dr. Milind Naik.
Yeah, one more point to add, Dr. Akriti, that is, I always advise our PGs never to do a Roplast on the day of surgery. Early morning, if there is no duct, they just go and press at the lacrimal sac area. I say, never do that, please.
Absolutely, absolutely. Not on the day of cataract surgery.
Yeah, yes. Okay, coming to second talk, let me introduce Dr. Milind Naik. Dr. Milind, he has completed. Yeah. Shall I go ahead, Anju? Yes. Yes. Dr. Milind has completed his MD ophthalmology from CMC Vellore and pursued fellowship in orbitofacial plastic surgery from University of California, Los Angeles. He is currently the consultant at the Department of Ophthalmic Plastic Surgery, LV Prasad Eye Institute, Hyderabad, and adjunct associate professor in University of Rochester, New York. He is a vice president of Asia Pacific Society of Ophthalmic Plastic and Reconstructive Surgery, editorial board member to Journal of Craniomaxillofacial Trauma and Reconstruction, Korean Journal of Ophthalmology, Journal of Cutaneous and Aesthetic Surgery. He is in the top 2% global researchers in ophthalmology, Stanford Study 2020. He's received the Achievement Award from American Academy of Ophthalmology in 2015. He has 230 peer-reviewed publications, 500 presentations, national of international and national fame. And his areas of interest are eyelid surgery, aesthetic and facial plastic surgery, thyroid eye disease, and minimally invasive ophthalmic plastic surgery. Over to you, sir. Awaiting eagerly for your talk, sir.
Hi, am I audible?
Yes, sir.
Yeah, Anju and Comtrust, thank you so much. This is a wonderful program. I've been listening to the talks, and it's always informative, and there's a lot to learn. I think I've shared a video. It's pre-recorded, so I'll request Anju, if she's there, to just play the video.
Yes.
Once the video is done, if there are questions, I'll take them.
Video is ready, Anju, or should I go for the question?
External diagnosis.
Sorry. Meanwhile, one question, sir. What would be the ideal gap time be between lacrimal surgery and intraocular procedure? Like after DCT or DCR, when would you ideally advise a patient to be taken up for cataract surgery or any other intraocular procedure? Sir, please unmute, sir. Sir, please unmute, sir.
Yeah, I think there's one publication which talks about when does the ocular surface flora normalize after lacrimal surgery, and the recommendation there was 4 to 6 weeks.
Okay.
Now, whether normalization of flora converts into zero endophthalmitis, we do not know. But in a case where you are able to wait that long without losing vision, I think that would be a recommended time, 4 to 6 weeks. If not, then obviously you would have to do it as an emergency, doing a punctal cautery temporarily, and proceeding with all the risks involved. I think it's a question best answered by the anterior segment surgeons, but study recommends 4 to 6 weeks.
Okay, sir. Do we have to repeat the swab or anything like that, sir? Not necessary.
I think that would vary from center to center, and each place would have a different protocol. I would suggest that the person who's going to take responsibility of endophthalmitis decides how stringent their protocol should be. There is no hard and fast rule here.
Yeah. Okay, so we have one more question. Any special precautions while doing DCR in patients with skin conditions like ichthyosis or some other skin diseases?
Well, you should choose an endoscopic approach in that case. If you cannot do it personally, you can refer it to a person who does it.
Okay, sir. Video is ready, Anju.
External dacryocystorhinostomy, or DCR, is the gold standard technique for treatment of acquired nasolacrimal duct obstruction. The surgery is performed under general or local anesthesia. Nasal packing can be done with a cottonoid soaked in 4% lignocaine and 0.5% xylometazoline. Here, we demonstrate a skull model, the site of lodgement of the nasal pack if the forceps is inadvertently directed posteriorly. The nasal pack tends to lodge in the inferior meatus, which is undesirable. The correct method, therefore, involves directing the forceps superiorly along the nasal cavity to ensure that the pack is lodged in the middle meatus, which is the area of interest in this surgery. A curvilinear incision is marked on the skin 10 to 12 millimeters in length, 3 to 4 millimeters from the medial canthus along the anterior lacrimal crest. Infratrochlear nerve is blocked by placing the needle at a point midway between the medial canthal tendon and the trochlea, along the superomedial orbital rim and directed posteriorly. The infraorbital foramen is palpated just medial to the midpupillary line, approximately a centimeter below the orbital rim. The anesthetic is injected in a perpendicular direction, staying above the periosteum. The dorsal nasal nerve is then blocked at the osseocartilaginous junction on the lateral wall of the nose. Finally, the anterior ethmoidal nerve is blocked by a transcaruncular approach. The needle pierces the caruncle and is directed posteriorly and medially towards the medial orbital wall just behind the posterior lacrimal crest. The skin incision is placed with 15 number scalpel blade along the skin incision as marked earlier. The subcutaneous tissue is dissected with the help of a monopolar cautery and the orbicularis is separated. This eventually takes us to the periosteum around the anterior lacrimal crest. Freer's elevator is then used to separate the periosteum from the bone and reflect it laterally up to the anterior lacrimal crest. The anterior crus of the medial canthal tendon is released with the help of a monopolar cautery. Orbicularis muscle is retracted with the help of a Demers retractor to assist in visualization. A lens spatula is then used to bluntly dissect the lacrimal sac of the lacrimal fossa. Once the lacrimal fossa is exposed, osteotomy is initiated at the junction of the frontal process of maxilla anteriorly and the lacrimal bone posteriorly. A change in color of the bone, which is white anteriorly and bluish posteriorly, helps identifying this starting point of osteotomy. A Kerrison bone punch is then inserted between the bone and nasal mucosa and the ostium is sequentially enlarged. It is important to know the limits of the osteotomy. Anteriorly, one can punch till the punch cannot be inserted further between the bone and mucosa, typically 10 to 12 millimeters anterior to the anterior lacrimal crest. Inferiorly, the limit is still the sac nasolacrimal duct junction. and superiorly the limit is up to the medial canthal tendon or 2 millimeters above the level of the common internal punctum as identified by probing. The posterior limit remains the point where osteotomy was initiated. The nasal mucosa is then injected with a mixture of lignocaine and adrenaline to provide good hemostasis. The punctum is dilated with a punctum dilator, and Bowman's lacrimal probe size 1 is passed to cause tenting of the lacrimal sac. Fluorescein stained viscoelastic is injected from the upper punctum to dilate the sac. This helps in easy creation of the flaps and also ensures that there is no lamellar dissection of the flaps. A longitudinal incision is placed with a 11 or a 15 number blade across the sac vertically from the fundus to the nasolacrimal duct to obtain a large anterior flap and a small posterior flap. Transverse incisions are then made at the edges to raise the anterior flap. The nasal mucosal flap is fashioned with the help of a 15 number blade. This flap is hinged superiorly and involves the entire ostium. The large anterior flap is raised and smaller posterior flap of the sac can be excised. Mitomycin C 0.04% is used for 3 minutes as an adjunctive measure, and the cavity is washed with saline. The nasal mucosa or the sac flap is trimmed to ensure taut closure. The two flaps are sutured with 6-0 polyglactin interrupted sutures. Orbicularis may be sutured with 6-0 polyglactin interrupted sutures. Skin is sutured in a similar fashion. Nasal packing is performed to provide hemostasis. And that brings us to the end of the surgery. A successful dacryocystorhinostomy surgery thus creates an anastomosis between the lacrimal sac and the nasal mucosa via a bony ostium and bypasses the obstructed nasolacrimal duct. Thank you. Hi, thank you. If there are any questions, I'll take them.
Yes, sir. So, do you routinely use MMC in all cases of DCR, sir?
Yes. Primary and definitely in recurrent cases.
Okay. That's a beautiful video, sir. really tempting all of us to do DCR?
Well, this is the standard incision. We do this less often now. Everyone in the department is trained with endonasal approach, and if you have to do external and you want to make it cosmetically the best possible option, you could even take a subciliary incision. We've published on this topic, and that's a good option to avoid a visible scar.
Okay, Anju, shall we move the next talk, or is there a change in the?
No, madam, we can go ahead with the next.
Okay, Husna, please. Thank you so much, sir.
Thank you, everyone.
Husna, please unmute.
So we will move on to our next talk on proximal lacrimal drainage disorders by Dr. Nandini Botra. Dr. Nandini is the consultant at Department of Ophthalmic Plastic Surgery Services at LV Prasad Eye Institute, Hyderabad. She completed her MS from AJ Institute of Medical Sciences, Mangalore, and pursued her fellowship in ophthalmic plastics and facial aesthetics, orbits and ocular oncology from LV Prasad Eye Institute, Hyderabad. She received Best Poster Presentation at All India Ophthalmologic Society in 2017. She has over 57 peer-reviewed publications and 50 conference presentations. She has conducted numerous workshops and live surgical demonstrations. And she is the reviewer for many journals, which include Graves Archives of Clinical and Experimental Ophthalmology, International Journal of Ophthalmology, Current Eye Research, Clinical Ophthalmology, and Saudi Journal of Ophthalmology. With this introduction, I invite Dr. Nandini Botra for her talk on proximal lacrimal drainage disorders. Over to you, ma'am.
Hi, everyone. Am I audible?
Yes, ma'am.
Yeah, thank you. Thank you so much for the introduction. So I'll quickly move on to the talk in the interest of time. Right. So is my slide visible?
Yes, ma'am.
Right. So my topic for today is proximal lacrimal drainage disorders. Now, this is a very these are disorders which are probably not looked at or not diagnosed usually. So let us just look at a few of them today. So I'll just cover 3 punctal disorders, 2 canalicular disorders, and 1 in the common canaliculus with its clinical significance. So firstly, let us come to something called as incomplete punctal canalization. Now, usually when we have kids in our clinic who present with epiphora since birth, our default diagnosis is congenital nasolacrimal duct obstruction. But there is a catch here. Not all kids have a congenital nasolacrimal duct obstruction. We should always make a point to look at the puncta. Now look here, you can see a membrane around the puncta with vessels traversing over that membrane. Now this is what we call incomplete punctal canalization. So this is a developmental disorder where the puncta, during the separation of the eyelids at the 7th month, the puncta did not really open up. So there can be 2 different types of membrane. Here what you see is an external membrane where you can actually trace the vessel nicely over the membrane onto the other side. However, an internal membrane will have the appearance of bayoneting that we see in optic disc in cases of glaucoma. But essentially, both the conditions can be treated by a simple procedure, that is membranotomy. Now here I would draw your attention on my left. You see 2 different types of punctal dilators. To the left is a slow taper punctal dilator, which is less sharp and is more dilated. Whereas for membranotomies, we need something called as a rapid taper punctal dilator, which is longer and sharper. So it will pierce through the membrane, break the membrane, and once the membrane is broken, we dilate the puncta a little, do an irrigation, and in 99% of the cases, the irrigation is freely patent and there is no associated nasolacrimal duct obstruction. So this is a very simple condition to diagnose. The click here is when these kids present to us in the clinic, they do not have a lot of history of discharge, but the parents would say that there is constant epiphora and there is constant watering with minimal discharge. So moving on to the next condition, that is idiopathic canalicular inflammatory disease. Now, this is a very recently discovered condition, although we've been seeing it for ages, but we've never really looked at it from a disease perspective. It affects the proximal lacrimal drainage system. It is idiopathic and non-infectious and typically affects middle-aged women. And these patients come to us with watering, which usually begins in one eye and then gradually progresses to involve the other eye. So for the ease of treatment and understanding, we've divided this disease into 5 stages. So here, if we look at the puncta, we cannot really differentiate between the inner and the outer punctal rim. There is a gross edema in the punctal area. And if we look at the ASOCT and follow the vertical canaliculus over here, there is edema along the entire vertical canaliculus obstructing the opening. So these patients do not really have a blocked orifice. If you forcefully do syringing through these puncta, it is always patent. However, they will still continue to complain of epiphora. Now moving on, if it's untreated at stage 1, it progresses to stage 2, where you see that there is increase in the edema, and in the peripunctal area, there is a lot of vascularization which moves towards the puncta. This is stage 2, that is stage of progressive centripetal vascularization. In stage 3, this punctal rim becomes much more prominent and it becomes much more angry looking. And if you look at the ASOCT, you can see a nice pouting of the punctal rim. So this is stage 3, that is stage of pouting of vascularized mucosa. If untreated at this stage, it proceeds to stage 4, where a membrane forms over the puncta and blocks the orifice completely. Now, if the membrane is flimsy, it is stage 4A, whereas if the membrane is very dense, it is stage 4B. And untreated at this stage progresses to stage 5, where there is scarring in the punctal area and becomes irreversible from this stage. So certain diagnostic findings in these cases is canalicular mucosal edema is definitely present. The microbiology is negative. Systemically, the patients are perfectly fine. The collagen vascular profile is negative. On histopathology, chronic inflammation is seen in the tissues. And if untreated, there is relentless disease progression to reach stage 5. So initially, when we did not know the condition, we did not do any treatment for it, and ultimately it caused total punctal effacement. And once it reaches that stage, there's no going back. So then we thought, since there's so much inflammation in the punctal and the peripunctal area, we gave the patients topical steroids, and we had an amazing response where the puncta opened up, the edema reduced. And there we followed it when in cases where there were membranes with punctal dilatation and monoca. After removing the monoca and after stopping topical steroids, what we noticed was there was 100% anatomical and functional failure. That is, there was relentless progression again. So we had to think of a way to keep inflammation at bay for a longer time or for a longer duration. So then we added topical cyclosporin to our treatment regimen. So topical steroids for a month, tapering topical steroids for a month and cyclosporin for a month, reduces the edema and gets the edema under control. Followed by that, in cases where it's required, we go ahead with punctal dilatation and monoca, and then continue the use of topical cyclosporin for the next 3 to 6 months. With this treatment regimen, the 100% failure rate converted to a 60% success rate, which is a big number. So what were the failure cases? So the majority of the failure cases fell in the category of stage 4B and stage 5. So stage 5 is anyways irreversible. Also, what we found very interesting was when this condition was seen at a younger age, say less than 30 years of age, the failure rates were much, much higher. So these are certain pictures. On my left is the picture pre-treatment, and on my right is post-treatment, where you can see that the punctal contour is very well established and is open now. Similarly, in these pictures, if you see stage 3 and stage 4 and post-treatment with cyclosporin 6 months later, the puncta is nice, well-rounded and open, and the patients are subjectively and functionally doing very well. So coming to the third topic, that is punctal agenesis. Now, this is a very commonly known topic, but there are a lot of different treatment strategies that are followed for punctal agenesis. So how do we recognize this? So punctal agenesis is an embryonic condition where there is absence of puncta. So you will not see any punctal opening or punctal papilla in the punctal region. There can be hair in the pars lacrimalis region of the eyelid. And if you very closely observe in the canalicular area, you will note a sort of hollowing, which is not there in normal people where there is a normal puncta and a canaliculus. So this helps us diagnose a punctal agenesis rather than an acquired effacement of the puncta. Now, why I am stressing on this condition is there are a lot of studies which have retrograde probing and creation of a neopuncta. But what we need to understand is in majority of the cases, there is complete absence of canalicular tissue as well. So we did a study where we did exploratory cut down to the depth of 3 millimeters and a length of 8 millimeters. And grossly, we could not find any viable canalicular tissue in these cases with punctal agenesis. And we sent these tissues for histopathology, where we saw that the tissues had a stratified squamous epithelium, as we see here, with occasional goblet cells, which tell us that the mucosa is mostly, where the tissue is mostly a conjunctival tissue. So is there a presence of a canalicular tissue? And do we really need to create a neopunctum, and is it really going to stay open, is the question that we need to answer. Similarly, in these cases with punctal agenesis, there is mostly a component of lacrimal sac dysgenesis as well. That is, the lacrimal sac is also not very well developed. So if you see, this is an endoscopic view of the lacrimal sac in a case with punctal agenesis, where we see that the sac is extremely dilated, and on incising the sac in the second picture, we see that the walls are extremely thin and flimsy. And this, when sent for histopathology, shows a mixed cuboidal to columnar epithelium with occasional goblet cells. So this lacrimal sac tissue doesn't really function properly to get any fluid into the sac tissue and the nasolacrimal duct tissue. Similarly, in a case with punctal agenesis, when external DCR was done, look at the sac. It is so dilated and so very thin-walled. Again, when this entire sac was sent for histopathology, only this area in the square showed actual sac tissue, which is almost redundant, and the rest of it was just a dilated cystic lesion. So doing CDCR, conjunctivo DCR, or other procedures in cases of punctal agenesis may not yield a good result. Hence, we need to figure out in which cases the sac is bound to be normal, and then take them up for surgery. So moving on to the canaliculi. So canaliculitis is a very common condition that we see in our day-to-day practice. Now, the normal teaching is in an acute stage, you will see swelling of the eyelid, lot of discharge, redness of the eyelid, and on eversion, you will see pouting at the puncta. So normal practice is to do a punctal snip procedure and then drain out all the discharge. But the present trend is to respect the punctal integrity and not cut the puncta. So if we do not cut the puncta, how do we go about removing the entire discharge? So we use a short taper punctal dilator, as I showed earlier. We dilate the puncta thoroughly. Once that is done, use 2 buds to entirely squeeze out whatever discharge and concretions are present, and they come out with the help of buds. Post that, all of us have a chalazion curette in our clinic. So use a 1-number chalazion curette, go very gently into the puncta and the canaliculi and gently scoop out the contents, scraping through the posterior, anterior, superior, and inferior walls of the canaliculus. Post this, all the discharge is sent for microbiology and topical antibiotics are started. So this is the presentation in acute canaliculitis. However, what we miss is the cases of chronic canaliculitis who keep complaining of epiphora, and they are just treated with lubricants over years till we recognize that it is actually a canaliculitis. So this was a gentleman, came with history of epiphora for the past 2 years, have been showing in various clinics, and has been only treated with lubricants so far. But if you closely look, there's no inflammation, but there's slight swelling in the lower lid near the canalicular area. On eversion, you can see that the puncta is clogged, even though it is not pouting. There's no inflammation, but there is clogging at the orifice. So we went ahead, did a punctal dilatation, non-incisional canalicular curettage, started him on antibiotics, and this is him after 2 months of treatment, where the puncta is regular, round. There are no cuts because we did not give any snip. The punctal integrity and hence the lacrimal pump integrity is maintained in these cases. Similarly, this was a lady who presented with history of 10 years of epiphora. There is clear swelling in the canalicular area. She was being treated with antibiotics and lubricants, but it did not work. So when she presented to us, since it's a 10-year-long history, what we saw when we were doing a curettage, we felt a very gritty sensation. When we looked into the vertical canaliculus, there was a canaliculolith present. So we had to do a 2-snip punctoplasty, remove the canalicular lith, which was almost measuring about 0.7 centimeters. And then we sutured the edges of the snip so that we can restore the punctal anatomy as much as possible. So in chronic cases of epiphora, always make it a point to look at the canalicular area and look at the punctal area. There may not be any swelling, there may not be any inflammation, but the punctal anatomy gives us a hint as to whether there is any underlying infection. Moving on to the next condition, that is the canalicular obstructions. So this is very commonly encountered in our clinics. So proximal obstructions are about 2 to 3 mm of canaliculus. Mid obstructions are between 3 to 6 millimeters of the canaliculus, and beyond 6 millimeters, they are distal canalicular obstructions. Now herein lies which cases should we treat and which cases should we not treat. So what can cause canalicular infections? There are various causes. A few of them may be Stevens-Johnson syndrome, OCP, trachoma, lichen planus, trauma, and others. We really don't know why certain idiopathic canalicular obstructions occur. In fact, in ICID cases, sometimes you see that the punctal edema resolves completely. However, the canalicular obstruction persists. So that can be an additional cause for canalicular obstruction. So what are the treatment options that we have? In proximal obstructions, general trend is to observe or to go ahead with a conjunctival DCR, because we do not know the rest of the mid and the distal canaliculus is open or not. Hence, observation or conjunctival DCR is a good option. If the patient does not agree to these methods, then lacrimal gland directed measures like botulinum toxin to the lacrimal gland can be tried to reduce the amount of epiphora. In mid-canalicular obstructions, we can attempt canalicular trephination with Monoca stent intubation. In cases where there is a failure of trephination, we can go ahead and do a conjunctival DCR, and failure of that, or if the patient does not want to go ahead with that surgery, then lacrimal gland directed measures. The most favorable in these canalicular obstructions is the distal obstructions. Here we can either go ahead with trephination and Monoca intubation if there's no associated nasolacrimal duct obstruction, or if there is an associated obstruction, just go ahead with DCR, either endoscopic or external approach. Both will do very well. Coming to the last part of the talk, and a very interesting part of the talk, and why I have included in the talk, I'll tell you towards the end. So valve of Rosenmuller is present at the junction of the common canalicular and common canaliculus and the lacrimal sac. Now recently, we've described 2 types of valve of Rosenmuller. So this is type 1 Rosenmuller. So just look at this internal common opening. So if you see there is an elliptical fold, mucosal fold on the superior or the posterior-superior junction of the internal common opening. When you get the probe in, this mucosal fold flips out towards the lacrimal sac. And then when you take it in, it again folds back and causes a slit-like opening. Similarly, this is type 2 valve of Rosenmuller, where you see 2 mucosal flaps, one from the superior aspect and one from the inferior aspect of the inner common, from the internal common opening. Similarly, when we put a probe in, the flaps, they bulge out into the lacrimal sac, and on withdrawing the probe inside, they close the opening, preventing the reflux. Now, why is this important is sometimes when we do probing or syringing, we do not get a hard stop. However, the syringing is patent, or sometimes there is minimal regurgitation back. At this time, do not force the syringe or the probe into the canalicular system. That way, we end up damaging these mucosal edges and the mucosal flaps. We can just slightly and very slowly and gently redirect our syringe or the probe so that we can get into the internal common opening and into the lacrimal sac. So knowing the anatomy just changes the way how we deal with the lacrimal tissues. Thank you. If there are any questions, then I can take them.
Due to the paucity of time, I request all the speakers to please answer the questions in the chat box. And I would just a take-home message to all PGs, please start ocular examination from the eyelids and please don't ignore the patient symptom watering. And thank you, Dr. Nandini, for the new insights into the proximal lacrimal drainage disorders. Thank you, all speakers. Over, Nafia, please.
Moving on to the next session, it's the faces of the face. I invite the discussants, Dr. Prabhusha Banerjee, consultant of the oculoplastic surgeon at Aditya Birla Shankar Netralaya, Kolkata, and Dr. Angela Jose, consultant of ophthalmic and medical retina specialist at Comtrust Eye Hospital. Over to you, madam.
Hello, a very good afternoon. It's my privilege to welcome Dr. Kasturi Bhattacharjee. Of course, we all know her. She is a very skilled oculoplastic surgeon and also the queen of aesthetics. She has many awards to her credit, including the Colonel Rangachari Award and also the recently won AIOS Star of India International Heroes Award. She has authored over 30 chapters and also she has more than 70 published articles in the peer-reviewed journals. As an ophthalmologist, she has pioneered the use of navigation in the transorbital optic canal decompression surgery and also received an award for that from APAO. And presently, she is the chairperson of the scientific committee of the Oculoplastic Association of India and also the director of the prestigious Sri Shankaradeva Netralaya in Guwahati. I welcome Dr. Bhattacharjee to speak on the pearls of blepharoplasty. Over to you, ma'am.
Thank you very much for the kind words. Can you hear me?
Yes, ma'am. You are audible.
My slides are visible?
Visible.
Thank you, Dr. Anju, Comtrust, for having me here. I'll be going a little fast because I have got another meeting starting at 12:45. So basically, I'll be speaking on pearls in aesthetic blepharoplasty. So whenever we talk about a common aesthetic surgery that can be performed by any of the ophthalmologists, it is basically the upper lid blepharoplasty, the lower lid blepharoplasty, and the medial epicantoplasties. So what is this upper lid blepharoplasty? This is a procedure in which a variable amount of skin, orbicularies, and the fat are either being excised, then this is being redraped, and then this is being sculpted. Interestingly, today it is one of the most common surgery that is being performed by many of the oculoplastic surgeons, either for a cosmetic indication or a functional indication. And by definition, it means the surgery or the molding of the eyelids. So I'll be showing a very simple surgery, especially for the beginners, like the most important, the mark. How do you mark it? It should be a very symmetrical marking and the incision. Initially, when I started with radio frequency in order to make it a bloodless, but especially for the young children, when they come for aesthetic indication, nowadays I prefer 15 blade because I feel that with this incision, the dynamic crease is the scar you don't see at all, and you do not have the static crease also. And they have a very beautiful dynamic crease. So following the incision, especially if you have a thick eyelid, you need to excise some amount of the orbicular, especially the preseptal, but not the pretarsal. Expose the fat, and you can see the beautiful white is the levator aponeurosis so that you don't injure. And the fat, you do not pull it out, whatever comes out. And what I do is basically I see the align it in line with the superior orbital rim. So the part which is above the superior orbital rim, that is the part which I usually excise. Nowadays, what from my many years of practice, or more than 15 years, what I have realized, the less you excise, it is better for the patient in the long run. Initially, we all were very, very aggressive. We used to excess too much of fat, but I believe up after 5 years, you see too much of excision might lead to some amount of deep superior sulcus deformity. And the lid crease formation is very important. Every patient, especially those who come to you basically for aesthetic concern, you need to do a lid crease. So here what you do, you placate the LPS, you suture the LPS to the tarsus. And normally what we know, you need more than 10 millimeter of plication to increase the palpable fissure height by 1 millimeter. So here you can placate less than 7 millimeter. And this gives a very normal, whatever the palpable height is, and it doesn't lead to overcorrection. So you excise some amount of the orbicularis, very little, which causes the folding of the skin. And the end point of the surgery that you hear, slight eversion of the eyelashes. Like this is the unoperated side, you still do not have the eversion. So the same surgical procedure is done in both the sides. Excise the skin, pursue incise. Incise for young children is usually by 15 blade. Then you excise the orbicularis some amount, you titrate, then you expose the orbital fat. We know upper lid has got two fat, the central, which is little reddish in color, and the nasal is much whiter in color. Expose both the orbital fat, then you excise the orbital fat. And once you excise it, the most important is a lid crease formation suture, which is basically you suture the LPS to the tarsus. There are different ways of doing it, but I think after multiple years of experience, I feel that this is a very nice way. It gives a permanent result, and the crease never goes up, and it gives more of a dynamic crease than of a static crease, which many of the people with Asian eyelid, they wanted. And the end point of the surgery is the closure. So what, as I have already mentioned, yes, what are the aesthetic indication? One is to convert a single lid fold to a double lid fold, where you create a beautiful eyelid crease. Like as you can see here that she has got no eyelid crease. Now you want to make an eyelid crease, and you give a beautiful crease, which should be symmetrical, and you really need to take time when you do the incision. Second indication is when you have a lash ptosis like this, you need to redirect the lash ptosis along with the blepharoplasty. And the third indication, when you have dermatochalasis with so much of periorbital fat being prominent. So these are the situation where you need to do a upper lid or also a lower lid blepharoplasty. So why I was mentioning that you should not excise too much of fat. Like this is an operation done by somewhere else outside, and she came to me for her correction. Can you see there's so much of asymmetry in the right eye? There's superior sulcus deformity. And if you look very carefully, look to the left eye, the crease is also not correct. So these are very challenging, because this situation, you really need to correct it. And now how do you correct it? The fat has already been excised. And so what do you do with the fat now? How do you give it a fat? So in such situation, what I have started doing it, this same orbital fat, I do a relocation. The whatever remaining fat, you need to again incise the orbital septum, and you need to transpose the superior orbital fat and suture it to the periosteum. This gives a very good correction, or in other ways, you can also go for filler. But filler, the results are not permanent, and we all know filler can have a vascular complication. So if you find that a fat is already there, whatever fat is there, you need to relocate and suture in the superior periosteum. And also for this, whatever extra amount of skin needs to be corrected, you correct it. And this is a lady, you can see a much symmetrical eyelid crease, and also a much beautiful correction. And you can see so good filling over here. And whatever the fat was lost, you can see a much better fat being replaced here. This is another lady, I can see she is also from a medical profession, and it was done elsewhere. And you could see the same thing. There was too much of fat excision. There was excision, most probably, I think so. Her orbital septum was injured and may have scarred, and this led to nicking. And you can see a sulcus deformity here. And the same procedure has been done. The fat filling has been done. The own fat has been relocated. And you can see a much better correction with a much dynamic and symmetrical crease. So along with blepharoplasty, many a times we need to do epicantoplasty. So there are different ways of doing an epicantoplasty. And one of the simplest way of doing an epicantoplasty is that you need to mark in such a way that you need to excise discretion of the skin. So along with the excision of the skin, if you do not expose the MPL and do not placate, the results are not permanent. Very recently, I've received lots of referral from outside where the initial results, the patient has shown me initial results, they were very happy, but later they told that it has come back to the original position, that is approximately 2 to 3 years. So you need to expose the MPL, you need to placate the MPL, you need to shorten the MPL in order to have a result which is permanent. Because in Indian scenario, it's very difficult. You need to do the best best in one sitting because of the expenses and everything is not covered by insurance. In abroad, it is very good because they can do very minimal surgery and even the patient can keep on coming. Everything is covered by insurance. But in India, it is not possible. Every surgery bears some cost to the patient. So we should see that the result should be good. The result should be permanent and not on an experimental basis. So here you could see the plication has been done and the same procedure, and then this is being followed by the blepharoplasty. And what is the endpoint? The endpoint is you need to make the caruncle being shown. You can see here the caruncle is hardly being seen, and post-operative the caruncle is being shown. But what is the best way of doing epicantoplasty along with the blepharoplasty is a redraping technique where you need to mark the point. The point A is the site of the new medial canthus. That means you need to shift this medial canthus from here to here. The point 2 is the apex of the epicanthal fold. The point C is that a 2 millimeter medial to your lacus lacrimalis, and the point D is along the subciliary line. So you join this point, you make an incision along this line, and then whatever excess skin is there, you can excise it, and then you can go for adequate correction. So this is point A, where I need to shift this medial canthus from here to here. Point B is, this is the highest point of epicanthal fold. Then you stretch the skin and see the point C, which is 2 millimeter from the lacus lacrimalis, and the point D, where you move along the inferior lid margin. And some people also put a point E, that is along the superior lid margin. Then you join on the points, and once all the points are being joined, you need to excise the excess of the subcutaneous tissue. You need to excise the whatever dense tissue is there, you need to expose the MPL. So MPL exposure is very important, and the most important, this is the MPL that you can see. You should be very careful that you do not injure the lacrimal sac below it, and you need to placate. But many times you see sometimes, especially in inverses, when you have inverses, in that case, you might have to do a posterior fixation of the MPL. For that, you need to use the titanium plate and the screw. But in other cases, if it is not the inverses which we usually get in blepharophimosis, in rest of the case, I think for a aesthetic blepharoplasty, the redraping technique is one of the best technique that I believe. And this not only decreases, you can see it also gives a decreased appearance of the telecanthus and gives a very adequate correction. There are other ways like the YV plasty and also the Z plasty or the master disc plasty. These are basically used for mainly the functional indication. When I talk about a functional blepharoplasty, it is like a situation like this, when you have a bilateral gland prolapse. So these are the situation which falls between a cosmetic indication and also a functional indication. As usual, you give the incision, you excise the orbicular is the most important thing, that you need to incise the orbital septum, take out the fat, and you should differentiate. This is the gland. You see the lacrimal gland is a little, paler in color as compared to the fat. So fat you can excise out, but not the lacrimal gland, which you need to check and push behind in the orbital, within the orbit, and you see how much amount it has come out. So you use a different suture. You can use a proline, you can use a polydec. I prefer a polyester because I feel when I pass through this periosteum, the chances of tearing the periosteum or late recurrence, I have never seen after using. Even nowadays, I prefer polydec even for my LTS, the lateral tarsal strip. Anything dealing with the periosteum, more than proline, I usually prefer a polyester. So then you push the gland, and then you can give a single mattress suture, or you can give 2-3 mattress suture. And once this is being done, and then you can go for the rest of the blepharoplasty surgical procedure as it is done for a routine case. And you see a very beautiful, see no much fat has been excised. You can see there has been no sulcus deformity. And this is sheep pre, and this is the post-operative. And this is what exactly you see in all the different cases and also in the front view. But what about the ibex? There are multiple questions that when we have an ibex, do we need to give filler or do we need to go for the surgery? This is a very common question. So what I believe that whenever you have only the medial fat pad, and this fat pad, it lies much behind the anterior lacrimal crest, these are the situation where we go for the dermal filler. And dermal fillers, it really manages very well. Like you can see, she only has a medial fat pad with some amount of prominence of the tear trough and some amount of pigmentation. So she is a candidate, she is young, and this medial fat pad has not extended. You cannot see the lateral fat pad. So this is a very, classic case of a dermal filler, where I usually prefer. Now I feel that I think the best way of injecting filler is with cannula, because you need to have a very good tissue integration. That is very important. Like you do not want to have lumps and bumps, but the tissue integration is really important. And once you have an adequate tissue integration, you can see the post-operative results are amazing. This is just on the table. You can see this is before with the tear trap, with the fat prolapse out here. And here there's concealing. What it does is pushes the orbital septum, pushes behind the prolapse fat, and it really conceals, the filler really conceals the lower lid fat, and also it manages the tear trap. And the results are instant. These are the marks of the cannula. See, on the table, you can see the fat has gone off. The tear trap is much better. This is another lady, you can see, not a very good picture. And the best is this, if you really look on the side view, this is the negative vector. You can see the negative vector gets corrected to a positive vector following a non-surgical method by giving injection filler. So this is another patient on the table. You can see so much of changes. And now the question comes that what do we do when we have a real big bags like this? So when you have a double convex deformity and when there's too much of lengthening, normally the textbook says if the lengthening of the lower lid is by 16, more than 16 millimeter, you should go for the lower lid blepharoplasty. There are different schools of thoughts that when do we need to go for blepharoplasty and when do we go for filler. And along with it, you have the herniation of the fat, where it is so prominent that it lies much anterior to the plane of the anterior lacrimal crest. These are the situation where you go for the blepharoplasty. Like this gentleman, you can see so much herniation. He's quite young, but you can see the fat, all the three fat beds are being so prominent. So here I have gone for a lower lid blepharoplasty with a fat transposition, and you can see the change in the negative vector. See this vector, see this mount out here, the change in the negative vector to a positive vector following the lower lid blepharoplasty. So this is how we do the surgery. Like, we have the three fat bed in the inferior orbital rim, in the inferior orbit, and we need to expose. So now the concept is that you need to go for tissue preservation. We need to preserve this fat, can be used as a filler. And once you use this fat as a filler, it gives a lifelong filling. It prevents a further prolapse because you don't have the fat in the orbit. The whole orbital fat has been replaced to the SUF region, and the results are usually nowadays it lasts for approximately 20 years. That is what most of the surgeons believe. So the most important, you need to expose the inferior orbital inferior oblique muscle, and this is the beautiful muscle sitting between the medial fat bed and the central fat bed. So once you expose it, you need to fashion out the fat. I usually do not excise the lower lid fat, but you need to have a good pedicle of fat and try to transpose as down as possible, making sure that too much of cauterization is not done, because you need to have a vascularization of the flap. So once you fashion all the three fat beds, so these are the three fat beds that are being fashioned. Once these are being fashioned, what you need to do, you need to release the orbitomallear ligament, which is a very thin ligament, is an osteocutaneous ligament, which is a vertical through ligament. So in that case, it almost gets released very easily. Even with the artery fossa, we can release it. And then once this barrier, that is the osteocutaneous ligament, is being released, we can transpose this orbital fat deep down into the SUF, and this acts as a filling material. So this acts as a filler, and then it will lead to a very good effacement. So you see the animation, this is the orbital fat. You release the orbitomallear ligament, and once you release the orbitomallear ligament, this whole orbital fat is being transposed deep down to the SUF, as down as possible, as down beyond the deep mallear fat. If you can do it, it gives a much better result. So this is again an animation. You can see all the three fat pads that are being fashioned, and one by one, if you can do it. And even if you don't do the lateral, that is also okay. But medial and the central, if you can transpose it deep down into your mallear region, it gives a good effacement of the lead cheek junction. And these are the three fat bed, and then you can see this is being transposed, and then it is being tied with the bolsters. So this is I usually do with a PTS, or you can use a Prolene suture, and you can remove the suture approximately 10 days following the procedure. And you can see the beautiful effacement. See the effacement, you don't see this, the fat here and this lead cheek junction, you can hardly make out. These are in the different days. And the best part, this negative vector gets converted into a positive vector, as you can see here, following a lower lid blepharoplasty along with the transposition of the orbital fat. So many times, along with the lower lid blepharoplasty, we need to correct the lower lid, because this is, after all, is an involutional disease, and you can do it either as an internal pexy, or you can do a lateral cantaloplasty or a pexy. Internal we do when we do a transconjunctival approach. It is very easy.
You just need to pass a proline suture. I usually use a 5-proline suture, just hook the lower canthus and pass it through the arcus marginalis just above the superior dental insertion. So once this is being done, you can do it as an internal PETC, but also many times when I do an external subciliary approach, this is a situation where you do along the advantage of external, you can do a smash sleeve, you can do orbis lift, and also you can do an external plasty. So this is a gentleman, you can see a 3-fat transposition along with the internal cantopexy, and this is the result. So with this, I conclude here. Thank you very much for your patient hearing and for having me in this beautiful session. Thank you so much.
Thank you, Dr. Bhattacharya. It was a very well detailed presentation. I hope it will give some knowledge to the beginners to start with blepharoplasty. Since we are very short of time, I'll just request Angela to do with the audience questions.
Yes, ma'am. There's just one question. Periocular pigmentation, which is a common complaint. How do you investigate or treat this?
Actually, the periocular, it has an external factor and internal factor. Internal is basically a genetic. Genetic, we see it runs in the family and it's very common. The external is basically your lifestyle, what are the makeup you use, or what the external factors, the solar damage, this is very common. But this is very difficult. It's really difficult to manage the periocular pigmentation, but this is because the best way is if you go filler. Filler, how it decreases, it gives an illusion, like it gives an illusion of decreasing the pigmentation because it takes care of the the shadowing effect, the shadowing that is caused by the superior orbital rim. So once you fill this, the shadowing effect is not there, and it gives the appearance that it is much decreased. But there are so many thoughts. People say that there are some medicine with papaya, people are applying cucumber, people are applying, some say that if you apply the coffee, because the coffee, it causes the vasoconstriction, so the vascularity decreases. So these are multiple concepts, but I have a good collection on a patient where I have done and I have documented, and I have with the same lighting, same setting, I have taken a pre and a post injection, and I have found definitely the shadowing effect is less, and definitely the pigmentation appears much less in the appearance is much less.
Thank you. Since we are running short of time, we shall move to the next talk. There is a slight change in the order of talks. Since Dr. Tarjani Dave has an emergency, she will be speaking next, and I request Dr. Shahid Alam to speak after that. So I call upon Dr. Rituja Thomas as discussant for the next session. Dr. Rituja Thomas is a consultant at Vision Eye Center, Delhi. She has done her oculoplastics and ocular oncology fellowship from Narayan Nethralaya, Bangalore. Over to you, Rituja.
Thank you, Dr. Angela. So going from one idol, Dr. Kasturi, to another one of my idols, Dr. Tarjani. She is a consultant and the associate director at LV Prasad Eye Institute. And she completed her basic education at Sion Hospital and at Ganpati Nethralaya in Jalna. And she's also a visiting ophthalmologist at Rochester. And she's done her oculoplastics as well at LV Prasad. And she's authored several publications, and she heads the ocular history lab as well at LV Prasad. She's won the best paper in oculoplastics 2 years in a row at AIOS, and an international best paper for thermal imaging in thyroid eye disease. So over to Dr. Tarjani for her talk on socket assessment.
Thank you so much, Rituja. I would really like to thank the Comtrust team and Anju for having me here. And Rituja, it's such a pleasure to be around whenever you're there. So that teacher in me comes out every time I see her face for some reason. So moving straight onto the topic, I've been asked to speak about approaching the socket. I have no financial disclosures to make, and you're going to see certain full face photographs of my patients for which we have the consent. Now on your right-hand side, you will be seeing the list of topics on which I'm going to talk today. So that's a synopsis of the subtopics within approaching socket that I will take care of. Based on these 10 themes, I hope I can make some conclusive summary on how you should go around treating a patient with an anophthalmic socket. So briefly, I'm going to speak about what an ideal socket is, what is the choice of surgery when you have a patient that needs a socket surgery, what's ideal volume of the socket, and when you don't have that, how do you augment the volume? Similarly, for the surface area, what's ideal and how do you augment when it's not ideal? Briefly about prosthesis, but Celia is going to talk more about this. And again, a pleasure to have Celia on the same forum. Celia worked with us at LV Prasad for a brief stint. Also, I'll briefly be speaking about eyelid corrections and the complications that you see in socket surgery, and eventually summarize my talk. So if you look at a patient who has an anophthalmic socket, what are the steps that you should have in your mind? The first part is to correctly identify the pathology. Say in this instance, she has a left thumbsical eye, but then you need to be very sure of what the cause for the thumbsical eye is. In other words, you should always have a high index of suspicion for any intraocular tumor when you don't have a clear-cut history of why the eye went into phthisis. Once that is done, you need to assess how the volume in the socket or the orbit is, how the ocular surface is. If the patient is wearing a prosthesis, then what's the quality like, what material is it made up, and how is its surface wettability, because these aspects affect anophthalmic patients in the long term, and eventually look at whether there are any eyelid anomalies or not. So the cause, the volume, the surface, the prosthesis, and the eyelid. It's a very simple nomogram that I follow in all socket patients in my clinic and ensure that my fellows do as well. So now, when you talk of socket surgeries, primary socket surgeries are of three types: evisceration, enucleation, and exenteration. And very intuitively, we all understand that evisceration is when you're taking out the intraocular contents, but your sclera, the optic nerve, the fat, and everything is absolutely intact. And hence, it's supposed to be less invasive as compared to an enucleation. Since the muscles are spared, you also have better motility in patients who have undergone an evisceration. In enucleation, you're aware that you are taking out not only the globe, but also a part of the optic nerve. And this is the surgery when you have an intraocular tumor, which you do not want goes orbital. So that would be the choice of surgery. And in exenteration, obviously, you're taking out all the soft tissue along with the eyeball and leaving back the bony orbit. And at times, also taking out the bony orbit if there's a tumor that's bypassing multiple spaces. So let's look at some common case scenarios. So on your left-hand side, you see a panel that's here, which is of a patient who has, the mother gives a history that the vision has been poor since childhood, and you see this kind of a yellow reflex in the eye. This is another patient who had a trauma and then developed a thumbsical eye, and this is a patient with orbital mucormycosis. So what would your choice of surgery be? For a patient who has a suspected intraocular tumor, you're obviously going to go ahead with an enucleation and implant because you do not want the intraocular tumor to become orbital and hence increase the mortality. For a patient where you very clear-cut established that it's a thumbsical eye, done a B-scan and ruled out any intraocular mass lesion, you go ahead with evisceration because it is less invasive, gives better motility. In certain situations where you need to take care of the entire pathology that's not only probably in the eye, but also in the orbit and salvage the patient's life, such as mucormycosis that we saw during this pandemic, you might need to perform what is known as an orbital exenteration. So this is, again, a very simple thought process. Any suspicion or proven intraocular tumor, enucleation becomes your surgery of choice. For the want of time, I might skip a few steps during the surgery, but essentially when you're performing an enucleation, you go ahead with the peritomy in a standard fashion at the limbus. The aim of the peritomy is to free the anterior as well as the posterior tenons from the globe so that when you're prolapsing the globe to enucleate it, you do not have adhesions that are holding the globe back into the orbit. Now, this is dissection of posterior tenons, which is done in the 4 oblique quadrants, the quadrants where the muscles are not present. Once you've done that, you tag your muscles. And typically, nearly everybody performs the myoconjunctival technique, which includes taking a second 6-vicral suture about 6 to 8 millimeters from your first traction suture, which is at the insertion of the muscle, and then dividing the muscle between these two sutures. So similarly, all 4 muscles are tagged, and then you eventually move on towards tagging your oblique muscles. So you're seeing here a little fast forwarded video where the superior rectus has been tagged. Just before this step, the oblique had a common insertion with the rectus. So we went ahead and we have dissected off the oblique. That's the rectus being tagged. And now you have the inferior oblique being tagged and cut. The oblique muscles can directly be cut. They do not need to be tagged. Now you have your 4 recti muscles with you, which you prolapse the globe out and push the speculum down. That helps you in prolapsing an eyeball out if it is a large eyeball. And go ahead, strum the optic nerve, go right posterior where your scissor movement reduces, because that tells you that you're very posterior into the orbit, and cut the optic nerve with one bold cut. So you should ensure that you do not reuse the scissors that are being used for cutting the optic nerve for more than 2 or 3 sittings. And if possible, use a fresh one in every sitting. Expose your posterior tenons, put your implant in, and go ahead and perform your wound suturing in 3 layers. The first layer here is the posterior tenons, which is sutured with interrupted 6-0 vicryls. Once you've done that, you want to complete your myoconjunctival sutures. So you see these 4 vicryl sutures in the 4 corners. This is still the posterior tenons being sutured. You take as many sutures as possible for you to get a very good fibrotic layer that prevents implant extrusion. Now, these are the vicryl sutures that have the muscles, and these are exteriorized, each suture in that respective fornix. What these sutures do is they translate the movement of the muscle onto the fornices, and your prosthesis is supported in the fornices at these 4 points. So every time the muscle moves with the other eye, the prosthesis also moves. Hence, myoconjunctival technique gives you a better motility compared to your plain enucleation or a simple enucleation without myoconjunctival technique. And then the closure is fairly standard. You go ahead and close the anterior tenons and then the conjunctiva. You could use interrupted or running sutures. In nearly every case, I end up placing a conformer and injecting a little bit of retrobulbar sensacaine, because these surgeries are the most painful ocular surgeries, and pain control is extremely essential. So that would mean the end of enucleation. I'll just fast forward it to show you the stage where we're inserting the conformer and eventually taking an intermarginal tarsorrhaphy between the eyelid margins. So for the want of time, what I'll do for evisceration is probably just take you through the pictures of evisceration. So you can see a slide here. So your peritomy and dissection of the anterior and posterior tenons is very similar, after which you make a stab incision on the cornea, remove the corneal button at the surgical limbus, go ahead and scoop out the contents of the eye. I find a periosteum elevator, the sharp end of the periosteum elevator, a better instrument to create that plane of cleavage between the uvea and the sclera rather than an evisceration spoon. Once you've removed all of that, you wash the cavity with alcohol, wash the alcohol out with saline, and then make what are known as petals or flaps of the sclera, which run in the 4 oblique quadrants where the muscles are not inserted, right from the limbus, a little short of the optic nerve posteriorly. And what you do after that is actually give a posterior circumferential incision. So what you've done is from the limbus, you've dissected just short of the optic nerve, and posteriorly you are dissecting off that flap. So you are creating 2 or 4 flaps, each of which is suspended by an extraocular muscle. And it's a flap because it has a muscle attached to it, which has its own vascular supply. So it's not a free graft of sclera, but rather a flap. What this helps you to do is it helps you to put a much larger implant inside, and then the flaps come anteriorly and close over that larger implant without any tension on the wound. And that's the closure that you're seeing over here, following which your anterior and posterior tenons is closed in a very similar fashion. And the conformer placed, a tarsorrhaphy done, retrobulbar sensacaine injected. Now, what is good volume? Why do we make these flaps? We make these flaps to have to ensure that at least 70% of the volume that is lost as a result of a socket surgery is replenished by the implant. So if you look at standard Indian eyes, the axial length is 23, 24, 70% of that would mean you at least need a 20, 21 millimeter of implant. And if you do not make these petals posteriorly, the implant cannot have a tension-free closure, and you will have a higher rate of implant extrusion post-operatively. So hence, making these scleral flaps sort of improves the outcome of the surgery. This is just an animation to show you that these flaps are suspended by the muscle, and hence the muscle moves, the entire flap moves freely over an implant to give you a tension-free closure and give you an outcome which is much better than when you use a smaller implant and end up with a larger superior sulcus deformity, as you see in this gentleman. All right, so certain people have assumed at times that making these flaps would make the implant slip between the two flaps and give you a higher rate of implant migration, but that does not happen even if you use a non-porous implant, and we've published that. Moving on to when you do not have adequate volume augmentation in the primary sitting. So this is a gentleman who's undergone an evisceration, wears a prosthetic eye, but doesn't have an implant. And you can obviously see that he has a larger superior sulcus deformity. So what can you do in these situations? Well, very simple. You don't have an implant, you put an implant. So you do a secondary implant, build up the volume within the orbit. Volume is supposed to be in the orbit, not in the socket where the prosthesis is sitting. And once you've done that, you'll see the superior sulcus build up beautifully, become comparable to the other side. The enophthalmos also reduces because now you have volume in the correct place. So you cannot bypass not having an implant or having a smaller implant by just increasing the size of the prosthesis. That doesn't work and doesn't give good outcomes in socket surgery. Alternatively, if a patient already has an implant, but that implant is smaller, you do not want to do an exchange, because the more number of times you touch the conjunctiva and tenons, the higher the chance that the patient might have an extrusion later on. In such situations where you have localized sulcus deformities, and sulcus deformities are a surrogate marker of volume loss, you can just go ahead and build that sulcus by injecting more volume into the orbit. So if you do a very simple thing of just pressing your eyelid here, you'll see the upper eyelid puff up. And that's essentially the volume building up into the orbit, which is actually moving the fat into the superior sulcus, and hence the superior sulcus puffs up or builds up or looks better. So this lady has had autologous fat transfer in her left orbit, following which you can see that the sulcus has now built up and is relatively more comparable to the other eye. If you do not have the expertise of performing an autologous fat transfer, you could be minimally invasive and use a filler. One of the ready available fillers, especially a more cohesive filler, is what I prefer to use in these situations. So you see a gentleman who has the superior sulcus deformity on the right side, not very happy with it. He has a good implant. He has a 20 size implant, but still is left back with some amount of enophthalmos. And all we've done in him is injected a filler. You see the point of entry here, and it's built up the sulcus very well. And he looks much better after that filler injection. In certain patients, you actually have an inferior migration of the implant. And in these patients, building up volume is much better by using a Porex wedge inferiorly. That's what we've done for this gentleman. And it's just building up volume in the orbit, which has actually even corrected the eyelid. We've not done any surgery for the eyelid. All we've done is we've built up volume in the orbit. Eventually, that has reduced the weight of the prosthesis post-operatively. And just this 600 grams of reduction in weight has brought the eyelid back into position. The heavier the prosthesis, the more pressure it puts on the lower eyelid. Gravity adds to it, and you tend to see this kind of retraction and a fold formation in the lower eyelid. And all of these can be treated when you augment the volume where it is required. So that's as far as volume is concerned. Now, what about surface? So an ideal surface surgery is when, are you able to hear me?
Yes, ma'am. Yeah.
So this is an ideal socket surgery where, despite all kinds of facial animation, the prosthesis doesn't pop out. So the ocular surface is built well enough to hold a good sized prosthesis in place. That's what an ideal surface looks like. But there are certain patients who obviously do not have an ideal surface, as you see over here. So this is a lady who you can make out has some amount of volume loss from the superior sulcus deformity, but she also has this retraction in the lower eyelid and she cannot close her eyes completely. There's legophthalmos, all of which tells you that there is a shallow or there is a loss of ocular surface, and on clinical examination, her inferior fornix is quite shallow. So what we've done for her is not only augment the volume, but also augment the surface in the same sitting by doing a secondary implant, fornix formation suture, and a mucous membrane graft. The pink tissue that you see over here is mucous membrane that we've harvested from her lip and transplanted into the socket. And with this, look at the lower eyelid. It's come back into position because you now have volume where it should be. And the surface is also better. The little bit of entropion that she has over here has also got corrected simply by augmenting the surface. She does have some ptosis, which can be subsequently treated. A similar patient who has this shallow fornicis with retraction of the eyelid, which is corrected. He also has some skin graft that was performed elsewhere within the socket, which has keratinized. So again, in his case, we did a secondary implant. We placed an MMG to augment the surface. Implant gave volume, MMG gave surface, and eventually we could reduce the weight of the prosthesis by 900 grams, which has brought the eyelid back into position, and we did not require any eyelid surgery. Certain other patients who have surface loss present just with localized entropion, as you can see over here, both of the upper as well as the lower eyelid. She seems to have a reasonable socket, but she has contracture of the ocular surface, which actually, by definition is from one eyelid margin to the other eyelid margin. All the conjunctival tissue is ocular surface. So she has some contraction of the surface, specifically in the palpebral area. And these are cases where performing a hard palate mucosal graft to give you posterior lamellar lengthening, in other words, surface replenishment, works much better than actually doing an MMG in the center of the socket. So this area is left bare, and this is a picture to show you that after about a couple of weeks, maybe about 6 weeks to 2 months, that area sort of tends to heal. And this is the area where the hard palate mucosa has been grafted, and it eventually takes up within the socket surface. And you get results as wow as this once you have put the eyelid back into position. Celia is going to talk a little bit more on ocularistry, but just briefly to tell you that there's a lot of advancement in this field where you can actually digitally print a patient's iris. So what do? You take a high resolution photograph of the other eye, and you use that photograph life-size measurement to actually give you the iris button within the prosthesis. So there's absolutely no change in the color, the dimension. The only thing that you can't do with this is give movement to the pupil. Someday I'm hoping that kind of technology will come in as well. The other thing that we also frequently do is to treat the surface of the prosthesis with something known as a plasma treatment. Now, all these prostheses are made out of acrylic, and acrylic, as we know, is hydrophobic. So we tend to make it more hydrophilic by performing plasma treatment. So this is the effect of plasma treatment on your left-hand side, where the tear film nicely sort of, spreads all over the ocular surface or the prosthesis surface. This is a more hydrophobic surface where the tear film does not spread. And this is the sort of difference you'll see in the shine of the prosthesis when you have a more wettable prosthesis, which is more hydrophilic, which is treated by performing plasma treatment over it. Last couple of slides on eyelid correction. It's important to identify pre-existing ptosis, as in this lady. Sometimes it goes unnoticed when you're, thinking on lines of, is it a tumor for which am I going to enucleate? Am I going to eviscerate? And explaining the implants and types and complications, this might go unnoticed. But, you see coexisting ptosis in almost as much as 30 to 40% of patients who have socket issues. And obviously this will be more pronounced when they wear the prosthesis. So it's important to pick it up. The other pearl that I wanted to give is anophthalmic ptosis always overcorrects. So go minimal on your levator resection when you're going to treat these patients. You tend to see this kind of overcorrection post-operatively. If it's minimal, it's going to settle down over a period of time. If it's really large overcorrection, you may have to perform an adjustment. So this is just an example to show you that, okay, we've had this kind of a patient. You see a sulcus deformity. You see the lower eyelid is retracted. You know that the volume is a little less. Surface also might be an issue. You go ahead and perform your socket surgery. Here he's had a secondary implant, FFS MMG. After that, you place a prosthesis, still a little unhappy due to some amount of ptosis which has been corrected. And even after correction of ptosis, required some amount of filler injection at these 3 spots where the tear troughs have been treated, as well as the bulk of the brow fat built up to give a very good post-operative outcome. I just briefly wanted to mention one complication of implant migration, because this is exceptionally difficult to treat. Anytime you see a migration of an implant, do not attempt an implant exchange, because the exchanged implant is going to go back and sit in the quadrant of migration, as you're seeing over here. So this patient has had 3 implant exchanges. every time the implant went and sat in the inferotemporal quadrant and thus was shallowing the fornix, and hence the prosthesis was resting on the lid instead of resting in the fornix. So in these situations, you need to identify whether the patient has significant migration which is not allowing the prosthesis to rest in position. You can refer to this paper that we've published on how to pick up migration and the extent of migration. And when it's migration which is not allowing your prosthesis to sit in the socket, you need some kind of treatment. And what do? We place a customized implant or a patient-specific implant that is crafted to go and sit in the quadrant of migration. So what that second implant now does is, it does not allow the primary implant, which is in the socket, to actually come and sit in that quadrant of migration. That is the only technique that helps you in situations with implant migration. This is a short video on how we craft these implants. So you can use several freely available online softwares that convert a 2D CT scan into a 3D CT scan. You obviously need a CT scan of the patient to perform any 3D printing of the skull model. This cropping is done to reduce the cost of printing, and you send the file to a 3D printer, which will eventually lay down your material, which is going to print the orbit. So you can see it. This is the 3D printer in action, and it's actually printing the patient's orbit. So these are the walls of the orbit. This is just support material which is holding the entire orbit. Once you put it in a water bath, the support material dissolves, and then you can use this model of the orbit to generate or to craft a specific implant of the size, shape, height that you want, which is going to go and sit in the quadrant of migration and block the migrated implant from coming back into that quadrant. So again, this is something that won me the AIOS award in oculoplasty, and is an innovation that we brought across in this field. You could refer to our article on it. Briefly speaking about one another complication, it's very common to see these kind of cysts. So if there's a patient who complains that, okay, I have been wearing a prosthesis, but lately my prosthesis is looking protruded, think recurrence of pathology if it was tumor, or peri-implant cyst if it is not a tumor. You'll be able to identify this bluish cyst, and just an aspiration and sclerotherapy works much better. You don't need to open and excise this cyst, because many times these cysts go all around the implant, and in the process of excising the cyst, you might compromise the implant. So summarizing, look for the presence of surface loss, look for the presence of volume loss, assess how the prosthesis is, and then address the eyelids. And if you follow this paradigm, then in most patients of socket, you will get a very good outcome. So that's the end of my talk, and these are the topics that I've covered for you. Hopefully I've done some justice to the topic. Thank you.
I think more than did justice to the topic. It was crisp as usual, and it covered each and every aspect that one would encounter with respect to the socket. And just one question that we had collected for you, and that is, what is your preferred surgery in irradiated sockets? So I would rather ask it as, what issues have you encountered, and how do you manage an irradiated socket?
One of the issues in patients that have undergone radiation is that they have a lot of fat atrophy in that orbit. So they tend to have an enophthalmic appearance. They have a superior sulcus deformity. These irradiated sockets also don't have a very good conjunctiva and Tenon's closure. The barrier is generally weaker. So I don't prefer to touch the conjunctiva and Tenon's if they already have an implant. I just go ahead and do adjunctive treatments like a fat transfer, and I prefer a autologous fat transfer because that fat is supposed to have some amount of stem cells and is likely to live better in the orbit, rather than doing a dermis fat graft, which requires more blood supply. And in irradiated sockets, that's an issue. So I either do an autologous fat transfer, or I treat the patients with fillers. Many times these irradiated patients also have fat loss in the temple. So other than treating the orbit, you could just add some amount of fat wherever you are seeing atrophy within the orbit. Dermis fat graft is something I would really think 10 times before performing in an irradiated socket for volume augmentation.
Okay, that's very useful information for us, and thank you, Dr. Tarjini. Over to Dr. Angela to carry on the session.
Thank you, Rituja. Thank you, Comtrust team.
Next, I call upon Dr. Shahid Alam to give a talk on the winking eye, oculofacial movement disorders. So Dr. Shahid Alam is a consultant and deputy director of Orbit Oculoplasty Reconstructive and Aesthetic Services at Aditya Birla Shankara Nethalaya, Kolkata. He has done his MS from the prestigious Aligarh Muslim University and also has completed a fellowship in oculoplasty and Orbit from SN Chennai. He was also awarded the fellowship of All India Collegium of Ophthalmology. He has worked as associate consultant in the Department of Orbit and Oculoplasty at SN Chennai for 3 years. He currently heads the Department of Orbit and Oculoplasty at SN Kolkata. He is an avid researcher and has published over 100 research articles in peer-reviewed journals and has also authored few book chapters. Over to you, sir.
Am I audible?
Yes, sir.
So is my screen visible?
Yes, sir.
Yeah. So I've been asked to talk on oculofacial movement disorders. So actually I had made up a PPT, but now because of time constraints, I think I had a video which was like almost of 10 minutes. And it is actually a compilation of all the patients of movement disorders which I have seen over the past few years. And along with that, all the signs and like typical features which are seen in these different disorders and how to differentiate among them. So I think that video will suffice and it will actually summarize my talk. So I'm going to play that video. So it's actually a compilation of all my patients, and the voiceover has been given by one of my fellow consultants, Dr. Varsha. So is it audible?
No, sir.
Is it audible?
No, sir.
The video is not audible?
No, I'm not able to hear it from my side.
Now?
No, sir. It's playing, but the audio is not on.
Yeah. Was it audible?
No,
I
sir.
think probably can stop sharing, and when you reshare, share it with the sound. There will be a
Hello?
option like that. No.
Hello?
Hello, sir. Can you hear us?
Hello? Hello?
We can hear you.
Yeah, can you hear me?
Yes,
Yes.
Okay,
but not
so
the video.
was the video visible?
Video was playing, but the audio is not, we were not able to hear it, sir. Can you reshare and then there's an option of play with sound. So you'll
Play
have
with
to-
sound.
uh,
Hello?
yes, sir.
Oh, share sound.
Share audio. Share
Okay,
audio
okay,
option.
okay. Yeah. Is it audible now?
Oculofacial movement
Audible?
Yes, sir.
disorders have always been a subject of fascination for neurologists, neuro-ophthalmologists, and oculoplastic surgeons. One of the first documentations of this disorder was made by famous Flemish painter Bruegel, who depicted blepharospasm in a painting named De Gapere in the 16th century. At that time and for several ensuing centuries, patients with such spasms were regarded as being mentally unstable and often were institutionalized in insane asylums. The involuntary oculofacial movement disorders that we routinely see in our clinics can be broadly classified into 7 categories: benign essential blepharospasm, Meigs syndrome, Bruegel syndrome, apraxia of lid opening, hemifacial spasm, eyelid myokymia, and aberrant facial nerve regeneration. The video would be presenting each of them briefly. Benign essential blepharospasm is a disorder of progressive involuntary spasms of eyelid protractors, orbicularis oculi, corrugators, and procerus. resulting in involuntary eye closure. It starts with ocular irritation and increased blink rate and gradually progresses to forceful eyelid closures. The spasm is more forceful in the orbital portion of orbicularis and involves the corrugators and procerus in varying degrees in different patients. Patients are extremely sensitive to light and have severe photophobia. Chronic use of orbicularis results in hanging down of medial portion of orbital orbicularis below the supraorbital margin and is known as Charcot sign. The spasms are worsened by increasing light intensity and movement such as walking and driving. The etiology is multifactorial, but the common belief is that the problem lies in the basal ganglia where the central control center for blinking may lie. Blepharospasm in many cases is associated with spasms of facial muscles, when it is called as Meiggs syndrome. It can also be associated with dystonia of mandibular and neck muscles, known as Bruegel syndrome, or other muscular dystonias. Apraxia of eyelid opening is a non-paralytic motor abnormality in which patients have difficulty opening their eyelids voluntarily. In contrast to blepharospasm, these patients don't have photophobia or any orbicularis spasms. Although some cases of blepharospasm can have an associated component of apraxia too, wherein the spasm is mostly limited to the pretarsal orbicularis. There is no Charcot sign as seen in blepharospasm. In contrary, patients have an elevated brow because of frontalis overaction. The etiology and pathophysiology, like other dystonias, is not well understood, but there is a co-contraction of orbicularis and levator with a delayed or inhibited levator response. Both patients of blepharospasm and apraxia develop some sensory tricks which help them opening the eyes. These include pressure over a point on the brow, pressure over lids of face, singing or playing musical instruments. The mechanisms of these sensory tricks is not known. Hemifacial spasm is characterized by involuntary, irregular, tonic and clonic synchronous contraction of the muscles innervated by the ipsilateral facial nerve. It usually commences with orbicularis oculi twitching or irregular rippling before spreading to the face over months to years. Unlike blepharospasm and apraxia of eyelid opening, hemifacial spasm has a recognizable etiology. Most of these cases have compression of the facial nerve root exit zone by an aberrant loop of anterior inferior cerebellar, posterior inferior cerebellar, vertebral or basilar artery, or rarely a venous aberrant loop. Hence, every patient of hemifacial spasm should have a brain MRI to exclude these causes. Since these patients are examined in the relatively dim light environment of OPD and patients are very much conscious, it is not uncommon not to notice any spasm when these patients are examined. It is a good idea to make them talk and ask them to forcefully close and open the eyes, which often induces spasms.
उन्होंने मेरे को आई ड्रॉप दिया आंखों में डालने के लिए दिन में 7 to 8 टाइम्स, लेकिन फिर उसको मैंने कंटिन्यूसली नहीं डाला. उन्होंने जरूर मेरे को रेफर किया था.
क्या प्रॉब्लम बोलिए?
कोई प्रॉब्लम नहीं,
कोई समस्या नहीं है.
तो चश्मा दिया नहीं सकता, देख सकता नहीं.
Facial hemiocymia refers to involuntary, fine, continuous, undulating contractions that spread across facial muscles. Eyelid myokymia is the most common variant of facial myokymia and involves the orbicularis oculi of lower and rarely the upper eyelid. It is said that eyelid myokymia is more easily felt than seen, but it can be seen if the eyelid margin and surrounding muscles are observed carefully. Eyelid myokymia begins at times of excessive fatigue, stress, and lack of sleep. The pathophysiology is unknown and they are generally benign and resolve spontaneously within weeks to months. The spasm of aberrant facial nerve regeneration is quite distinct from the essential blepharospasm and hemifacial spasm. They are weaker and appear only on voluntary contraction of muscles. Pathophysiological explanations of aberrant facial nerve regeneration include epheptic transmission and reorganization within the facial motor nucleus. There are several facts about these movement disorders which most of us are not aware of. Is remission possible in cases of benign essential blepharospasm? Though rare, literature supports a remission rate of around 11% in such cases within 5 years of onset. Does apraxia of lid opening also start with increased blink rate as in blepharospasm? In contrast to blepharospasm, patients of apraxia have very poor or even absent blink rate. As evident in this case of apraxia, we can see that the patient is not blinking at all. Does hemifacial spasm involve orbicularis of both upper and lower eyelid equally? It's a known documented fact that hemifacial spasm starts with spasm of orbicularis which later spreads to facial muscles. The orbicularis spasm is asymmetrical and the lower pretarsal orbicularis is more commonly and more severely involved as compared to the upper orbicularis, as evident very clearly in the present case. This fact has important implication when the patient is planned for Botox injection. Is it possible for hemifacial spasm not to involve orbicularis at all? Rarely, hemifacial spasm spreads in the reverse order starting from the facial muscles. This is called atypical hemifacial spasm, and the patient might present just with facial muscle involvement. Can myokymia spread to hemifacial spasm? Not only hemifacial spasm, other movement disorders like essential blepharospasm and Meigs syndrome can begin with eyelid myokymia and then later gradually spread and evolve. Is eyelid myokymia always benign? Though eyelid myokymia is mostly benign and resolves spontaneously, myokymia lasting for more than 3 months is an indication for imaging and might be an early indicator of multiple sclerosis. The present video is an illustration of how oculofacial movement disorders evolve over time from a simple ocular irritation and increased blink rate to frank blinding spasm. An attempt has been made to cover some lesser known facts which we tend to ignore whenever we come across such patients in our clinics. We hope it served the purpose and all of you enjoyed watching it. Thank you.
Thank you, Dr. Shahid. It was an absolute delight to watch your collection of videos. Dr. Prabhrisha, would you like to ask Dr. Shahid any questions?
Yes, we have 2 questions from the audience.
Yeah.
So the first one is, how do you make botulinum toxin injections less painful?
How do we make botulinum injection
less painful?
Less painful, yeah. So there are 2 things. One, you can apply ice packs, and secondly, you can apply lignocaine jelly. So though there are papers which have said that applying lignocaine jelly in some cases can decrease the effect of Botox. So we prefer applying ice packs, and if like patient is quite like particular about it, then we can give apply lignocaine jelly 10 minutes before the injection.
So the next question is indications of botulinum toxin in a case of ALO.
So apraxia of eyelid opening is actually difficult to manage, and these patients actually don't respond that favorably as compared to patients of benign essential blepharospasm. So one thing which the video didn't tell about is many of these patients that respond to anticholinergic drugs like trihexyl or GABA agonists like baclofen. So particularly patients of apraxia, and these patients are actually young. So these patients can have a neurologist's opinion and can be started on a course of these anticholinergic and GABA agonist medications. And actually, many of these patients respond very well to these medications. And then, if some residual apraxia remains, so in those patients, we can give Botox injections. And if the results are not favorable, actually, we can even try frontalis sling surgeries in these patients if it is quite debilitating.
Thank you, Dr. Alam. Over to you, Dr. Angela.
Okay. Next will be a talk, An Eye for an Eye by Miss Celia Winnie. She is an ocularist and artificial eye specialist. She has done her bachelor's degree in optometry and vision science from Pondicherry, a long-term fellowship in Next will be the talk on An Eye for an Eye by Miss Celia Winnie. She is a consultant ocularist and artificial eye specialist. She's done her bachelor's degree from Pondicherry, and she has done a long-term fellowship in comprehensive optometry from LV Prasad Eye Institute. She has also done an apprenticeship in ocularistry. She has worked as a consultant ocularist at LV Prasad Eye Institute, and she is also the General Secretary for Indian Optometrists Association, Kerala. Over to you, ma'am.
Thank you. Let me share my screen. Yeah. Hi, good morning all. I mean, good afternoon. I'm Celia Winnie. Thank you for the introduction, doctor. Let me talk about a little bit about ocular prosthesis. When we talk about oculoplasty, ocular prosthesis is a great factor and we cannot avoid that. So ocularistry, mainly we consider this field as an art and medicine. We used to use this ocularistry in oculoplasty. Mainly we do artificial eye, the ocular prosthesis, but we do also consider this ear and nose and also orbital prosthesis and fingers. We also called as anaplastologists sometimes when we specialize in those things. And ocularist means, an ocularist is a thoroughly trained professional skilled in the art of fitting and painting of fabricating custom ocular prosthesis. And when we talk about history a little bit, first, the first ocular prostheses were made by Roman and Egyptian priests as early as the 5th century BC. In those days, artificial eyes were made of painted clay attached to cloth and worn outside of the socket. It took about 20th century for the first in-socket artificial eyes to be developed. And nowadays we are using PMMA, polymethyl methacrylate. It is a high-grade acrylic plastic. And, if we talk about custom ocular prosthesis all the time, but we most of them prefer the stock eyes because of the unavailability of the custom-made ocular prosthesis. And these are ready-made and would fit patients with the best eye right out of the drawer. It is mass produced in variety of standard sizes and shapes and iris colors. Might be, you all of are using in your OPD sometimes, if the patient are very keen to wear something in the socket, we don't have any other choice if we don't have a custom ocular prosthesis in our hospital. And most of the time we are using this, and these are the two custom made and stock eyes, and this is a stock eyes. And this is this for the same patients, we made a custom-made ocular prosthesis. And always this is prepared according to the socket measurement and made up of high-grade plastic PMMA, high-quality PMMA. And this most of the time this will this will reduce discharge and discomfort for the patient. And of course, good symmetry with the other eye. And because we are painting, hand painting the iris and the sclera, everything to match the other eye. And you can see that stock eye is wearing, the same patients wearing the customized prosthesis. And we can correct this ptosis and, anophthalmic appearance, lag of thalamus. Most of the problems with the stock eyes we can correct with the custom-made ocular prosthesis. And here you can see the patient was using the stock eyes for many years, and he developed a soft tissue in the lower side, and we could do the surgery for the patient, lower fornix formation surgery, and then we fitted the artificial eye for that same patient. And you can see the cosmesis, how it is improved. And for the atrophic bulbar patient, or thusical eye with a great volume patients, we are using the scleral shell. And this will be a very thin shells we can warn over the present eye. And when we should advise an artificial eye, you know the indications. I'm just going through it. Microphthalmia patients, you can see the varies of conformers. So we start with the 2 to 3 mm button conformers till 22 mm conformer. So we gradually we are giving the conformers to enlarge the socket, and up to maybe it takes 1 year, 2 year, 3 year. Maybe with the non-surgical techniques we are following this, we will give the conformers, and we will increase the size of the conformer. And sometimes in some point we will do the customized conformers also to increase the volume of the socket. And non-surgically we can use we can make some alternatives for that if the patient is willing for that. And but in children, we mainly using this non-surgical methods, and this will achieve the result. We can in 3 years or 4 years we can have a customized ocular process with the 80% volume of the other eye. In anophthalmia cases, it can be congenital and surgical anophthalmia. In both cases, we can use this ocular prosthesis. In congenital anophthalmia, most of the time we need a conformer, placement before going for the customized ocular prosthesis, and we will again increase the conformer size in the anophthalmic socket according to the growing process. And in some patients, it will be take 1 or 2 years or 6 months. In customized ocular prosthesis will give more result. So that gives maybe in 2-3 months we will get a good volume. And thusical bulbar, always we can 99% of the cases we can go without surgery if the patient is having less pain, and it is tolerable and tenderness is very less, and the volume is sufficient, and then we can go for the prosthetic eye directly without any surgery. And these are atrophic globes, and in this cases also if we have folium, we can go directly with a custom-made ocular prosthesis, and otherwise we need a evisceration or enucleation with the implant, and then we can go ahead with the custom-made eye. And these are I'm sorry, I think the heading is some mistake. These are orbital prosthesis. In nowadays we are getting more mucormycosis patients. With the after excision, many patients are coming in these days, and we will plan for them the orbital prosthesis. We can fit this orbital prosthesis in 3 types. One is the implant, with the implant, maxillofacial implants. And then we can attach with a spectacle. This is called spectacle mounted prosthesis. And the third thing, we can use glues. Silicone glues is available, and with the glue we can attach the prosthesis in the face. And then we have a releasing agent, and patient can itself, they can do the with the releasing agent, they can take it out and then clean it, and then they can put it back. Mostly we are preferring this silicone glue, because it is cosmetically, it is more appealing, and it is for the patient, they will always choose the silicone glue, because the spectacle mounted prosthesis always have a gap in here in the temporal portion, and people can easily make out whether it is an prosthesis or original. So most of the time people will choose the silicone glue. And with a severe orbital trauma, in this case also we do accentration, and we'll go for a orbital prosthesis. And these are severely deformed socket or contracted sockets, and we get all these congenital cases we get maybe at the age of 26 or 27 with a fully contracted socket. And most of the time we will try with the non-surgical methods with the conformers, customized pressure conformers. We'll give some pressure with the midi tapes, and then we'll ask them to use for 1 or 2 months, and then we will increase the size of the conformer, and then maybe we could able to fit customized ocular prosthesis without any popping out and all. But in some cases we should depend surgical methods. So in that cases, I think already Dr. Tarjani talk about it. And then we will, after surgery, after 6 weeks, if it is DFG, maybe it will take more time. And after that, we can go for a customized ocular prosthesis. But in my experience, I would say 90% of the cases we could, patient won't be willing for the surgery, because they, at the age of 26 or 30, they need a immediate result, and they don't have any time. Or maybe they're planning to planning to marry, and that time they need a prosthesis. So at that time they won't be willing for the surgical procedure when we explain about the procedure. So 90% of the cases we tried a customized ocular prosthesis, and most of the time we could able to fit some customized ocular prosthesis. In this case also in ophthalmos, we don't have any other option. We need to do some enucleation or evisceration plus implant, and then afterwards we can plan prosthesis. And will the we all know it will move, and we get 90% of the movement in most of the cases. If it is the well placed implant, then we will get a good movement, and also for the Kozhikode eye also we will get good movement. And implants, I think she already talked about customized implant, and nowadays we also get this customized implants, and the migration of the implant also she talked about. And in my perspective as an ocularist, I would say this most of the time this migrated implant also the patient won't be willing for a surgical procedure to correct that. And in that cases also we many times we tried this pressure conformers to at least they can use that without any popping out, and maybe the movement will be less, and there will be a restricted movement to that side, but still patient would be able to do without any they can use that prosthesis without any popping out. And we in some cases we cannot avoid surgical procedures, so we should do that. And conformers, we have ready-made conformers available. After surgery also we can use this, and we also make customized conformers for the impression taking, and to use for the bilateral and ophthalmic patients, and the congenital and ophthalmic cases. We 80% of the time we customized conformers for these cases. If we want some enlargement of the socket, we do customized conformers. And fitting process, when we talk about fitting process, if we have a hands-on training, we could able to understand more thing about the fitting process. But let me be brief about it. This is the impression taking. You can see in the photo we have impression trays, ready-made impression trays for the right and left eye. There are separate impression trays in different sizes. We have it, and then we will select the impression tray according to the socket measurement, and then we will take the impression with the alginate. It's an irreversible hydrocolloid material. We will inject this with a 10 ml syringe. We will inject that alginate into the eye, into that impression tray, and then we will wait for 1 or 2 minutes, and we will get this, the exact measurement of the socket backside. And then in that same impression trays, we will convert into the wax, and then purified wax we can use inside the socket. And that, with the wax only, we are doing the fitting process, where the location of the iris and the orthophoric position, everything we will arrange in this wax model. And then in that wax model, we will convert that in the cast, and we will make a cast of that wax model. And then in this cast, we will make acrylic with this iris. We will also, at the same time, parallelly, we'll do that iris painting, and then we will attach this iris to that cast, and then we will attach to the ocular prosthesis, and then we will get a scleral base with the iris, and over this we will paint sclera, conjunctiva, everything, and with the blood vessels, everything. And then after that, over that we will make a clear acrylic coating, with the same PMMA. And then we can dispense after polishing with a thorough polishing in the back side and the front side. And I usually do this for the optometrist. So when about care and handling, all of you know, so I don't. I'm not going into that. I know how to remove and how to insert the prosthesis. We use this plungers, sometimes, but most of the time this won't work. The water will be inside, and patient won't be able to use that plunger all the time. So 80% of the time we will prefer the hand only. We will teach them how to put it inside and then take it back. And for the advice for the patient who is using customized ocular prosthesis, they can clean the prosthesis every day is ideal. In our scenario, they will go, every day they'll go out, and they're exposed to dust and all. So most of the time, we'll tell them to clean every day, and they can use mild soap like baby shampoo, and rinse thoroughly after that, and then they can put it back. And it should be professionally polished every 6 months, at least every 6 months. And if they have any problem, or they're not make it out, and then at least once in a year is a must, because we have a lot of deposits backside of the prosthesis, and also there's some scratches over the surface of the prosthesis. So we should do that periodically, then only the socket will be healthy. Otherwise the scratches can cause some minute problems in the socket. And replacement, when we should advise to replace a prosthesis, they can use the high quality PMMA. They can use it for 10 years and 5 to 10 years. There is no problem, because in every polishing we are just cleaning that prosthesis and without any deposit and all, and then they can use it for many years. But if they have any change in the appearance, or they have any recurrent infections coming on, or dryness, they feel more dryness or discomfort with the present eye, or dropping of that eye, the customized eye with that thing, if they feel some ptosis, then they can go for a change. Because most of the time when the prosthesis, the size increases, in the size of the socket is increasing, so the customized prosthesis looks small. So that time mechanical ptosis will come. So that time they can go for a change. And the popping out very frequently, the process is coming out very frequently. It is not fitting inside the socket. And if they experience these problems, then they can go for a change. Otherwise, if everything is okay, there is no need to change, every year or every 2 years. They can use if it is properly maintained and properly professionally polished at least once in a year, then they can use it for 5 to 10 years, no problem. And these are for for the parents. We usually ask this. And how long does an artificial eye last? As I told you, if you are using the good PMMA, then it will last for many years. And if they have any problem with the prosthetic eye, we discussed already. If they have that problems, they can use that. They can change that to a new one. Otherwise, they can use the same. And as Dr. Dojini told, many new technologies are coming. Nowadays we are using the digital painted iris, and also the different types of PMMA is available. The quality is changing. So if they want to experience the new technology, then they can go for a change. If they are already okay with the present prosthesis. Some people, they wanted to change because they might hear about the digital iris or any other. Maybe they want to change to a self-lubricating prosthesis and all. Then they will go for a new one. They can opt a new one. And of course, you can participate in sports activities even they wearing artificial eye. Only thing is that when they swim, they can use a goggles. Otherwise, some protective measures should be there for the other eye, the good eye. Otherwise, there is no problem with the prosthetic eye. Obviously, they can swim, and they have to use some goggles, because many people, they complained they lost eye in the water, so they should use that. And I think these are some happy patients so far. And you can see this, sometimes if we give a very good measurement and very good fitting of the eye, and still it looks big or small, after do everything, all the fittings, whatever we can. And then after that, if a patient is complaining, or if we feel it is big or small, then we can use some optical corrections over the eye. We can use plus lenses to magnify the eye, or minus lenses. And sometimes horizontally or vertically, if we feel that the fissures is narrow, and then we can use this cylindrical power also to we can give some optical illusion. At least when they wear the glasses, it looks fine. And I think I'm done with it. I think for this group of people, I think I could have done more, and maybe next time we can come up with special cases. We have some of them, and the bilateral and ophthalmy also we are working 2 or 3 parallelly. So we will come up with the good cases next time. Thank you.
Thank you, Celia Winnie, for that insightful talk. We are very fortunate to have you attached with our hospital also. We will quickly move on to the next session on trauma. Can you stop screen share? Rituja, do you have any questions for Celia?
No, I think she covered everything. If you want, we can move on. Thanks.
Okay. I thank all the speakers and discussants of the previous sessions. Celia, could you stop screen share?
Moving on to our final session, we have trauma. The discussants for this session will be Dr. Anju Chandran, consultant oculoplastic surgeon, and Dr. Sangeeta Rajagopal, consultant ophthalmologist at Comtrust Eye Hospital. Over to you, madam.
Welcoming everyone to our final session, trauma. There is not even a single day that we don't deal with trauma, either trivial or severe. It's a great pleasure for me to introduce our speaker, Dr. Raguraj Hegde, consultant in Orbit Ophthalmic Plastic Surgery and Ophthalmic Oncology Service, Department of Ophthalmology at Manipal Hospitals, Bangalore. He is the director of the Vision Mission in Singapore. Over to you, sir, to keep us enthralled with the topic, orbital fractures, basics to cutting edge.
Sorry. Good afternoon, everyone. Are you able to hear me?
Yes, we can hear you.
Yeah, I just shared my screen. Um, I would like to thank the organizers, especially Dr. Anju and all the rest for such a fantastic show. We're at the fag end of the meeting, and I hope I'm not keeping anyone from their lunch. I'll try to be as concise as possible, even though orbital fracture is a very large topic. Orbital fractures, basically 30-40% of all facial fractures involve the orbit. There is a common misconception that orbital fractures means only blowout fractures, but actually the blowout fractures are a small subset of all the orbital fractures in continuation with the other facial fractures. It's important that we do not consider the orbit as a separate entity, and we have to we have to see the facial skeleton, how it corresponds with the orbit. The orbital rim is a very important landmark. It is a frame of reference for while we are repairing orbital fractures. So the face is supported by 4 vertical buttresses and 3 horizontal buttresses. As for the practical classification of orbital fractures that we have come up with is one is the internal orbital fractures, or the popularly known as the blowout or the blow-in fractures, where only the orbital walls are involved, but the frame is not involved. The orbital zygomatic fractures, the frame is involved, and the area of impact is on the malar bone, and the nasoethmoidal orbital fractures, or the Inouye fractures, where the trauma is directed right at the central midface. So there is a fracture from within the nose towards the orbit. And then there is a complex orbital fractures where there is no discernible pattern that we see, and where the area of impact is. I will try to give a few examples as I am going along with my presentation. So the 3 important structures in the orbit are the infraorbital fissure, shown by the green arrow, the orbital strut, or the intraorbital buttress, shown by the red arrow. This is the transition point between the medial wall and the floor of the orbit, now basically that keeps the globe in position, and when it is damaged, there is usually hypoglobus, and there is a the globe is not in position, and it is once it is damaged, it is quite difficult to repair this orbital strut. The posterior ledge, shown by the blue arrow, is the palatine bone, which is the strongest bone in the orbit. This is where we place the orbital implant when there is very extensive large fractures. The titanium implant is placed on this posterior ledge to keep otherwise the repair is not done well if it's not in the posterior ledge. So here we can see that the infraorbital fissure is enlarged compared to the previous thing, and then that it shows that the area of impact is very large. And there is also possibly the fracture is not just involving the orbit, also it may be involving other parts of the face. And this is where the strut is damaged, and both the medial wall floor is also damaged along with it. So where in this case, most likely there will be a hypoglobus because there is no support for the globe. Orbital blowout fractures, there are 2 mechanisms that I've mentioned. One is the direct impact on the globe, where there is increase in intraorbital pressure and there's buckling on the floor and the medial wall. And the other mechanism is when the impact is on the rim of the inferior rim, when then there's a buckling effect on the floor of the orbit, thereby causing a fracture. There are various varieties of blowout fractures, which is the medial wall, the floor, isolated medial wall, isolated floor, and sometimes the medial wall and the floor, and sometimes involving the strut, but may or may not be. This white-eyed blowout fracture is something quite peculiar because, as you can see here, there is no obvious signs of trauma externally, but the patient has a subtle problem where whenever she's left, there is a history of trauma, of course, And since she sees on the left gazes, she's having diplopia. Even on the 9 gaze, we don't really see any restriction in the movement unless we're carefully looking for it and eliciting it. And we got a CT scan, and sure enough, there was a orbital fracture, a trapdoor kind of fracture where the orbital fat as well as the intramuscular septa was entrapped within the fracture, while the extraocular muscles was not. So, and when we took her up for surgery, we saw that there is the crack that is there, that's seen in the CT scan, and we repositioned the orbital fat back into the orbit and put like a barrier implant. This is a osteomesh. This is also a bioresorbable implant, so it absorbs within 1.5 to 2 years of time, and it completely absorbs from the orbit. This is before surgery and this is after surgery. As you can see, there's not much of a difference externally, but most importantly, she doesn't have any diplopia after the surgery, and that's the end point of the surgery. Sometimes these large extensive fractures are there where this girl fell down the stairs, and she had both medial wall floor as well as the strut was completely fractured. Because of that, she had diplopia and inophthalmos, hypoglobus, as well as pseudotosis. So we had to repair the orbit with a prefabricated titanium implant, which is done, and where you can see that the strut also is well reconstructed, and the most importantly, you can see that the titanium implant is sitting at the posterior ledge that I had spoken to a little earlier. So this is exactly sitting where it should be. And as after about 6 weeks, you can see that all her symptoms before surgery have resolved. Orbital circumferential fractures is classically known as the tripod fracture. So here, the major principles is sometimes usually 4-point fixation is advised, but sometimes the 3-point fixation is enough. Like in this case, where we fix the frontozygomatic suture, the nasal buttress, as well as the inferior orbital rim. So we can see that it is very well the thing. And if there is, and after repair, we have to see if there are any other fractures that needs to be fixed. So sometimes even after a good ZMC fracture repair, we see that there is a floor fracture defect, because even though it is well, there is loss of bone, and then there is a floor defect. So in this case, we need to put a barrier implant so that that fracture doesn't cause any entrapment of orbital tissues. So like in this case. Complex ZMC fracture, this is a complex ZMC fracture when both sides are involved. The left side is more involved than the right side. As you can see, it is completely displaced, and even the both the buttresses, the nasal as well as the pterygoid buttresses, both have been fractured. And and this is confirmed by all the sagittal, the coronal, the axial, as well as the coronal. In the coronal scan, we see that the right orbit is relatively okay. Only the left orbit is somewhat deformed. So we concentrate only on the left side. So after fixing the vertical buttresses from the oral side, we then move to the orbit side and fix all the orbital rim on 2 different positions. And we reconstruct the orbit with the prefabricated titanium implant. This is the post-operative outcome, where we see that all the fractures are well approximated, and this is about a few weeks later when this post-surgery. Nasal epidermal fractures, basically we see that this is when the central face is the point of impact. We commonly see in boxers and road traffic accidents. We see this is an example where he fell down the stairs and the railing hit his nose area. And we see that he has bilateral orbital fractures on both sides, and frontal bone fractures, including dural tear and the CSF leak. So the neurosurgeons went in first, so to repair the dural leak, and after they were done, we went on to fix the forehead and the glabellar region with a titanium mesh. And once that is done, we proceeded to fix the orbits with a prefabricated titanium implant. And the nose also was fixed with a splint, and then was on regular follow-up to make sure that the splint did not go out of place. As we see that it is the post-operative scan, we can see that it is well reconstructed, and even when we see the 3D reconstruction, we see that the nose also is quite raised compared to what it was previously. So this is 2 weeks post-surgery, and this is a photo about 1 year later, because he had traveled out by the time it was 1 year, so he had sent a photograph of his after 1 year. So you can see that his nose is quite well reconstructed by now. So the roof fractures is next. When is a little tricky to or the roof fractures, we usually do not intervene if it's a very small fracture like in this one. This was a small fracture, and we decided to do conservative management. And over time, the bone remodels, and after about 6 months, we see that the bony remodeling has occurred, and we did not need to intervene. But in some cases, we need to intervene where this is a roof fracture with a meningoencephalous seal. We had to do a craniotomy, and then along with a neurosurgeon, and then we had to repair the roof from the craniotomy incision. But what if the patient is a pediatric patient? So this is a 4-year-old child who fell from the second floor of the second floor of the of her house, and she came with rhinorrhea, which was later found to be CSF. She also had frequent headaches, and the left side of the orbit was there was a hypoglobus, and when she cried or when she was training, there was surgical. There's a orbital emphysema, especially in the periorbital area and the lacrimal sac area. But there was no restriction of eye movement. So when we did the CT scan, we saw that there's a big crack that was running right from the nose to the ethmoid bone, and to the extend to the roof and up to the frontal bone. And we can see that there is a gap between in the roof, and it is confirmed by the CT scan, the coronal and the axial cuts. We see that where that crack is running, there is a gap, but this still didn't explain all of her symptoms, especially the CSF rhinorrhea. But it became clearer once we saw that once we did the MRI, and there is a clear meningoencephalus which has got into the orbit. We can see that here, and that is the source of the CSF rhinorrhea. So so we wanted to avoid craniotomy for such a small child. I discussed this case with my colleague who's a skull-based surgeon, if we could repair it from the orbit side itself. And we decided to go ahead with the transorbital neuroendoscopic surgery. It's called TONES. It's been described in literature. So this is where we go to the orbit and fix the, we see identify the fracture, this thing, and repair the dural leak. And once the dural leak is repaired, we then fix the orbital roof. So here we did a lid crease incision, and when we reached the orbital rim, the superior orbital rim, at the moment I took a periosteal incision, there's a gush of CSF fluid that came out. Then after we controlled the CSF fluid coming out, we saw that this is the defect that is there, and that is the pulsating part of the brain with the meningeal covering, and it was also attached to the meningeal covering was attached to the orbital tissues. So we had to carefully dissect out the meninges from the orbital tissues. So we had to carefully separate it from the orbital tissues, and we see that it is separated. And once we had separated, our skull-based surgeon went in and repaired the dural leak with a dural substitute called Duragen. He used a double inlay method with Tissel glue, which is a fibrin glue. And once this is the second one going in, and once that was completely repaired, I again took over the case, and then we repaired the orbital fracture using osteomesh again, which is again a bioresorbable implant, and we tucked in the edges into the intracranial side so that it doesn't the implant doesn't fall on the orbit. So this is when we're tucking in. So once we started tucking in the implant, and this is the final position before closure. So post-operatively, we saw that there is good separation between the intracranial contents as well as the intracranial contents as well as the orbital contents, and we could even notice that there is the implant that we had placed also is visible because it is radio opaque body. So this is about 8 weeks. Her CSF rhinorrhea as well as the emphysema had completely resolved, so we did not have to worry about that. There is a mild ptosis is present, but we are hoping that it will resolve with some time. This is an old fracture. He had a road traffic accident about 6 months before, and then there was then after that he had a primary facial reconstruction elsewhere near his hometown. But when he came to me, his primary concerns was that he was having diplopia wherever he, which all gazes, and the left part of his face was deformed. So on examination, we saw that he had an obvious inophthalmos, and there was upper sulcus deformity as well as pseudotosis along with the hypoglobus. He had occasional headache, sometimes nausea, vomiting, and bradycardia in some of the times. And in CT scan, it was quite obvious why he was having, because the inferior rectus was attached. There was a floor and medial wall fracture, and the orbital rim was also fractured and unrepaired. So there was and the inferior rectus was attached to the broken bones, which is why he was having diplopia in most of the cases. But surprisingly, we also had a frontal mucosid, which is what which was occupying some of the. I think probably it was because of the initial trauma and further repair, which would have obstructed the drainage of the frontal sinus. So, so we had to do a customized implant for him because we did not want to do an osteotomy and do a repeat surgery. So we did virtual surgical planning using his CT scan. And after we did took care of this thing, we did mirroring of the orbit on the other side, and we constructed a patient-specific implant which would sit flush against the orbit. And since his posterior ledge was not there, that is where we usually keep the implant. This posterior ledge was constructed specifically for him on the lateral side of the orbit, and with and also the inferior rim was also supported with the titanium. And so after we reconstructed, using a mock implant, we just made sure that the implants was the correct size and it was accurate. And then we proceeded with surgery, where the ENT surgeon went in with the endonasal, did an endonasal endoscopic frontal sinus marsupialization. And after that, I did the orbital reconstruction using the patient-specific implant with a transconjunctival route. And the post-op scans, we can see that the orbit is well reconstructed and it is quite predictable because beforehand we had predicted which is a proper implant, and it was 3D reconstruction, so there is very less room for error. And this is the CT scan, post-operative scan, where we see it's all the orbit, including the floor as well as the medial wall, is well corrected. This is the 3D scan where you can see even the malar area is also supported with the implant. So as post-surgery, he had diplopia only in extreme upgaze, which usually is not so significant in most people. And no diplopia in all the other cases, and his hyperglobulus is gone, and he had a little bit minimum inophthalmos, but it was only elicited clinically. The patient did not feel so. In summary, facial fractures involves multidisciplinary teams, but oculoplasty surgeon is always involved whenever the orbit is involved, because there's always a role for him, because there is so many things are missed out by the other specialties. Anatomy and radiology are very important knowledge spheres for oculoplastic surgeon to in orbital fractures, and fixing orbital frame is important before we go on to fix the walls of the orbit. And orbital fracture repair is not just about fixing bones. It just one badly fixed orbit is enough to give nightmares to both the patient as well as the surgeon who has operated. Thank you very much.
Thank you, sir, for that detailed presentation. Now over to Dr. Anju to come up with questions.
Thank you, Dr. Regraj. It was indeed a basics to cutting edge with those varied presentations. Just a couple of questions, especially for people, ophthalmologists sitting in the periphery. They see orbital trauma of varying degree. So when is it that they need to advise for imaging? Which signs do they have to look out for them to advise imaging?
First thing is double vision. Double vision is the most important first sign that we see. Whenever they want to, whenever there is some degree that there's a direct impact on the eye, and the patient complains of double vision, then we have to get a CT scan done. And also, sometimes it's quite obvious that there are other fractures. So when you see that there is other facial fractures, most likely even sometimes orbit is involved, even though sometimes the orbit may be spared, even in other facial fractures. In rare cases, it may be spared, but it's always good to rule out, because anyway, they would have to get a CT scan done for the other facial fractures. Other than that, I think on case-by-case basis, if they don't see any external trauma, then they can probably skip this thing, and if the patient is not complaining of any other symptoms. Sometimes even a CT scan may not rule out a fracture, because it depends on the slices. So if the slices are 3 millimeters that is usually taken, that sometimes misses the fracture slices. So sometimes even a CT scan might show that there is no fracture, but the patient will be feeling that there's a fracture and there's an entrapment. That subtle entrapment, just by clinical sign, and some cases we have gone in, even though the CT scan is showing negative, there is no fractures. Still, there might be a small green stick fracture which is entrapping the orbital tissues.
Okay. Any specific this thing you tell the radiologist what cuts, what size cuts?
So first thing is at least a minimum 1 millimeter CT scans. Okay. Even though they may not give you all the films because of the cost, but when they're acquiring it, better to take a 1 millimeter CT scan, because it's easy to miss with 3 millimeters. And with 1 millimeters, you should get a coronal, sagittal, and an axial cuts.
Okay.
And along with that, a bone window and a soft tissue window is important. Bone windows is mainly for to see the orbital fractures, and soft tissue windows give you chance to see if there are entrapments, and if the entrapment is because of the muscle or the fat or intramuscular septum. And when there are other fractures involved, so I always get a 3D reconstruction, because you should not miss out on the other fractures if it is there. So if it is if other parts of the face are involved, I would get a CT face instead of just a CT orbit. If you're suspecting an orbital blowout fracture, just a CT orbits would be enough.
Okay. I think that pretty much answers most of our questions, though we have a lot. I know it was a very difficult task talking about orbital trauma and fractures in such a short time. Thank you for that. Now we go on to the next talk.
the grand finale, I should say. According to me, lid suturing is a skill which every ophthalmologist should possess. And to talk about it, we have one of the doyens of oculoplasty in India, Dr. Ashok Grover. I'm privileged to be introducing him today to all of you. He is currently the chairman of the ophthalmology department at Sri Gangaram Hospital, Delhi, and the chairman of Vision Eye Center, Delhi. He has done his basic ophthalmology degree from AIMS and has also MNAMS, FICO, FAICO, and FRCS in oculoplasty. He is the recipient of Padma Shri, one of the highest civilian awards for his extensive work in ophthalmology. He is currently the chairman of the subspecialty education of ICO, that is the International Council of Ophthalmology. He is the president of Ocular Trauma Society of India, and he was a past president of many prominent oculoplasty organizations. He serves on the editorial board of Asia Pacific Journal of Ophthalmology and Indian Journal of Ophthalmology, and he has received numerous prestigious awards and orations. To name a few, the Distinguished Service Award from Asia Pacific Academy of Ophthalmology, Honorary FRCS, Honorary Fellowship of FICO, and Colonel Rangachari Award for Best Paper from AIOS. Over to you, sir. He will be talking about lid tears and lid trauma and repair.
Good afternoon, everyone. Thank you, Comtrust, Kozhikode, Ophthalmic Society, and especially Dr. Anju for this opportunity to talk to you all on a very basic subject, primary repair of the eyelid and canalicular injuries. My voice and the slides, I hope, are all clear.
Yes, all clear, sir.
Thank you. So adnexal injuries constitute almost 1/3 of all the injuries that present to ophthalmologists, and road accidents and assaults are the commonest factors. Let's look at the eyelid injury management. The repair of eyelid injury needs to be carried out to restore anatomy, which restores the function, but at the same time, on the face, aesthetics is extremely important, as it has an important role in the confidence of a person and his ability to communicate. Primary repair within 24 hours is ideal, as it allows the best possible results. However, cases presenting a little late may be repaired by primary repair techniques after controlling edema or any infection. Cases that present much later need to wait till about 6 months when the tissues have become mature and less reactive. However, in some cases where there is exposure keratopathy or globe is threatened for some other reasons, we may need to repair earlier. Primary repair is the most important for prevention of deformities. You need to choose between local and general anesthesia based on the age of the patient and the complexity of the involved tissues. Associated globe repairs may require general anesthesia. A good preparation includes taking care of infection, inflammation, tetanus prophylaxis, and a good wound hygiene, including a thorough wash with betadine and removal of all foreign bodies. Wound management is something that we will take up in detail. The commonest problems that we need to tackle in eyelid trauma include the management of the eyelid lacerations, the marginal repairs, which is a very critical repair, as abnormally done or inadequately done marginal repair often leads to bad deformities with the threat to integrity of the globe. Levator identification and resuturing where required is also important. Canthal injuries often lead to extremely unsightly deformities, and primary management can prevent them. And canalicular injuries are important to prevent lifelong troublesome epiphora. Simple lacerations are these, can be easily repaired because of the rich vascular supply on face. We get extremely good results, and there is very little need to debride any tissue. Best results are obtained if we carry out a repair with a fine suture like 6/0 nylon or 6/0 proline and attempt to create a little eversion of the wound edges by the configuration of the sutures that we place. More complex lacerations like this one may require a greater skill and may require you to work like a jigsaw puzzle to make sure that you place the right edges at the right positions. At times, wide undermining is required where there is some loss of tissue, and sometimes flaps or grafts need to be used, as we'll see in some of the examples. However, if there is any contamination of the wound, you try and avoid a primary graft. Marginal repair is the most important technique. It is important to use the right sutures, right magnification, and work under the microscope illumination. The first suture for marginal repair is passed just behind the gray line in the firm tarsal tissue, like a vertical mattress suture, as you just saw. The second suture passes at the posterior margin, and this suture, vertical mattress suture, takes the first set of bites 3 millimeters from the cut edge, comes back to the same side 1 millimeter from the cut edge, and then the suture ends are tied and left long. The third suture, again as vertical mattress suture, is being passed closer to the lash line, ensuring that all parts of the margin are well opposed. The anterior most suture is left long, and the posterior two sutures are tied within it to ensure that no suture is irritating the globe. The tarsal repair is then carried out with a 6/0 vicryl partial thickness suture, which does not go up to the conjunctiva, and the skin closure is then carried out with the same 6/0 nylon or 6/0 silk suture that you are using. A good apposition at the end and a little pouting margin at the edge is important to ensure a good final result. Meticulous primary repair is extremely helpful in preventing deformities, and the results that we get are extremely good because of the rich vascular supply. This is the kind of apposition that you can get in bad-looking injuries. The levator injuries are important to identify. If you have prolapsed fat, that indicates this is the pre-aponeurotic pad of fat, and it indicates a possible levator injury. Meticulous approximation of the levator, both to the fibers on either side and to the tarsal plate, is important to get a good correction. The lid edema postoperatively does not allow an immediate correction of the ptosis, but over a few months, you can get back nearly a normal appearance if suturing is done well. The canthal tendon injuries, the lateral canthal tendon and the medial canthal tendon require a special attention. An avulsion of the lateral canthus like this is common. It is important to use firm tarsal tissue here. Take double arm bites with a proline suture 4/0 or 5/0, and then take a bite through the Wittnall's tubercle at the lateral rim. So this bite must start behind the orbital rim in the periorbita and emerge anteriorly in front of the orbital margin. A double arm suture is ideal, but if you do not have one, we use a needle like the one that you are seeing here, a good firm bite through periosteum is important. Where you do not have that, you can dissect more, create periosteal flaps to get a good apposition. In other cases, you may need to drill holes through the lateral orbital rim and pass it. At the end, it is important to recreate the lateral canthus with a good acute angulation by passing vertical mattress sutures or vertical mattress sutures through the margin. This angulation, which is an acute angled angulation, is important to retain. Medial canthal injuries are often associated with canalicular injuries and require repair and intubation. It is particularly important to identify the injuries of the posterior lacrimal crest, the posterior crus of the medial canthal tendon. If it is broken, you need to definitely put it back with Prolene sutures, besides repairing the canaliculus and the marginal defect at the canthus. You can see a Prolene suture being used for the repair of the posterior crus at the medial canthal area, and this needs to be near the posterior lacrimal crest, as we will see. For complete avulsions, you may need to use the techniques which we will talk about later. So what is the technique for medial canthal reposition? Let's look at it in detail. It is important to go through a transcaruncular incision and expose the area behind the sac, which is the posterior lacrimal crest. And it is here that you can take a bite through the periosteum there, and then take a bite through the medial canthal tendon. And when you oppose this, you can get a good deep repositioning of the medial canthus, which is important. Other cases may require an internal fixation. Particularly the bilateral cases, transnasal wiring may be a good option, where the hole is created just superior to the posterior lacrimal crest. For other cases, a low profile mini plate is preferred. After the reposition of the naso-orbitoethmoid fractures, as Raghu said, you can put in small plates, either T-shaped plates or 2 screw plates like the ones that we have shown here, which are drilled superficially to ensure that you get a good deep positioning of the medial canthus. You can see these 2 titanium hole plates. Let's look at the video of this technique. So this is an old case. So we've done a Y2B plasty, removed the redundant tissue, exposed through the same incision the area behind the posterior crest, behind the sac and the posterior crest, passed a Prolene suture through a 2-hole plate, and the other hole is used for closing with a titanium screw at the posterior lacrimal crest. A 4 to 5 millimeter suture is all that you nail is all that you will need. Now we are passing this suture through the tissue of the medial canthal tendon, and then we have got a good apposition of the medial canthus. The Y2B plasty is then being closed, but we make sure that we do it with a double arm suture so that there is not too much tension, and take a bite through the deeper tissue as well, so that this end moves down rather than this end moving up. So the medial end comes down so that you have a very deep and nice positioning. You also need to remove some of the dog's ears before carrying out a closure, as you see here. And you can get a canthus like this to improve to a position like this on the first postoperative day. So medial and lateral canthal tendons need to be taken care of for good repair. So this was a patient with a forehead laceration and medial and lateral canthal tendon avulsion. This is the post-operative appearance immediately after surgery, and you can restore back the anatomy rather well. So an early, meticulous primary restoration of anatomy is the key to success in eyelid trauma. Another example of a medial canthal avulsion, which has been placed back and gives a good reconstruction. For the loss of skin, we have used an advancement skin flap, and we are able to get a good medial canthal apposition and a good skin closure. I'll touch upon the canalicular injuries as well, which again need to be carried out early, and where referral to an oculoplastic surgeon is not immediately possible, it's better for the general ophthalmologist to repair them if a referral will mean a delay. So let's look at the canalicular lacerations. They may occur either as direct trauma due to penetrating injuries caused by, among other things, blouse hooks, which is a peculiar cause in our country while feeding the infant, and the indirect ones, which are usually due to assault or a finger poke or a road accident. Most of the injuries are indirect, or 84% of them. Only 1/6 are direct penetrating injuries. Young adults are the most commonly injured, somewhere in the age group of 21 to 30, and males are more often affected. The activities like fishing are again important in causing these injuries, dog bites, and other predisposing factors. The injuries, if they are obvious, they are easy to identify and carry out a repair. However, this may sometimes be occult and opposed back again, as happened with a blouse hook injury or with a small trivial trauma. Now here it is important to pass a probe, have a high index of suspicion, so that an injury like this is not missed out. If you don't treat the canalicular injuries, you risk persistent lifelong epiphora, which can be extremely troublesome, and an abnormal appearance of the medial canthus can again be quite a drastic cosmetic problem. Lower lid is much more commonly involved, but 20% have both upper and lower injuries. Although 80% of the drainage takes place through the lower canaliculus, the consensus is that the upper canaliculus must also be always repaired. Ideal desirable time is not to do it immediately in emergency, but wait for your normal operation theater things to be available, which is the ideal time of 24 to 48 hours. But within first 5 days, chances of success are very good. How do you carry it out? You must identify the cut ends, approximate the cut ends, carry out a stenting to retain the patency of the canaliculus, and make sure that you retain this stent for an adequate period of time, which is usually 6 weeks now. Again, general anesthesia used to be the one advocated so that the tissue edema caused by local anesthesia does not make the identification difficult. But as the techniques have improved and visualization with microscope has become available, local anesthesia has become the procedure of choice. Identification of the lateral cut end is easy as you pass your probe through the punctum. It reaches at the lateral cut end. It's the medial cut end which can be difficult, especially if the injury is relatively medial. But good illumination and high magnification of microscope allows the shiny white cuff of rolled out cut edges, which are quite clearly visible, and canaliculus is a wider structure than most of us think, and it's quite easy to identify. It can be aided by passing a probe with normal anatomical orientation, placing the lid in normal orientation, and where it reaches the medial cut end, you can often locate the medial cut end. However, the method that I find most useful is the Morrison's method, wherein we put a pool of fluid or saline in this area, inject the air from the opposite punctum with a large syringe, like a 10 or a 20 cc syringe. Block the area of the sac with your finger, put a little pressure on the sac region and inject. You will see the air bubble emerge from the medial cut end. If you're not immediately able to see the source of that air coming, pass a fine suture like a 6-0 or 8-0 suture anterior to the area where you're seeing the air bubble emerge. And you will invariably be able to see the source when you lift that up with the traction suture. So this is the method that helps me locate most of the time. Other methods like using a dye or milk or a fluorescent dye or even a trypan blue can all be helpful. Pigtail probes are a useful method in expert hands, those who become used to it, which is passed from the opposite side and brought out through the cut end, but are not as commonly used as they used to be. Self-retaining mini Monaca silicone stent is the most commonly used stent, although several surgeons prefer the bicanalicular intubation. And for those where incidentally you may be in a periphery where a mini Monaca stent is not available, you can use a 22 gauge intracath, which is a Teflon material. So stenting is most often monocanalicular, and pericanalicular suturing is important. It is important not to try and go through the walls of the canaliculus, but just apposition of pericanaliculus area with 2 or 3 sutures works very well. And one-stitch canalicular and anastomotic techniques have been shown by several authors to be giving good results, and the repair can be carried out in a short period. So let's see the technique using an intracath, which is what you may need to use when you do not have a mini Monaca stent. So if you give a small snip through the punctum, you are able to introduce your mini Monaca or your intracath stent. We are using the needle as the stent, as the support, and we can then pass pericanalicular sutures using 8-0 vicryl. 2 or 3 pericanalicular sutures, one superior to the canaliculus, one inferior, and one along the line of the cut are usually adequate. And then you can carry out a marginal repair using your 6-0 silk or 6-0 nylon by the method that we had earlier discussed. What you need to do when you are using an intracath is to remove the sharp needle part of it so that it can work as a blunt stent. So mini Monaca is the most commonly used material and allows a self-retention and therefore is a very useful tool. So here we are passing a mini Monaca. If you have a wide separation here, it is best to take out the mini Monaca stent here and then reintroduce it medially from the medial cut end, which makes it much easier. So here, since these are very closely opposed, we are passing it in one go. What is most important is to see how the stent works as a self-retaining thing. So you see this knob, which is then introduced through the punctum to make it self-retaining, which gives this. So let's look at another example of identification of the medial cut end in another canalicular injury, passing the probe, and then we see that it passes through the medial cut end very easily right up to the bone, which is a good indication that you are going through the right position. So as I said, if you're using an intracath, this is a 22 gauge intracath, make sure that you remove the sharp needle part of it for it to act as a support. And then pass it through the medial cut end right up to the bony feel. Then you can pass your pericanalicular sutures. Since this was a little old wound, about 5 days early injury, we are making the edges raw, and then we are carrying out suturing with 809 vicryl superior to the canaliculus through the pericanalicular tissue, one along the margin through the deeper tissues, and one inferiorly, and then a marginal repair can be carried out. So this is a technique which works well for these cases. This is an occult tear where you can easily carry out the repair and get excellent results. Success rates are very high, as shown in various series, including our own series. Complications like stent extrusion or cheese wiring, which particularly occurs with bicanalicular intubation, granuloma formation, hematomas, or infection are quite infrequent if adequate precautions are taken. Thank you very much. I hope that covers the subject. I'll be happy to take any questions.
Thank you so much, Dr. Grover, sir. Every time I listen to you, I have something new to learn from your presentation. Years of experience indeed, and very, very well done cases. We already have a question, but I think you've answered it. Are these lid avulsions best done under GA or LA?
Most of the times we are able to do it under local anesthesia. Maybe a little sedation in the anxious patients, and in the younger patients, general anesthesia, of course. If younger than 15, 16 years of age, general anesthesia would be necessary.
It's very interesting to note in this part at least in this part of Kerala, what we face is something called a cradle hook injury. So usually it is the elder child who comes with a torn lid and a canalicular tear, because they, I think, very interestingly look at the younger child lying in the cradle, and that's how they end up in our emergency OPD most of the times. So in a bicanalicular tear, how, if we are unable to visualize the medial end of the canaliculus, then what are the tips? Or in some instances, we are able to visualize only one of the cut ends. So in that case, do we just do that, or do we have some other tip by which we can find the second cut end?
If it is the inferior one that has been done, then maybe we can just carry on with the single repair. But if you've not been able to locate the medial one, then of course you must take measures. So what you can try again is a little injection in the sac of a dye and try and press it and try and see where it emerges. That sometimes you can inject the dye in the location of the sac and make it full, or you can even put something like Helon in the sac and then try and press and see where it emerges from. That can be helpful if you do not have access to the other punctum like a Morrison's method.
Okay. And cases like where you have a lid margin tear. When I mean lid margin tear, that is almost most of the lashes are avulsed with a very small part of the tarsus being involved. In such conditions, how do you go about with the repair?
Will you please explain again?
That is, we don't have a full thickness lid tear as such, but instead the horizontal part, that is the part involving the lashes, are avulsed, and there's a minimal tear of the tarsus. So how do we approximate?
In that case, it's in fact a little easier. First, make sure that you have reopposed the tarsus in position, which is by putting partial thickness 6/0 or 5/0 nylon or chromic catgut sutures to oppose the skeletal structure, and then carry out an apposition of the margin where the lashes have been cut through by using a 6/0 or even an 8/0 suture of nylon. Because if it is only the anterior lamina that has been cut, place a suture like the anterior suture we placed along the lash line, and you will be able to get a very good apposition with a 80 or a 60 suture in the lash line, making sure that you have aligned them well. What sometimes happens is that you do not get a good apposition, and that leaves behind a little irregularity. So even in brow, that is a frequent problem, that we get a brow deformity because of the fact that brow was not opposed at the time of primary repair. So just make sure that anatomically you make sure that the lash direction is right when you are placing your sutures through the skin lamina close to eyelashes, or pass a marginal suture close to the lash line as we did in the marginal repair.
Okay, thank you, sir. We have a question from Dr. Reguraj. How do we repair a canalicular tear where the puncta is involved?
That makes things a little more difficult. But what you do is you use a Mini-Monaca stent and do a little repair after you place the Mini-Monaca stent by placing a suture of 80 nylon to the Mini-Monaca stent and to the intact part of the margin. And the region where the punctum is slit, you put in additional sutures either with Vicryl or with nylon. So repair the punctum as well. Make sure that you retain your Mini-Monaca stent by giving additional suture.
In such instances, do you leave the stent for a longer period?
No. The principle of retaining stents only for a period of 6 weeks is more than adequate to have a good cannulation. Hope, Raghu, that answers the question.
Dr. Vijayalakshmi, any questions? Madam, you're muted. Yeah. It's yeah, louder, please.
So thank you, sir, for that wonderful talk. Really,
how are you?
Yeah, especially for our PGs, it was really useful, sir.
Thank you, Dr. Vijayalakshmi.
When leading with lid tear trauma, when there comes a really perfect what to do next. Anyway, this will be really an enlightening one. Thank you once again, sir.
Thank you,
from
Dr.
the Comtrust
Vijayalakshmi.
family, sir.
So with that, we come to the end of today's session. We have our organizing chairman also, Dr. Prakash, with us now. So would you like to add something?
Yeah, nothing. It was a fantastic CME, Anju, and congrats to you for conducting such a wonderful CME. And it's our great privilege to have Grover sir to explain us on such basic topics like lid tear. It was fantastically explained, and I think our PGs will benefit a lot. Not only PGs, many of our consultants also will benefit a lot, sir. It was thanks a lot to you, sir, for taking your time off and explaining to us in such a detail.
My privilege to be a part of this CME.
Yes. And thanks to all panelists, Dr. Reguraj, Dr. Marian Pauly, Dr. Prabhisha, all panelists for participating in this fantastic CME. Thank you all.
Thank you. Thank you so much.
Thank you.
Comtrust friends, please stay back.
Yeah. IT team, I think we can stop the recording.